Oh, you guys are. Oh, all right. We are live. All right, you guys. Thank you so much. I can already see several people in the comments that have joined us. My name is Michelle Hearn. I'm a registered and licensed dietitian, and I'm the head dietitian of the American Diabetes Society. Joining me is Dr. Tony Hampton. And you guys, we are going to have an expert every single hour. Every single hour, we're switching. Dr. Barry will actually be on next hour. So, thank you so much, like I said, again, for joining us. We've got a QR code up above that you guys can scan to donate. Our goal is to raise $25,000 just to continue this work and advocacy. But yeah, how we're going to get started. And please, if you have any questions, ask. We want to make this as interactive as possible. But we're just going to tell you guys a little bit about the American Diabetes Society, what it is, who we are, why we're different than the American Diabetes Association. And then Dr. Hampton and I are going to share just some incredible patient success stories. You guys, nutrition is so powerful when it comes to reversing type 2 diabetes. So Dr. Hampton, take it away.
Well, I'll let everybody know, hey, I'm here as a metabolic health doc. I love everything that we're trying to achieve with the American Diabetes Society, because in this clinic where I exist, I absolutely see people getting off medication. So, and I just want that for everybody in the world. There are so many people who don't hear this message. And although I think there's great work being done by the American Diabetes Association, what we're trying to do is shift the focus towards nutrition. We believe that the biggest driver of reversal is what you put on your plate. So we want people to know that. They don't always hear that in a conventional medical practice. And it's not that the doctors don't believe that that's important. They just haven't been trained to make that the primary starting point. They tend to focus on medication. So we really want to put the message out there that this is how you heal. And I've seen it happen in my family. I've seen it happen in my practice. But I'm a YouTuber. I'm a guy who with Advocate Health on the South Side of Chicago. I do obesity medicine. I just finished my obesity medicine clinic just literally moments ago. And I also got some additional training in nutrition. So I have a master's in nutrition just to kind of compete with Michelle a little bit, because I want to know everything. So I got a little master's in nutrition so I can understand the biochemistry and review it, so that when I'm making videos and when I'm talking to patients and at conferences, I'll be going the Symposium for Metabolic Health literally tomorrow to be there to speak about obesity. So you just have to, have passion about this, because you see people heal. And I want everybody here to understand the work we're going to be doing. So again, if you have not heard of this society before, in order to make things go, we need to get people to help out. So that's why we're here today. So Michelle, what would you say is some of the talking points that people should know about the society?
Yeah, and really quick, I just saw one comment pop up from Ken Burks. Ken, you asked, I have had type 2 diabetes for 25 years. Like, is it too late for me? And it is absolutely not too late for you to make some major health improvements. And Dr. Hampton and I are going to share some stories of people who, I imagine Dr. Hampton I'm going to share a story of someone who has been diabetic had type 2 diabetes since 1994, so over 30 years. But yeah, so the main talking points, like, once again, who are we? Why is this different? You guys, our slogan, our desire, what we're trying to communicate, you deserve a normal A1C. We don't want to be managing your type 2 diabetes. I'm very fortunate. I'm the youngest of 4 sisters. And so I get to spend quite a bit of time, especially with my 2 older sisters. My second oldest sister is a surgeon. So I was in Houston with her chatting, and she was like, Shelly, you wouldn't believe how many doctors still think that type 2 diabetes is a chronic progressive disease, meaning it only gets worse. You cannot improve it with nutrition. You put people on medication and we kind of manage it, but ultimately knowing they're going to get worse. And what we know, and what Dr. Hampton and I have seen, is incredible, powerful changes when you utilize therapeutic carbohydrate restriction. And so that is our goal in our advocacy, because we have the evidence. This isn't just anecdotal, you guys. We have tons of clinical studies, and you're going to see Dr. Eric Westman on here later, who's published, I want to say over 50 papers on how you reverse type 2 diabetes using therapeutic carbohydrate restriction. And so that's one of our big talking points, saying that, like, we're certainly not anti-medication, but we want nutrition to be one of the main talking points of the conversation. Because from the patients that I'm seeing, Dr. Hampton, I'll let you speak on this as well. Often they'll come in and say, like, you know, a doctor or dietitian didn't really talk to me about nutrition. They might have said something kind of arbitrary, like eat healthier or eat brown rice instead of white rice, but they didn't really talk about lowering insulin, getting rid of carbs, you know, using protein and animal fat as their main sources of nutrition. So not only, you know, do we want that to be the main talking point, we want to provide recipes. We want people to be able to have an easy to understand recipe guide. And like the Academy, maybe we shouldn't be talking about the association. We're not going to have lots of sugar and other things in our recipes. That's very silly. And we also want to have resources for providers. You guys, how great would it be if every time somebody with type 2 diabetes went into their doctor, they came out with a handout? This is what we do with Dr. Mariella Glant. I work with Dr. Glant. You're going to see her later today. They get a 2-page handout. Eat this, don't eat this. We're not trying to stress people out, do macros. It's like avoiding the starch, that's right, protein, fat, and if you want to, some low starchy vegetables. So
yeah,
that's the goal. That's the advocacy, but that takes financial resources. All of us, myself, Dr. Hampton, you know, Dr. Berry, Ben Bickman, we are all volunteering right now because we believe in this so much. And we do not have the backing of Eli Lilly or Pfizer or the Sugar Research Foundation. We're never taking any of those donations, because when you do, and they will give you lots of money, then you obviously have to play by their rules, which may be less than ideal when it comes to human health.
Yeah, and I think the boldness of saying we're going to be grassroots, I think we should do that not just in what the work we're doing. We should do it in politics. I mean, just imagine if we use our resources to support things we believe in, and I think if we do that, then you'll know that we're serving you. A politician who does that is going to serve you. So I just think that approach is the most logical. And I want to say that a lot of the other organizations, and we don't have to name them, they're not independent from big pharma and big food. They get a lot of their funding from those sources, and it's just impossible to get a big check and then expect to not serve their needs. So one of the things that we thought was important was to be in a position to be independent, and also that'll give us an opportunity to advocate for things that we know work. We know nutrition works. That's why we have, you know, half the board is like nutrition professionals, right? We know that works, and there's nothing that's going to keep us from doing that. So I really think that, in fact, if anybody makes a donation, do me a favor and put it in the chat. Just say, hey, I just donated, or, you know, just so we can shout you out periodically. Another thing I want to do with this time, before we look at some more questions, is just talk a little bit about what happens in the place I sit here, which is my clinic. And I've seen amazing transformations. Now, before I started my journey as a low-carb doctor, probably 13 years ago, and now I'm more in the carnivore world now, nobody got off medicines. I probably have one or two people in maybe 14 years of clinical practice who got off of medicine, one or two people. This past week and last week, I took about 4 people off medicines in 2 weeks. So I went from, think about the difference, and this is transformational. And the one person, there's a couple of people I can think of, but in fact, if you want to hear the full story, I did an interview with a Gwendolyn Butler. And so if you search Dr. Tony Hampton and Gwendolyn Butler on YouTube, you'll see that interview. And she was amazing. She's actually a nurse, actually a medical assistant. And she came to me having been diabetic type 2 for about 12 years, 11 or 12 years. Had been on insulin most of that time. And so when she saw me, she just thought being on insulin was her destiny. She thought that was just going to be her story. Lo and behold, we get her on a low carb diet. Didn't go crazy to carnivore. We just went to low carb, and we were able to, within 45 days, having been on insulin for 11 years and being told she'd never get off, she got off insulin in 45 days. And it really, and so the question is, what allowed her to do the low carb diet and others don't? And I think the thing that did it for her is that in her work environment, she bumped her head. And this is after she met with me. And when she bumped her head, she had to go in and get an MRI. And guess what the MRI showed for this person who was, I think she was barely 50. It showed that she had microvascular disease.
Oh, wow.
And because because she's in a healthcare environment, she already knew that meant, okay, now my risk for dementia is higher. Now my risk for a stroke is higher. So in that moment, she was inspired to make a big change, and that changed her life. So, and since then, I can't remember what her A1C was. I think it was in the 9 range, and it went down to like 6 in no time, and it went down to normal. And again, we're all about normal in this organization. We're trying to 5.6 or lower. Not, I don't care if you're
not 7.
Because if you're thinking about it, if you're at the American Diabetes Association would say a 7 is okay, right? But if you think about what a 7 A1C means, that means your blood sugar average is 150. But the normal blood sugar should be, somewhere between 70 and 100. So if you are in an abnormal range for a long time, it may take you longer to get all the complications. And you can start with your head. You're talking about type 3 diabetes, which is dementia. We're talking about a stroke. The number one cause of blindness, diabetes. You get down to your heart, high risk for heart disease because the blood vessels in your heart are affected. Number one cause of kidney failures, diabetes. Number one cause of amputation, diabetes. A high risk for erectile dysfunction for our guys, diabetes. So it's all blood vessels. It's all the same disease. So if you get that A1C to normal, things get better. Now that's a type 2 example. Imagine a person comes to you with type 1. Now my wife has type 1. So this is a story she resonates with. But I had another gentleman, Otis, who I was able to see. We didn't know he was type 1 at first, but we found out. And so for everybody checking us out, always get a fasting insulin. Always do it. If you're not sure about type 1, type 2, get a C-peptide, get some antibodies to your islet cells, because you need to know if it's type 1 or type 2. Either way, he was an engineer, and you don't have to be an engineer to do this. So he was very focused, and he was very motivated, and he was able to get his A1C from maybe 8 or 9 range into the 5.6 range just by being focused on reducing the starch and sugar. So whether you're type 1 or type 2, it's really important that you understand that this is the same diet that you should work towards. So I really believe that those 2 examples are just scratching it. We can talk all day about examples. And because we have so many, at the end of the day, we need more metabolically trained doctors like ourselves, and nurses and nutrition professionals and pharmacists like my wife, who understand it's reversible. And with that in mind, I think we'll do much better. So you have also some stories to share, Michelle. What's on your brain?
Yes, I have some incredible stories. And so, like Dr. Hampton, Dr. Mariela Glant is an endocrinologist and working specifically with a lot of Medicaid patients. So a lot of people, one of her areas is in the Bronx in New York. And so the program that she does, and this is what would be kind of hopefully the future of healthcare, is basically gone to the insurance and said, like, hey, look, you're spending a lot of money. I mean, that's another reason, you guys, that type 2 diabetes is the second most profitable disease for big pharma. The only more profitable disease is cancer due to chemotherapy and radiation. But think about it, when you have type 2 diabetes, or if you know somebody who has type 2 diabetes, like Dr. Hampton was saying, it's not just like, oh, I don't feel very good. It's, you end up having kidney failure, you have heart failure, you can potentially have issues with Alzheimer's or dementia. You don't heal from infections very well. Often people have dental issues, rotting teeth. It's not pretty. So anyway, going to insurance and saying, like, we can save you money. You are spending a lot on these medical complications. And so what she does is she takes patients off medication. I had a patient, Dr. Hampton, probably the most profound person. She was on 200 units of insulin a day. Wow. This person is 36 years old. And even with 200 units of insulin, could not get her blood sugar under 300. That is how profoundly insulin resistant this human is. If anybody in here is on insulin or knows somebody on insulin, that is an astronomical amount of insulin.
It is.
And she was in a situation where her sister was killed tragically. So she had taken custody of her niece, and she's working 2 jobs. And she just, was eating her cultural diet, very high starch, plantains, beans, rice, sugar, did a lot of stress eating, was obese. And when the first time we met, she told me, yeah, the doctor told me I'm going to be blind by the time I'm 40. Like, just be ready. She's like, I already have started working on how am I going to file for disability? Who's going to take care of my niece? And nobody had ever told her the power of a low carbohydrate diet. Once again, people had said this arbitrary advice, eat some whole grains, eat healthier. You guys, type 2 diabetes is a disease of carbohydrate toxicity. Your body cannot handle anymore. There's no more room at the end. I like to use the analogy of like a hoarder's house. Like there's stuff everywhere. Like you can't put anything else in. What should you do in that situation? You want to take stuff out. If you've ever seen that movie, it's like also like a full glass of water. Anytime you pour in more water, you're going to have spilling over. You're going to have more inflammation. And so she was shocked because once again, her entire diet, and I don't know if you see this too, Dr. Hampton, do you see people with very low levels of blood urea nitrogen, BUN as well?
Yeah, absolutely.
Okay, and so what that means, you guys, BUN, often when I see a very low blood urea nitrogen, people are not eating very much protein because that's a breakdown of protein. So I have someone eating almost no protein, eating an astronomical amount of carbohydrates and starches. And, and there's a lot of lifestyle factors that go into that too. They're very stressed. They don't sleep very well. There's all kinds of different things that, sometimes they're smoking. Sometimes there's other things happening. But this particular individual, and, we'll call her Mrs. Smith. So once again, Mrs. Smith, 36, 5'3", 300 plus pounds. Within, she took a little bit longer, but within 5 months, within a month and a half, we had reduced the insulin from 200 units to under 100. And then within 5 months, her A1C went from 12.1 all the way down to 6.7, which once again is still technically type 2 diabetic. And then in another month and a half, her current A1C is 5.8. And so she was just like, I'm not quite there. But that's an incredible. I have no doubt that the next time we check her A1C, it will be under 5.8. And is it hard? For her, it was very hard initially because that was so much of what we eat is habit, but she kept telling me like, I know if I can just keep eating that protein. She's like, people at my work offer me cake and I say, nope. And she's like, I keep cans of tuna, I keep cans of chicken. And this is someone doing this on a very low income. And so she showed, it was very humbling to me to see that people like this, it's possible. But she said the first time she saw her blood sugar under 200, she's like, I had to call my boyfriend. And I was like, something's wrong with these test strips. We're going to go to Walgreens. She's like, so we go to Walgreens, we buy more test strips. We try it again. And we're like, something wrong with everybody's test strips. And then she started crying. She's like, oh my God, it's right. I'm healing. And so it's very, and I don't know if your patients experience this too, but within the joy, there's some anger there.
And I think that's a good point. Like most people are crying in the office because they're getting bad news, or they're crying because they're disappointed that they have to add to the prescription list, right? Mm-hmm. Well, patients in our environment, they cry because they're celebrating. And it's so funny because they're celebrating and they look at you. Even when Gwendolyn Butler, she said, I'm her angel. And I'm like, well, I'm not living a perfect life. So that's qualified for that. Shout out to all the angels in the world. But what I think she was conveying is that you kind of inspired me. But ultimately, I have a similar conversation with a lot of people. So ultimately, when we pass that, we're going to pass a baton to our colleagues at the end of this hour, Dr. Kim Berry, for example, right? And when we pass that baton, we expect him to take that baton and run with it, right? So when I'm in this clinic, right, I'm passing batons. And my goal is to have somebody in front of me who I have inspired, but who will take that baton and run. And when you run with that baton, it's actually you that's making the change. And we're just here to kind of give you information you hadn't heard before. And hopefully we'll live in a world where that changes, where we have metabolically trained doctors like myself and nutrition professionals like Michelle Hearn. Shout out to Michelle for writing a kid's book. What's the title of that book, Michelle?
The Fox Family Food Fight. It's
Fox
on
Family Food Fight. We love food fights. So if you have young people in your life, make sure you go to Amazon and check that out. But I do want to keep it simple in terms of, what's the magic of what we do? So we have this great website, the American Diabetes Society, that will help guide you, right? And I want you to take advantage of that. But a metabolic health doc is not doing anything magical. This is not Harry Potter. We're just telling people, when Dr. Eric Westman, I remember when I was getting into this space, and I respect him so much, he's kind of a mentor to me, and I like him because he's evidence-based. And he's like, listen, we're just getting your carbs to less than 20 a day. That's it. In fact, I'll tell people, if you really want to be successful, make sure it's total, not net carbs. So if you're hearing this for the first time, if you get your carbs somewhere between 20 and 30 total a day, not net, you don't subtract the fiber and the sugar alcohols. And when you do that, you avoid a lot of those keto products, which are okay periodically, but that should not be the foundation. Your foundation of your diet should always be real whole foods. I'd say your success rate is going to be in a 95 to 100% range, in terms of if you can keep it there and be consistent. Some people do less than 50 carbs, but then there's about a 70 to 80% success rate. And then I also tell my patients in this magical clinic, it's all about animal protein. I always tell them lions and tigers don't get fat. So if you eat like a lion or a tiger, now Tony the Tiger, they called me that when I was younger, right? Well, Tony if he's frosted flakes, he's gonna have a problem. Bears eat salmon. Winnie the Pooh, if you do the Winnie the Pooh aversion, you're gonna have problems. But if you eat like a lion or a tiger, you're not gonna be fat, and you're probably not gonna have diabetes. So animal protein, like a lion or tiger, non-starchy vegetables. It's really that simple. And what most nutrition professionals will tell you, Michelle Hurd won't tell you this. They'll say, eat all the fruits you want because fruit is natural sugar. We've learned in our world that the sugar is going to be recognized by your body as sugar, no matter if it's from fruit or not. So can you eat berries and fruit with low glycemic index periodically? Absolutely. But we find that for most people, it's animal protein, non-starchy vegetables. If you have an indulgence, you probably want to lean towards berries. And literally, that's it. Like, there's no magic to this. There's no I need I need the berberine supplement and all that. No, those things are fine. They do work like metformin, and that helps. But what I'm saying is, it's all about what you put in your mouth. And if you do a good job with that, you're going to do really well. So I just want to really emphasize how important that is. And then I think maybe, Michelle, I did see a question.
We've had, I saw a couple, and I want to shout out, we appreciate everybody. I see some donations coming in. I'll try to make sure and go back and shout out your name. Thank you, you guys. We do have a QR code. So, even if you're like, $5, $10, that means a lot to us, getting the word out. If you do have a question, please feel free to talk to, are either you taking new patients from Connecticut? I don't know about your practice. I'm all virtual. So feel free to hit me up on my website, thedigestiondilemma.net, if that interests you. I want to share a patient success story, and then I'd like to share, and I'm sure Dr. Hampton can elaborate on this a little bit. A lot of people that I see initially are very afraid of steak and ground beef and butter because that's high in fat. And we've just been told for so long that fat is bad. People throw out egg yolks. I know I used to do that when I was a young human. But real quick, just one, I had a gentleman whose A1C was 10. And, that was his first time getting his A1C checked, and it really scared him. And, once again, gave him that 2-page handout, like Dr. Hampton was saying. And once again, it's not magical. He basically just said, I'm just going to buy the meat that I can afford. Whatever's on sale at the store, I'm going to buy the meat. He ate basically, it was either beef or chicken, whatever was on sale. He ate a bunch of avocados, and he also cooked, I think, with coconut oil and butter. And in 71 days, so less than 3 months, his A1C went from 10 to 5.4. So just, once again, completely reversed his type 2 diabetes. And I know we have somebody on here that said, hey, I've had diabetes for 25 years. I had a patient who had diabetes for 30 years. And so, there's always hope and healing. And that's one thing I tell everybody I work with is the human body and brain, our ability to heal is like beyond what the medical system has allowed you to believe. But, it's usually like, take more medication. Yeah, you're going to feel worse. Sorry, this stinks. But the body wants to heal. We just have to put in the correct nutrition, and we have to stop putting in things that cause harm. Right. And so real briefly, talking about, I'm certainly not a cardiologist. I'm not an MD like Dr. Hampton. But what we understand is that we cannot look at cholesterol, specifically LDL, in a vacuum. That has caused so much misinformation. And honestly, I believe that's caused a lot of people to be sick, to avoid meat and to avoid butter. But guys, what happens if you eat a very low-fat diet? And my overwhelming dietitian experience if you avoid fat, you tend to really go heavy on the carbs or on the sugar. In the 90s, everything was low fat, but what did they replace it with, right? I don't know if you guys remember like Slim Fast and Snack Walls, like, oh, it's just these little carb sugar bombs.
Yeah.
And our rates of obesity just continue to increase. And if you look at like how different foods impact your blood sugar, you know, protein is very level, fat is almost negligible, and carbohydrates is like a mountain. So, you know, LDL has a lot of important functions in the body. You know, cholesterol has a ton of important functions in the body. It's important in your immune system. It's important for hormones. We actually have very good data that the higher your LDL is, especially as you age, you have less risk for infection, less risk for cognitive decline. Well, why is your cardiologist freaking out when your LDL is high? Well, what happened is they used to look, you know, especially in the 70s. I mean, there's a bunch of studies. We could probably talk for hours and hours on this. But if you look at like a clogged artery, if you look at plaque, you actually will see LDL in there. And so what happened is people were like, oh my gosh, LDL's clogging arteries. They freaked out. Well, what the question should have been is why? Right. Why are we finding LDL? Because LDL is free flowing through artery. You'll see like the Inuit Eskimos have LDL of 400 and they have no heart disease. The number one cause, well, first of all, for LDL to get stuck in your artery, you have to have some inflammation.
That's right.
What do you guys think is causing inflammation? High blood sugar over time is the number one cause. And so if you have elevated A1C, if you are pre-diabetic or have type 2 diabetes, in my opinion, we shouldn't prioritize getting LDL down. We need to prioritize getting your blood glucose down and getting insulin lower.
Yeah, that's a great example. And one of my favorite shows was Smart. Well, I like dogs too. One of my favorite.
We're doing it live, guys.
Smarter than a fifth grader, right? So I always try to explain things like a fifth grader would understand it. So whenever I'm in clinic, I always use the LDL cholesterol as the I have a brick Georgian type house, so it has to be tuck pointed periodically. So the mortar to tuck point my house is the LDL cholesterol. And when the cholesterol falls to the ground, I don't want to hit my grass. So the good cholesterol, the HDL, takes it away from the house. So that's kind of how I visualize it. And the question is, if my house is not a brick house, but it looks like a stucco house all of a sudden, why would my LDL go crazy and clog up the surface of my house as it would do in your arteries, right? And the answer is, as Michelle has suggested, inflammation. So if there's a party in my house that shouldn't be happening, too much going on, a lot of sugar being consumed, then my LDL cholesterol is going to go crazy. And so if I'm looking down from space and I see fire trucks going to my house to put out the fire, and then I realize it, so I'm going to assume as an alien that the problem was the LDL, when the LDL is actually there to do repair work and to help me heal. So what we have to do is in our medical community is to train the doctors that no, it's not the LDL. It's like Michelle said, why did I have a fire? Why am I having to stucco a brick house? And if we fix that problem, then the LDL numbers settle down. Everybody's happy. We just tuck point the house and we don't turn a brick house to a stucco house. And again, Michelle has suggested that there are a lot of things that we need cholesterol. As a man, I want cholesterol because I need to make sure I make testosterone. Mm-hmm. And guess what? Women need to make estrogen and they got testosterone too. So cholesterol, if you just Google that, you'll find that that all the hormones, most of the hormones actually start with cholesterol. So a lot of times you'll see somebody that's vegan whose levels are going to go down because they're not converting like they should. And I particularly like fat because fat is if you look at any graph, you'll notice that the fat is the one thing that doesn't raise your blood sugar much. Mm-hmm. And if you don't raise your blood sugar, you won't raise your insulin. And if you have a hyperinsulin state, going back to your brain, your eyes, your kidneys, all the things that diabetes can hurt, if you lower your insulin, you won't have all of the consequences of a high insulin. And truth be told, if you haven't heard this, people with type 2 diabetes actually have a high insulin state. They have plenty of insulin, it's just not working very well. And when you're in a hyperinsulin state, not only are you going to tire your pancreas out after a while and convert potentially from a type 2 to a type 1 where you have to take insulin, but that high insulin state is going to cause all your blood vessels in your body to constrict. It's going to cause you to hold on to salt. So we tell people with blood pressure to restrict salt, but if you have a hyperinsulin state, you're still going to absorb salt. Oh, by the way, you're going to have all this inflammation. And what we do in the medical community is we'll say, okay, well, we want to reduce the sugar so that we won't have hyperinsulin. So we'll just give you a medicine like Jardiance to make you urinate out the sugar. Now, does that make any sense to have to pee out a lot of sugar in your kidneys? Is that a good idea? Probably not. Oh, by the way, don't worry about the inflammation. We'll just give you a statin. Oh, by the way, don't worry about the calcium coming in that causes constriction. We'll just give you a calcium channel blocker. Oh, don't worry about the constriction. We'll give you a nitroglycerin tablet. So we have pills for everything. But if you just fix one thing, that high insulin state, then you don't have the downstream consequences. And that's why people with type 2 diabetes, like my patient Gwendolyn, are able to reverse it by simply removing the poison instead of seeking antidotes. What are the antidotes? Insulin, pills, things like Ozempic. All of those are antidotes. Even berberine is an antidote. Let's eliminate the need for all of that by simply removing the poison. And the good news is the last time I had a ribeye, which just happened to be yesterday, it was delicious. There was no suffering here. And for those who are not carnivore, who are also ketovore, etc., well, the asparagus can taste pretty good too. The broccoli can taste pretty good too. The greens can taste pretty good too. So you can still enjoy your life, and then you manage your decisions. I was just at the Cheesecake Factory. What is a carnivore doing at the Cheesecake Factory? Had a relative come through. Shout out to my relative, Cassandra, who's visiting Chicago. And when I was there, I simply ordered a double cheeseburger with cheese on it and bacon. And I just ate the burgers and the cheese and the bacon. That's not suffering. My wife ate the side because she's a ketovore. She's like Nisha Berry. She's a ketovore. So she ate the side, and we stay in that lane. So no matter where you go, you can just say low carb, restaurant and put a name after that, and they will give you ideas. Low carb at McDonald's, low carb at Longhorn, low carb. So there's a way to manage even when you're out and about that'll allow you to do pretty well. I did see a comment from Robin Goodhand. She said, I brought a Keto Mojo. I'll see those guys at the symposium because they always have a booth when I go there, and they have a great products for glucose and ketone monitors. So she brought it, and she's still having trouble getting the ketones up and the sugar down. And so I just wanted to comment on that question. Number one, it may, you got to give your body time to do what it do, right? So be patient. That's number one. Number two, going back to what I said earlier, I tell my patients, you got to get those carbs down. So if you're not doing less than 20 total carbs, not net, I would say, let's do that first. Always remember that low carb keto diets are moderate protein diets. So you need protein, but you don't want to go crazy. And keto diets are actually high fat diets. So it's sometimes people have too much protein in their diet and not enough fat. And I always use the mnemonic BOCA for butter, olive oil, coconut oil, avocado oil. Those are oils that simply just get cold pressed, and they tend to be better than seed oil. So I would advise her to bump it up a little bit. I would give it a little bit more time to become fat adaptive, meaning that you're really burning fat as your primary fuel. So I just wanted to do a shout out for Robin for bringing that question up. And one more thing, I see Charles Michael, he commented on, I have contacted the society, and he wanted to find somebody in the Denver area. But then down later in the chat, someone mentioned Dr. Jeff Gerber, who's in the Denver area as a potential clinician. I always advise people also when they're looking for a metabolically trained doctor to look for someone who is either on the Low Carb USA site. They have a search engine, the Symposium for Metabolic Health site. The Diet Doctor site is still active, and they also have a search engine. And there's others, but I think using a search engine like that to find a doctor who has this training is probably a simple, easy way to align with your goals. But when you're talking to a conventional doctor, you have to just talk to them with dignity and respect and say, hey, I'm thinking about changing my diet to achieve metabolic health. I'm going to probably be reducing carbs. Will you walk with me? Will you walk with me? Because I really need somebody who can maybe look at a study and help me from a medical perspective, but just be respectful. Understand that the training is what got them to where they are. It's not that they don't care. They really want you to be healthy, but they're just kind of forced to follow guidelines that don't serve us. Anybody can look at a food pyramid and see that it's flawed. We are grateful that no matter how you feel about politics, that with the new administration, they do kind of get it. Dr. Casey Means, who's potentially going to be a Surgeon General, is already in the low carb space and gets it. So, and you don't have, and let's be clear about politics. You don't have to agree about everything. You just want to find some things that align with your mission, which is what we're trying to do. And let's work towards that particular goal. And then we can deal with the other issues down the road. So I really am hopeful that we'll be able to get some things done with the current administration under Kennedy when it comes to metabolic health related topics.
I'm glad you are hopeful.
I gotta be. That's the only way I roll.
I mean, it's Nina Teicholz who said every member of Congress is sponsored by at least one pharmaceutical, some up to 36. Well, so we'll see how that goes. Yeah. But like you said, we don't have to depend on policy to change. We can start grassroots. You and you can change today. You don't need anybody in Washington telling you what to do. And yes, I validate that changing the guidelines would be everything for hospitals and schools and prisons. Like that would be my ultimate goal and dream. But grassroots, you guys, that's what's really going to change the world. Because when you change yourself, it's not just you. It changes your family. It changes your community. It changes everybody you touch when you're a healthier human. And so real quick, we had a few questions I definitely want to address. Somebody was asking specifically about ketones, like and how to get your ketones up. And I appreciate Dr. Hampton's response. Intermittent fasting can really help too. People are very afraid of fasting. And I do want to say, if you are on any glucose lowering medication, you definitely want to make sure you're talking with either your doctor or a dietitian or somebody that can help you with that. But a lot of people, skipping a meal, letting your body kind of use some of your own body fat for fuel, or having, like Dr. Hampton said, having more fat. Unfortunately, my wife was diagnosed with breast cancer a few years ago and had to be on a therapeutic ketogenic diet. And that is different than like a carnivore diet. It was the first time that we actually restricted protein, because protein can go back through the cycle and become glucose. So if you're finding you're potentially eating a ton of protein, maybe pull back. And once again, it's not like, the super tiny bits of protein, but it's not like going super crazy. And then having more fat, whether that's olive oil or avocados or coconut oil, and just play with it a little bit, see what feels good for you, monitor. Also I always say there's levers, right? Nutrition is the number one lever, but yeah, exercise is another one, doing a little resistance training, going for walks, moving as you're able. And then also addressing sleep. If you're able to manage your sleep and stress, that can have a profound effect on your blood glucose. So what else? Okay, ketones. Oh, and somebody else asked about reversing type 2 diabetes. That's what we're talking about all day. Like what is the best way to do that? So I think both Dr. Hampton and I would agree that starting just by, getting your insulin lower, and that's by following either carnivore diet, a ketovore diet, really getting carbohydrates low. And you guys, unfortunately, especially if you're very sick, like if your A1C is very high, your margin for error is pretty low. If let's say if you have $5 in your bank account, you can't be like, well, today I'm going to go spend $1,000. It's my cheat day. It's not going to end very well. You don't really get a cheat. Last 30 years have been a cheat day. So really locking in. And that's not to say that you can never going to be able to have some fruit or potentially some starches again, but yeah, really buying in. The people that do the best, in my experience, really go hard for, between 3, sometimes, to 6 months to see results. Has that been your experience as well, Dr. Hampton?
Yeah. Again, there's levels of motivation that will vary because everybody starts from a different place. I had a couple of patients today, ironically, who struggled since the last visit, and it was mostly stress. But if you hear what they stressed about, it was some significant things. One was a loss, and another was just having marriage issues. So I can't expect a person in the middle of a storm to, come out on the other side without struggle. And so always give yourself grace. that does not keep you from moving forward, but it does allow you to say, you know what, I was going, when you're in a pandemic, it would be reasonable to say that may be a difficult time to be optimal. We're in a pandemic, so.
Yeah, you're going through a divorce, you're moving across the country. Probably not the easiest time to change your health and change your life. So
I do want to say, for those who are just joining us, we're here representing the American Diabetes Society, and we're on the board, and we're just here to create awareness. Our focus is using nutrition to heal reverse diabetes type 2 and to better manage type 1, where even a type 1 can have a blood sugar or A1C at the normal range of 5.6 or lower. And just to put that in perspective, I've shared this before. The average type 1 has an A1C of 8.6 in America. And I learned this statistic when my wife was taking Dr. Eric Westman's Adapt a Life type 1 diabetes course. And during that course, they said but that 8.6 translates to a blood sugar that's probably like 200 on average. But more importantly, it translates into losing, on average, 12 years of life.
Oh, geez.
And when you've been married, we've been married 32 years now, and I'm not trying to give up 12 years of life with my wife because we couldn't eat slightly differently. So it's really important to understand that this is kind of a big deal. So the QR code's up there, the website's down there. So make sure you take advantage of that. Share in the comments if you're supporting the cause. One of the questions, reversion to the mean, said, my total cholesterol went up in 1 year, just like I warned my doctor it would. Obviously learning and knowing what would happen, but every single important marker was great. She told me no need to take the statin that I refused to take. And that's interesting. So most doctors will continue to push. And ultimately, what's better? You take and I would not ask you, this is not medical advice, right? So when we share things, we have to be careful. But if you're even at risk for heart disease and you take a statin, there's data that would suggest that if you do that with the high risk of heart disease for 5 years, you may gain about 4 days of life additional by doing that. Now, most people don't know that. Now, so that's one thing. The other part is, I also think there's another approach, which is if I have diabetes that's not controlled, it's not at go, your risk for having a heart attack is equal to a person who's already had a heart attack. So that's a real risk. So sometimes what I tell patients is, if you're going to take a drug like that, knowing that the lifestyle is going to be more effective, but if you want to bridge yourself from your current state to where you are at go and your A1C is normal, and then maybe at that point you don't take a statin, that's another approach you can take. So you always want to talk to your doctor or your advanced practice professional and just kind of negotiate what you're going to do. And I think that approach is better, but I can tell you from my clinical experience and what I've seen in the research is that the lifestyle lever is one of the most effective to reduce inflammation, which is what I think the biggest benefit of a statin is, the inflammation benefit. But you can do that with a dietary approach. So I really encourage anyone who's checking us out to understand that. Secondarily, we also know that, yes, you may have a bump in your cholesterol or LDL because of saturated fat in your diet, et cetera. But the bump is actually a beneficial bump, meaning most of the times when that happens, you're increasing the fluffy, large particles of the LDL cholesterol. You're reducing the small particles, which are the ones that gets into the crevices. Therefore, your quality, like if you look at his comment, he said, all his markers were better. He probably had a lower fasting insulin level, which everybody should get. And everybody should get a calcium score test too. In our health system, it's a $49 test out of pocket. He probably had a triglyceride to HDL ratio, which is the most important thing you will look at on your cholesterol markers, that is less than 2 and even better, a 1. He probably had set rates and CRP, inflammatory markers, that got better. He probably had the particle test where the small particles were low and the large particles were at go. So ultimately, if everything's getting better And the only thing that's elevated is the total cholesterol. And by the way, the total cholesterol includes the bad cholesterol. I mean, the good cholesterol. So if you have a very high HDL, your total cholesterol is going to be high. You should celebrate that, not be upset about it. And then you should not lean on the LDL cholesterol as the best marker for your risk for heart disease, because we only care about diabetes and hypertension for the main reason is we don't want to have a heart attack or a stroke. So if you look at a cholesterol or LDL as a baseline, you'll find that the blood pressure, and there's a blood pressure machine right next to me, is 1.9% more predictive than the cholesterol and LDL for a heart attack. Oh, by the way, that fasting insulin I mentioned earlier is 6.7 times more predictive of a future heart attack. So let's focus on the metabolic markers that we are not necessarily getting from our primary care doctor. And if necessary, we'll go outside of that environment to maybe own your own labs or something like that and get your own labs, which will then make you feel better about moving in this direction. So I really think we're hoping that this is the type of information that the American Diabetes Society can share with people, not just recipes and things like that Michelle and the rest of the team are going to put in front of you, but just the knowledge of why you should not worry, particularly when you feel great, you're losing weight, you feel more energetic, mental clarity, and all these things that happen that allow us to even do the work we're doing right now. We feel like doing this work. It's not just because we know it's the right thing to do, because we feel good. And you just can't beat that with a stick, Michelle.
Yeah, feeling good is everything. And that is a dietitian that makes me very frustrated when some of my patients will go to their doctors that aren't really educated in the metabolic health, and they feel so much better. And like you said, all the triglycerides are lower, HDL is higher, but since LDL is slightly elevated, their doctor really worries. But I just want to reiterate that Dr. Hampton was saying that fasting insulin, you guys, you have a high fasting insulin, or if you have high blood pressure, that is much more indicative of a potential for a heart attack than, looking at just LDL in a vacuum. So I just, we're really looking at the current medical system, and some of the standard of care is, in my opinion, scaring people when we can really fix so many of these issues with nutrition. And somebody asked about ketosis and ketoacidosis. And so as a dietitian, that a lot of people are scared that they're two incredibly different things. And I've only seen ketoacidosis a few times in my entire career. Do you see that at all in your practice?
Yeah, a lot of times it ends up happening in the hospital. So they'll kind of bite, because usually when they're that sick, they'll go straight to the hospital. So have I seen a few people in my practice get it? Sure. But like you said, nobody's getting nutritional acidosis. You can get nutritional ketosis, meaning you're in ketosis. And the reason, and ultimately you just don't see it, but one exception. And we mentioned the medicine earlier for those who are just joining us. We mentioned the medicine Jardiance. So the medicines that make you urinate out the glucose can put you at higher risk for what they call euglycemic ketoacidosis. So if you're on one of those GLT2 inhibitor medicines, it's important to be cautious. Now, most endocrinologists say you can probably still do low carb with that medicine. But if you look at the guidelines for therapeutic carb restriction, we have an asterisk in there that states we need to use caution because there is this risk of that occurring. But as a general rule, and our nutrition professionals, our pharmacists, and our doctors need to know that keto diets are very safe. And it may be the most logical diet for a person who has a carb intolerance. You're removing the poison. So if we can get past these fears about saturated fat and red meat and all of these things that have already been debunked, then we can move towards a diet that's likely to be the most effective for diabetes and easily you could argue is the best diet for obesity. As an obesity medicine specialist, I've not seen any other dietary pattern. In fact, the Public Health Collaborative put something out about comparing low fat to low carb. And in the history of randomized trials that they've reviewed, there's not been any low fat diets that would be more plant-based that were more effective than a low carb diet in the history of randomized trials for significant weight loss. That's gotta make
It's
you pause.
impressive.
You know what I mean? In the history. So why are we don't have to play around with
So we have this incredibly effective way of eating that is, like you said, the history we've looked through, all different types of diets. And, I know there's a lot of plant-based, higher carbohydrate diets being pushed, but this lower carbohydrates, especially animal-based diets are sustainable, effective. It was actually Dr. Eric Westman who told me, this was back in, I want to say the 2020, 2021. He said, Michelle, these are the most studied in looking at everything, looking at Mediterranean diets, vegetarian diets, ketogenic diets are the most studied diets showing they are effective, they're sustainable.
Yeah.
People want to do them. They like this type of food and they're safe. Like we have very minimal and ketosis, you guys, nutritional ketosis is a very safe state to be in, where obviously ketoacidosis is not. That's something that is relatively rare. It can be caused by either specific types of medication or incredibly uncontrolled blood sugar. I see it sometimes in like an uncontrolled type 1.
That's
but not, but when I was a dietitian training as a dietitian in 2009, that was the way to scare you. It was like, oh, ketosis, it'll kill you. It's like, no, those are two very separate things.
Yeah,
so.
And it should make you pause if your doctor or other clinician still speaks that language. That just suggests that they're probably not keeping up with the basic science. And we do want to, we're paying the copay so that we are in front of somebody that's doing that. So, and there was a question. And by the way, guys, as you continue to support this cause and ask questions, I forgot to mention QQQ. So if you put QQQ in front of your comment, that'll let us know you have a question. Jeff Palmer, proper human diet. One shout out to Dr. Berry for coming up with that. 1.5 years, labs in the good optimal range, except blood pressure 140/80, cholesterol is 400, weight stall for a year. I'm eating too much protein or fat, carbs, basically looking for a little feedback. Starting with the blood pressure, I just want to say that the blood pressure is complex for a couple of reasons. One is because I mentioned nitric oxide earlier and how hyperinsulin states will reduce the nitric oxide, which will then lead to constriction. The nitric oxide is made in your blood vessels naturally, but they won't be made if you're in a high insulin state. So imagine a person literally can reverse type 2 diabetes within a very short amount of time. It's just like bariatric surgery. When I have patients who have bariatric surgery, they literally come out of surgery and have to get off insulin almost right away because that surgery does multiple things that lead to that. But Dr. Jason Fung, he does a lot of fasting. So fasting will also make things happen pretty fast. But ultimately, at the end of the day, your blood vessels take a little longer than diabetes. So it may just be the healing, endothelial cells are still healing. They're not really making nitric oxide. So you may be in that range where the blood pressure is still running a little high. But I created my NEST acronym: nutrition, exercise, less stress, more sleep, recovering from trauma, and how you think. Because if your sleep is off and your stress is off, you're still going to have a high blood pressure. But I would also argue that the minerals are important. So a lot of people in our community, some people use electrolytes, some don't. You could argue that electrolytes, those things could be off. So not only should you check those things like the sodiums, potassiums in your blood, but you also need to maybe consider electrolytes as a way to kind of help your blood pressure balance to be better. We're not surprised when the cholesterol goes up. We're more concerned about the triglycerides going down and the good cholesterol going up. So if you have a bump in your cholesterol and you're concerned, I would just have your doctor check the particle sizes and your inflammation markers. If your inflammation markers are down and your particle sizes are favorable, where you don't have a lot of small and you have large, your triglyceride to HDL ratio is good, then I would not let that total cholesterol be an issue, because again, it may be that your HDL, your good cholesterol, is high. Weight stalls are very common. In some ways, they're good because your body's recalibrating. Sometimes it's like, hey, let me take a break. Your body thinks you're killing yourself, right? I mean, if you just go crazy losing 100 pounds, your body's like, well,
yeah, man, we gotta stop.
Easy, right? So your metabolism is gonna be impacted, etc. So sometimes a little bit of a stall is actually your body just chilling for a minute, trying to protect you, and so just be mindful of that. Although I will admit that we talk about this being a high-fat diet when you're doing keto, And sometimes when you're not fat adaptive, sometimes the fat may be too much. So sometimes you have to start, being mindful. We don't talk about calories a lot, but sometimes you're just eating too much. It's okay to eat till you're full in most cases, but if you're stalling and you give it a little time, you may want to think about things like that. Think about your sleep, think about your stress. Or are you snacking? I mean, who walks by, some peanuts and don't grab a handful? And Dr. Eric Westman will tell you, don't even try peanuts when you're doing low carb or keto, because it's just like it's an addictive thing to eat. So you're going to have to problem solve, and that's kind of what you want your doctor to do. You want a doctor to walk with you to problem solve, because everybody's uniquely made, and bio individuality means that we have different struggles for different reasons. Let's just say this live stream is stressful. It's not that stressful, by the way, but just imagine if it was. then that would affect my body. And imagine if I did that all the time and it's stressful to me, then my story would be different than yours, and I would have to figure out how to make it less stressful. So just always problem solve. Don't get frustrated, and just stay the course.
I love that. Yeah, no, that's fantastic. I do often see people, especially, women, when we're going through perimenopause, into menopause, there's often people will have stalls, and we do the same thing. We kind of go back through, and it isn't uncommon for people to get a little excited with eating fat. We want you to feel satiated. We want you to eat, until you're full. But if you are struggling losing body fat, sometimes just pulling back on that a little bit can actually help, because you can actually use your own body fat, right, to making up some of your calories. So thank you guys so much to everybody who's donated. There's the QR code and the link. We really appreciate everybody. Dr. Hampton, somebody's asking if fiber is necessary. What are your thoughts around that, being mostly carnivore yourself?
Well, the Journal of Gastroenterology did a study, and that study basically had people who were eating zero fiber, which is kind of where I'm at, and people eating fiber in a group in between. And the group that had abdominal pain, bloating, cramping, were the group that was eating the fiber. And I just think that to say you need fiber is a false statement. When I was with Carrie of Homestead, Howe had a meetup at his theater, Montello Theater in Wisconsin. And at that theater, I talked a little bit about Dr. Bobby Price's video about carnivore, the 8 things you should worry about. One of the things he mentioned during the live stream, and shout out to him, because we like anybody that's out here sharing nutrition. He said that you can't have a bowel movement without fiber. Now, is anybody on this live stream thinking that statement? That the lions and tigers can't have bowel movements. Carnivores like myself, Dr. Kim Berry, Dr. Chafee, can't have bowel movements. So again, it's okay to have a interesting conversation about these topics, but you do not need fiber. It's not an essential nutrient. And we have proven to you that you don't, because we have bowel movements. So I think all of the things that benefit from fiber are true things. Like maybe it helps to reduce your cholesterol and but the reality is you don't need it. We need amino acids and fatty acids, and you can get that from a steak or chicken or fish. So I just think it's overrated. If you benefit from fiber, have at it. I find it makes me bloated and doesn't make me feel good at all. So I am not a big fan. But I meet people where they are. I have vegans in my practice. So whatever works for you works for me.
Yeah, I see both. I see people do really well in carnivore, and I see some people that just really appreciate the low starchy vegetables and are happy and have no. So it's like, I think if everybody just did that, I think we're totally okay. So, and especially sometimes if you're transitioning off a very high standard American diet that has a lot of starches, sometimes incorporating some fibery things really works well for certain people. So, instead of a potato, I'm having cauliflower rice or something like that. So, and thank you to everybody who's donating. I see a couple in the comments. Thank you guys so much.
I see one more thing. There was another comment from Drex of the North. That's an interesting. And what it was a question about sweeteners like sucralose. Can they stimulate insulin production? Right. Mm-hmm. Great question. And the answer is yes. And it's really important to know this, because some of the electrolytes we recommend sometimes can have sucralose in it, but it can stimulate insulin response. And not everybody, in some people, And sometimes it does it without even raising your blood sugar, which is really interesting. So, so I just think that you just have to be careful. We feel better about stevia and monk fruit. We feel less comfortable with sucralose and aspartame and saccharin. So if I were in your shoes and you just got to get that sweet taste, I would lean towards stevia and monk fruit. Some people use allulose as a sweetener. But if you're rarely doing it and you just need a little electrolyte bump and you talk, if I do electrolytes with sucralose, it kind of bothers me. Maybe after the second time I do it, so I tend to avoid it. But if you tolerate it and you find that your things you're measuring are okay, having that periodically is okay. But I definitely want you to know that's a definite possibility.
So I wonder if you and I are going to get kicked out here pretty soon. We're coming up to
the
11th hour, you guys. So I know Dr. Berry and Temple Stewart are next. Yes. Real quick, there's one question results from the Blue Zones diet that is more plant-based. I actually had to do an entire continuing education thanks to the Academy of Nutrition, governing board of all dietitians. And just very briefly, most of the people in the Blue Zones, they actually eat a lot of meat. Some of those areas, specifically Japan, Okinawa, is some of the highest consumers. North Korea. That book was incredibly flawed. Like going back through their studies, and so I always encourage you guys to do this too. And most people don't do those. Statistically, 80% of people only read headlines. They don't even read actual articles. But often people will say stuff and they'll cite studies. I had a patient do this. They were very scared about stevia. And, this person said it was a neurotoxin. I'm like, did you read their studies? And she messaged me back and she said, their studies don't say anything about neurotoxin. They actually say good things about stevia. So that's I could do a whole presentation on how silly the Blue Zones research is. But just know that most of the places that they talk about are very high meat eating places. But I will also say a few things about their longevity that I think we could do better in America specifically is they really focus on community. Yes. They get a lot of sun. They tend to get more movement.
That's right.
They also get a lot of meat. So
I did a video. I did one video. If they search my name on YouTube and Blue Zones, one was showing all the data that proved that they do eat meat in every Blue Zone, number one. Number two, I did a video saying what you just said. There are benefits of the Blue Zone, and a lot of it was community and things like that. So you definitely don't want to throw the baby out with the bathwater.
No, there's some very good important things.
We learned a lot.
Don't eliminate. I think their take-home messages were like, eliminate meat, eliminate eggs. It's like, oh, no, don't do that. Right. So, well, you guys, it sure has been an honor to be here with you. I'll actually be back with Dr. Eric Westman at 4 p.m. Central. And I have patients I'm going to have to go see. So, Dr. Hampton, do you mind just carrying on until?
Yeah, I can absolutely carry on. You go do your thing. I'm done with clinic, and I'll just wait for my baton to be passed in a moment. So I'll kind of see what's going on in the comments and make some comments. So absolutely have no problem. But thank you, Michelle.
I appreciate it. I'll see you soon.
And I definitely want to continue this conversation by saying to everybody here that you being here is an example of what's going to move the needle. Everybody who is on a journey needs people, whether it's a physician with training or somebody who is like themselves that they can relate to, like that Gwendolyn Butler example that I shared earlier. Everybody makes a difference. So rather you're just talking to a neighbor, not preaching, but just saying, if they ask you a question, oh my God, how did you get off your medicine? Oh my God, you have really lost a lot of weight lately. So what's going on? And how have you done that? That's your moment to advocate for what you feel will be an approach that may work for them. But I also want to say, when I was at the Symposium for Metabolic Health, I think the last time I spoke there, may have been last year, my topic was how vegans and carnivores can live in harmony. And I think that type of approach is the better approach. Do we have fun making fun of each other periodically? Absolutely. But, and I won't make fun of Dr. Kim Berry for sure. But at the end of the day, if you have a person in front of you who ultimately is more plant-based, I'll be out in a second. I'm in a live stream. I'll be out, I promise. But the key is this. If I'm with a patient who's Hindu and they worship cows, right? then it's likely that I'm not going to convince them to eat a steak, right? And I need to honor that. But then you have Dr. Mariana Glant, who's going to be on here later. And you have people in communities like in India who are actually still getting off of their medicine by doing a low carb plant-based diet. And so we have to meet people where they are. But we also have to know enough to say that, yes, the Seventh-day Adventists, 15% of which are plant-based based on data, may advocate for a plant-based diet. And they do live 10 years longer than us. So we have to honor that. But we also can say that the Mormons, who also live 10 years longer than the average American, eat a ton of meat. So do we ignore that data point? Do we ignore the data point that Hong Kong eats a ton of meat, 2 steaks per person per day on average, and they live longer than most civilizations? Maybe they compete with Japan, but that's it. We have to honor these. And I think as a person who's watching us, following us, learning from us, have a few of those nuggets in your back pocket. But again, we're not here to fight. We're here to just say, this works for us. And all we ask is that you allow us to do what's best for us, and then you do what's best for you. And I think that approach is the best approach. But I do have a baton in my hand, Dr. Berry, and I was told I needed to pass it to the next runner. Now, I'm not sure how much, I don't know if you're like Michelle Hearn, who's an actual runner, but I'm just hoping to pass that. So I think it'll be helpful for those who are new to you to introduce yourself, share a few talking points. We've had a good start, and I really appreciate you and all the work you do. You've inspired me probably more than anybody to have a YouTube channel. You pulled me to the side one day and said, man, I need to hear your voice. I was like, I'm busy. I don't have time for that. And you said, you know what? You're going to reach more people. And I really will always be grateful. You're one of my mentors. Dr. Eric Westman, for slightly different reasons, one of my mentors. And I'm just grateful that I've found myself in such good company. So thank you, my brother, for everything you're doing.
Oh, it's my pleasure, Dr. Hampton. And let me just say, the amount of people that you're reaching and your reach into different communities is invaluable, both for the ADS and for your own patients, because they now have you 24/7. If they're like, I wonder what Dr. Hampton would say about this, you got a video. They can go watch it at 3 a.m. when you're in bed asleep, and they've got their doctor with them 24/7. So I applaud you for taking, because it's a big leap to start a YouTube channel, especially if you're a busy practicing physician with a family and other social responsibilities. It's a big leap. And so thank you for the work you're doing with the ADS, and thank you for what you're doing in Chicago and all around the world with your YouTube channel. You are making the world a healthier place. Now, I've got Temple Stewart, one of our registered dietitians. I think if you need to go see patients,
I'm gonna make a move. Everybody have a great live stream. Thanks, and you guys have a great one.
There's Temple. Hello, Temple Stewart. How are you doing?
Hey, good morning. I'm doing well. Thank you.
So good to have you on here. So we're picking up the baton. We're going to take this to the next hour. And I want to encourage everybody watching this right now. I need you to tweak the algorithm. I need you to do that by telling me where in the world you're watching this from, what city, what state, what country, first of all. And if you haven't already hit the thumbs up or the heart and the subscribe button, please do that right now. It's free, doesn't cost a penny. And then please next click the share button and share this on as many different social media outlets as you care to do. That's how the ADS can reach new people, people who don't know that they can reverse their type 2 diabetes. And I want to first give a shout out to all of our type 1 people with type 1 diabetes. You don't get talked about nearly enough. We all know that and we honor that, but you guys know as well as we do that 95 to 97% of people with diabetes, it's type 2 diabetes. And it's not fair to people with type 1 diabetes, but that's just the way it is. And so that's why we talk about type 2 so much more than type 1. It's not that we don't honor people with type 1 diabetes. We very much do. And we very much want you to have a normal hemoglobin A1C. And we want you to drastically cut all of the complication rates that people with uncontrolled type 1 diabetes have. I think Dr. Hampton talked about this earlier. If you have uncontrolled type 1, you're going to cut 11, 12, 13 years off your life. And that's just your lifespan. But when we start talking about your health span, Temple, you're cutting decades off of your time on this earth that you could be healthy and active and productive and having fun, and rather than being in dialysis or walking with a cane because you had a toe removed or a foot or a leg. We don't want any of that stuff for our type 1 diabetics. So we got people from all over the world. We got Texas, we got Arizona, Idaho, Arkansas, Michigan, Birmingham, Alabama, Illinois, Ecuador. Hey, Ecuador in the house, Omaha, Nebraska, Raleigh, North Carolina. Yeah, good. So please keep in mind that when you share a video like this to your social media, it shares it in your regional area. So wherever you live in the world, the social media is going to share it to people who are near you. So there's probably, you have a next door neighbor, or you have a friend or a relative who follows you on Facebook or Instagram or wherever, and they're going to see that when you shared that. And if they have prediabetes or type 2 or type 1 or MODY or LADA, they're going to say, oh, what's this? American Diabetes Society. I haven't heard of them. Temple, how's it going? What have you been up to?
Oh, the same old stuff. I was just amazed at all the different countries represented in the comment section. I think it's such a cool thing that the American Diabetes Society is getting out, not just to the States, but to the globe. I think it's what a treat it is for people to find hope that this could provide.
Yeah, 100%. And I just noticed that the other Diabetes Association has changed their thumbnail. And it's now, it looks like the ADS logo.
Interesting.
It's, and it has 85 in it, which I've never heard them talk about. So I thought that was quite interesting, because if you just glance at it, it looks like an ADS logo, but it's not. So I think that we're being noticed and making a difference. But what I want to tell all 468 people watching is, number one, we need 1,400 people watching this.
Yep.
And you do that by hitting the thumbs up or the heart. You do that by leaving a comment, by asking a question, and by sharing this video. That's how you make that happen, because there are millions and millions of people around the world with diabetes who don't know that type 2 diabetes is reversible. And they don't know that they can have a normal A1C as a type 1 diabetic. They've never been told that. Every time I speak, Temple, all over Tennessee and all over the world, I'll ask people, who all has type 2 diabetes in the room? And always some hands go up, because it's super common. And my next question is, has your doctor told you that you can reverse your type 2 diabetes completely? And invariably, this is what I see. No, I've never heard that. My doctor never said I could reverse it. They told me it was chronic and progressive, and I would have it for the rest of my life. And so that's the message of the ADS. Now, the second thing is, I've already checked our bank account, and the donations are rolling in. But here's who has not donated. Are you ready for this list? Coca-Cola, Kellogg's, Kraft Heinz, Mondelez, Pepsi-Cola. None of these guys have donated. And the other association that wants to be Partners for Life with diabetics, they get millions of dollars a year from those huge corporations who basically make a profit by harming people's health. And not only has the ADS not gotten any donations from these big pseudo food manufacturers, we don't want their donations. And if they send us a donation, guess what we'll do? We'll tear up the check and we'll send it back and probably issue a press release saying, hey, Pepsi-Cola, we don't want your money because you've done enough damage already. So what we need is $1 donations, $5, $10, $20, $100 if you got it, by either scanning the QR code or going to the AmericanDiabetesSociety.org and making the donation that you're financially comfortable making. We're never going to get $1 million checks from the people who make junk food. They are not interested in our message, because our message to them is don't eat junk food to start with. It's not actually real food. It's pseudo food. It's frankenfood. And I'm going to let our registered dietitian, Temple, talk more about the difference between real, whole, one-ingredient foods and what that can do for your health versus ultra-processed junk food that you see all the advertisements for. You're always seeing cute little TikTok and Instagram memes about this new cereal or that new soft drink. Why don't we ever see commercials about real food, Temple? And what's the difference between real human food and pseudo food?
Yeah, I think that's a great question. And before we jump into that, I wanted to add to Dr. Berry, tell our audience if we're getting any donations from pharmaceutical companies as well. Is that something we're going to be doing?
100%, yeah. And it's actually in our founding bylaws that if we receive any kind of donation from a big pharmaceutical manufacturer, which I doubt we will, but if they trip and fall and actually accidentally send us a donation, we're not going to take their money, because anytime a society or an association or an organization accepts a very large check from a big pharmaceutical house or a big food manufacturer, they get to then have a little bit of say-so in your messaging. And we see this in the other Diabetes Association. They got a huge check from one of the artificial sweeteners. And then all of a sudden, in the recipes on their website, you needed to use that artificial sweetener. And we're not interested in business partnerships. We're not interested in that at all at the ADS. We're interested in educating people with type 1 diabetes who are currently stuck with it for life, how to have a normal A1C and drastically reduce all the complications. And we're interested in teaching people with type 2 diabetes how to reverse it completely. We do not want to be your partner for life. We want to teach you how to reverse your type 2 or manage your type 1 so beautifully that when your doctor checks your A1C, it looks like you don't even have type 1 diabetes. And so, yeah, we're not taking any donations from big pharma or big food. We're not interested in establishing a cozy relationship with them. They could go pound sand. We're here to help people with diabetes know how to eat in order to have a normal A1C.
Yep. And I think that's a great segue into talking about ultra processed foods, how they get us to type 2 diabetes, and kind of the difference between those and real foods. When I talk about ultra processed foods, I always explain to people, think about ingredients that you would never use at home or you would never find in your kitchen. Additives, emulsifiers, artificial colors, preservatives, lots of sweeteners, flavor enhancers, all that kind of stuff. You're thinking packaged foods, soda, cereal, fast food, chips, even processed, meats to some degree, versus real foods, which are going to be your whole foods, minimally processed, closest to the natural form, foods that you can recognize, pronounce, you can kind of find on planet Earth, meat, dairy, seed, nuts, those types of things as well. And, the why this really, really matters for your health is obviously, we're going to get into the blood sugar control and insulin conversation. Ultra processed foods are often extremely high in refined processed carbohydrates and sugar, and that's going to make the most impact on your blood glucose, on your insulin, on all of these. Real foods have high protein, they have fat, they have all these things that do a great job keeping blood sugar and insulin low and slow. Lots of ultra processed foods promote inflammation with all these additive ingredients and seed oils and omega-6 fatty acids and all these other things that our body's just not used to tolerating. Ultra processed foods can also damage your gut health. They just put your chronic disease risk levels so high. Type 2 diabetes, but that's not the only thing. Cancers, pretty much everything under the book could be linked back to ultra processed foods. And so, think of ultra processed foods as not really foods at all. And that's really what we're encouraging you guys to make the switch from is these foods, frankenfoods, human processed foods that were never, ever meant to be consumed or put in our bodies. This is what we're trying to direct our attention from. We're trying to bring it back to meats and whole foods from planet Earth.
Absolutely. Now, I want everybody to tell me in the comments and be honest, which way of eating are you currently following? Are you low carb? Are you keto? Are you ketovore? Are you carnivore? Are you following a lion diet? Are you vegetarian? Are you vegan? We at the ADS want to help every single human being on planet Earth enjoy their best possible health. So tell me in the comments, what is your diet? And if it's standard American diet, that's fine. Right now, it's not fine going forward in the future, but we want to know what kind of diet you're following right now in the comments. and that'll help the algorithm know that this is super important when it sees lots of comments. So tell me in the comments, are you carnivore-ish? Are you keto-ish? Are you low-carb-ish? Are you on the IC diet, which means whatever I see, I eat? Tell us, are you on a junk food diet? Be honest. Don't lie, because we can't help you unless we know where to meet you at. And so I want to see in the comments what everybody's doing right now. Now, as a registered dietitian, I've seen a couple of questions about calories. And, there are some people who say it's all about the calories. Some people say calories have nothing to do with it. Why should people, especially people with diabetes or prediabetes or insulin resistance, why should they focus more on carbohydrates and sugars than they should focus on calories?
Yeah, great question. And it's really because your hormonal environment dictates everything that your body does with said calories, right? So in the standard American diet, your body is constantly spiking blood glucose, insulin, et cetera. So even in a calorie surplus in this situation, you're getting these products locked into fat stores quickly. Now on a carnivore, ketovore-ish, whatever you want to call it, low carbohydrate diet where carbs are zero or very, very low, insulin stays low and steady, and fat burning or lipolysis stays switched on. And so I probably fall somewhere in the middle. I think carbs matter. I mean, calories matter to a degree, but hormones matter so much more, right? Because they're telling your body, what are we going to do with this? Are we going to store it? Are we going to use it quickly for energy, et cetera? And so another important effect, carnivore, keto-ish, whatever, protein leveraging is so, so important. Carnivore is extremely high in protein, same thing with some of your keto types. And obviously protein is the most satiating. So you're getting your satiety hormones, your GLP-1s, all these fun things that we like to talk about. And that helps you burn that fat by, kind of naturally controlling the calories that you're consuming. And you're also not going to get those ultra processed, hyper palatable dopamine hits from those ultra processed foods that we talked about, which encourages you to eat more and kind of keeps you on this unlimited, I'm starving all the time train. It's just so much different when you lower carbohydrates, you get into ketosis, you're fueling your body with fuel that works well and is very efficient. Whereas, only focusing on calories and consuming a lot of carbs, simple sugars, and things like that, you just get stuck in these hormonal effects that promote overeating, that promote never being full, and kind of keep you in this food noise trap all of the time. And those are the biggest differences. So yes, we should pay attention to calories. And I certainly don't encourage people to just consume, loads and loads of them. But when you are eating low carbohydrate, ketovore, carnivore, whatever it may be, your body naturally controls a lot of that because your hormones are in a very healthy place. Your ghrelin, your leptin, your satiating hormones, all of that is at a good point, and it kind of controls your overeating. I hope that answered your question. What should you add?
No, I love that. I think that thermodynamically speaking, calories obviously are a real measurement and they are a real thing. But I think you said it beautifully. Your satiety hormones and your hunger hormones are 10 times, 20 times, 50 times more important than the calories. And you and I both know that someone who's counting calories and not worrying about how many carbohydrates and how much sugar they're eating, much of the ultra processed frankenfood that you can buy in the supermarket is designed by chemical engineers and food scientists to hack your hormones. Because if they're able to hack especially your satiety hormones that tell you when you're full, then you never feel full. And you can just keep eating their food-like products all day, every day. And that's going to lead to you just eating too much food. When you jump on your bathroom scales and weigh yourself, that is weighing atoms and molecules. It's not weighing calories. Calories are a unit of heat energy. And so you're weighing atoms and molecules. And when the big food manufacturers have hacked your hormones that tell you when you're full, and you just eat too many molecules or atoms, which is what food is made up of, then that's going to show up on the bathroom scale. And then when you're eating too much sugar and too many definitely simple carbohydrates, that's going to show up on your blood sugar. And anytime your blood sugar spikes because you ate too much sugar, too much simple carbohydrates, your insulin level is going to have to go up to try to pull that back down. And so that's going to leave you hyperglycemic, hyperinsulinemic, and then also in many cases, if the processed food is inflammatory, inflamed as well, and then it's going to be very, very hard for you to lose the stored fats. The most important of which, as Dr. Hampton said, is the visceral fat, the fat inside your belly, the fat inside your liver and your pancreas, the fat surrounding your internal organs. That's the most dangerous fat that you want to get rid of. And in order to do that, you have got to cut the sugar and cut the simple carbohydrates. And then for some people like me, you even have to cut even the more complex carbohydrates down quite a bit in order to attain your ideal body weight range and your ideal blood sugar range and your normal A1C. You've got to do those things, and it's different for different people.
Yeah.
Now, everybody watching this, we're almost up to 500 people watching this, and we've got to get this up above 500 so we can reach more people. If you have a question for Temple Stewart, who's a registered dietitian, or me, who's board certified family physician, type it into the comments and put 3 capital Q's, QQQ, in front of it so that we can differentiate it from just a comment. And we're going to pull up some questions and answer them as time goes on.
I saw one, Dr. Berry, that I think we could tackle about impossible meat versus real meat, and really why impossible, or any of the lists, right? There was a new one I saw that came out that's kind of a different type of butter that Bill Gates kind of made. So let me just tackle this in a couple directions.
Yes.
One, the first thing is the ingredient list, right? Look at real meat, any form of it, pork, beef, chicken, that's all that's in it, right? You look at Impossible or any of these other brands, it's soy protein, oils, canola oils, methylcellulose, yeast extract, food starches, a lot of other additives, preservatives. You cannot make this in your kitchen. It's refined. It's in an industrial facility. It's lab engineered to make it look like meat. There's very, very heavy nutrient deficiencies in it as well. So like real meat is going to have, B12, heme iron, zinc, creatine, carnosine, all your beautiful nutrients that work good in the body. Impossible meat is all fortified. So any nutrient in Impossible meat is going to be your synthetic vitamins, minerals, et cetera. And then of course, again, back to the additives, is you don't have additives in real meat, and it's designed perfectly to fit together in its amino acid profile, versus these kind of fake. Again, I keep going back to Frankenfoods because that's really what they are. The Impossible burgers, the Impossible sausage links, all of that is designed, but it truly is a Frankenfood and is not going to pay off well hormonally or in terms of nutrient density at all.
Yep, I totally agree. I think you're exactly right. And here's a question from Nancy. Nancy says, I don't have diabetes. However, I have an enlarged liver. I've read where it can be connected and diabetes is on the way. Is this the case? Yes, Nancy. By far the most common cause of an enlarged liver is fatty liver disease. And fatty liver disease immediately precedes developing prediabetes and then ultimately type 2 diabetes. And so the first thing I would do, Nancy, is ask your doctor to check a fasting insulin level, and yours is probably going to be high. You want that to be under 10 if at all possible. And then realize that the fat in your liver did not come from the fat that you've been eating. It actually comes from sugars and simple carbohydrates that you've been eating too many of, and that's stored immediately in your liver as fat. Fatty liver is very dangerous for many reasons, but it is absolutely a harbinger of type 2 diabetes in your near future, 100%. Here's another question from Ruby. What have you heard about being carnivore and kidney transplant? So I'm not sure exactly what you mean. I'm assuming you mean if you've had a kidney transplant, should you eat a carnivore diet? And I may be speaking towards the myth that eating lots of healthy animal protein is somehow bad for your kidneys. And so I'm going to take this first and then let Temple take it. What I would tell you is if you've had a kidney transplant, you want to protect your remaining kidney function like gold in the vault. You want to protect it at all costs. And the way you do that is by eating no added sugars and really limiting the amount of simple sugars, simple carbohydrates, and maybe even more complex carbohydrates. You want to keep your carbohydrate intake very, very low. And that's going to involve, because you got to eat something, right, Temple? You can't just live on air and sunshine, although some people tell you can. I don't think that's true. You have to eat either carbohydrates or protein or fat or some combination. And if you cut your carbohydrate intake, then by definition, you're going to increase your protein intake and your fat intake. And I can tell you, Ruby, that there's no research that shows that eating a diet that's rich in healthy animal protein does anything bad to your kidneys at all. And I know 10 or 15 people watching this just said, well, my doctor literally told me that I have a little bit of kidney disease. I need to cut back on red meat because it's so high in saturated fat. And let me just tell you, that is a medical myth that will not die. There is no research ever in the history of humanity who has shown that if you eat lots of healthy animal fat or healthy animal protein, it is going to do anything but be good for your kidneys. Do you hear this myth a lot in dietitian circles, Temple?
Yeah, and it actually was one that I was taught. But when you look at the research, just like Dr. Berry said, this myth kind of originated from bad research on people in like end-stage kidney disease. And so it is just so far from the truth. And they kind of took it and ran with it, including a lot of dietitians, because this is something that is still very often taught. And, you know, and I'm sure you've seen this in your practice. I've certainly seen it in mine. Is I have seen nothing but kidney GFR improvements. All of your kidney markers improve with a low carb ketogenic style carnivore diet. And so, yes, this is one of those myths that need to die right alongside saturated fats. But I couldn't agree more. I think this has gotten blown way out of proportion. And so you're spot on with protecting your kidneys. The number one cause is diabetes, high insulin, all these other things. We've got to stop that before even thinking about high protein being damaging.
Yep. And here's a comment from Easy Peasy Keto. Ketovore cured my stage 3B chronic kidney disease. Do it. And I know Temple is probably just like me. I have seen so many hundreds, really thousands of comments from people who started either a low carb diet or a ketogenic diet or ketovore or carnivore with some degree of chronic kidney disease, either stage 1, stage 2, stage 3A or 3B, even stage 4. And they said, hey, man, after a few months on this diet, my kidney function actually improved, even though I was eating way more red meat, way more protein, and way more healthy saturated animal fat. My kidney function improved. And so I think it's important for people to understand, because if you have chronic kidney disease, Temple, this is your one life. And you're like, okay, I see these people on YouTube talking right now, but this is my one life. And my doctor, who I love and respect, told me to drastically cut back on red meat because it was bad for my kidneys. What am I supposed to, how am I as a patient, what am I supposed to do with that? Have you encountered anybody that you counsel as a dietitian that are like, yeah, but my doctor told me specifically to cut back on red meat or animal meat or just protein in general? How would you counsel somebody like that to help them understand, yeah, I know your doctor said that, but they're just wrong?
Yeah, you know, and I would at first explain that I used to be the dietitian that gave out poor information. And so I had a lot of people that came to me and I was giving out some of that same type of rhetoric about saturated fat and high protein diets. And so I want people to understand that we are very fallible. We are human as well. And a lot of times, you know, you may be talking to a doctor or dietitian or someone else who's just not up to date on the research. And so I would encourage you to be a citizen scientist, as we would call it, and look and dig and get second opinions and ask around, because like Dr. Berry said, this is your life. We can tell you what we see and what we know to be true, but I would encourage you to also dig for some answers yourself. And I think you'll find them just like we have, right? The light turned on for us and we'll never turn it back off in the way that we practice clinical care. And so just understand that I was once that dietitian giving bad information. Dr. Berry, I don't know if you were ever that doctor giving bad information, but
yeah, absolutely.
You know.
In the first few years of my medical practice, from 2000 to about 2004, I would have repeated this medical myth to my patients as well. I would have said, yeah, you got to cut back on the red meat and saturated fat. You got to stop the bacon. You've got chronic kidney disease, because that's what I was taught as well. We didn't have much nutrition education in medical school, but definitely that was covered, that if you have any chronic kidney disease, protein is bad. You got to limit their protein and tell them to drink lots of water. And now, knowing what I know, looking back, it's like I would love to be sitting in that nutrition class and say, could you show me the research showing that healthy animal protein is bad for human kidneys? And also show me the research that drinking lots of extra water is actually good for human kidneys. I would love to see that research. Now, I'd have probably been kicked out of the class because they didn't like a lot of backsass in medical school. But I think that it would have been educational, not only for the other 174 students in my class, but also for the professor as well, because they were repeating the medical myth that they had been taught, just like you did early in your career and I did early in my career. But that's one of the main goals of the American Diabetes Society, is to start to teach doctors, and we're already doing that at a very limited scope, because we haven't raised the money that we need to raise yet to start putting out educational materials, not only for practicing doctors, but also for medical residents, for medical students, for pre-medical students, and for people who are in schools of dietetics and nutrition, to say, hey, here's the American Diabetes Society, and they're saying, show us the research. Where's the research at proving this? If you cannot show us the research, then please stop saying that animal protein is bad to eat if you have chronic kidney disease.
Another thing I would add to that as well, for everyone to understand, is oftentimes medical literature, medical textbooks, the curriculum that we're teaching in our schools, even to dietitians, pharmacists, the whole gamut, is usually about 15 to 20 years behind the updated research. So there's a really high probability your practitioners or clinicians are behind if they aren't purposefully staying up to date, right? And so just understand that most of what a lot of us were taught was far outdated, even to begin with, in the curriculums in the medical literature and textbooks as well.
Yep. And here's another very common medical myth that many doctors and dietitians believe with their loving heart, because doctors love their patients. They want to do the best thing for them. But many doctors believe incorrectly that eating meat has been proven to increase your risk of developing colon cancer or heart disease or some other cancer. And Walking Trees ask about this because Walking Trees may believe this myth currently, but the problem is that this has never been proven to be true. There is a lot of observational research that shows a possible weak association between eating meat or red meat and colon cancer or other types of cancer, but there's never been a single research study ever conducted that showed a causal relationship between eating red meat or any other kind of meat or egg and an increase in colon cancer or any other kind of cancer. And Walking Tree says until the meat causes colon cancer. And so causes, that's the word where you made your error, Walking Trees, because there's no research that shows a causative relationship between eating meat and colon cancer. There is no such research. And so I would encourage everybody watching this, if your doctor says, oh, got to cut back on the red meat or other meat because that causes colon cancer, say, well, gosh, doctor, I was just watching a YouTube live and they said that there's no research to prove that. Could you print me out a copy of that research when you get a chance? Because I'd love to read that. And either that's going to cause that doctor to just ignore you and move on and not talk about it anymore. But what I hope would happen is when the doctor gets home, they would say, yeah, let me look that up. And then when they look it up, they're going to go, huh, There is no research. I probably should stop telling my patients that and tell them to just eat red meat because it's very low in carbohydrates, especially all my patients with diabetes. They should eat more red meat because that's going to, by definition, cause them to eat fewer carbohydrates and thereby improve their blood sugar and their A1C. What do you think, Temple?
No, I couldn't agree more. It's all, observational studies, and they also rely on extremely inaccurate food frequency questionnaires that look for associations. This is certainly not cause and effect. And a lot of dietitians participate in this. But these food frequency questionnaires are so inaccurate, and they don't account for any of the co-founding factors either. They don't look at, people who may be eating more red meat, but also smoke or also drink multiple glasses of alcohol a day, or they may be sedentary and eat more processed foods. And so there is little to no evidence, especially with fresh meat or anything like that. And so I couldn't agree more. I think that looking at the research that we do have in context of insulin resistance, inflammation, and obesity being linked to colon cancer is so much stronger when you compare the two.
Yep.
It does not. This again, we could add this to our list of, you did add it to your list when your book, Lies That My Doctor Told Me, of nutrition myths that truly I'm ready for them to go to the grave, because this is a constant battle as well. But you're absolutely correct with the research studies. It's poor.
Yep. Now, I want to tell people about a new addition to the American Diabetes Society's website. Temple and Michelle and our other dietitians have been working feverishly, and they now have a large selection of ADS approved recipes on the ADS website. And so tell us about the recipes, Temple. How many do you got on there now? Do you have more coming? And what's the range from cheap and quick to expensive and convoluted? What kind of recipes can people expect, and how would they find them on the website?
Yeah, so just go to our regular website and you can find that in a tab. I will tell you, there is something for everyone on their website in regards to recipes. We have everything from keto carnivore style desserts all the way to savory, to appetizers, to simple 5-minute meals. We are going to continue to expand our recipe list. And if there's something that you guys would like to see, please drop it in the comments as well so that we can put that on our list. I think that's the beauty in working with multiple dietitians who have the same values, but kind of different perspectives, is you're going to get a lot of different takes on this in terms of recipe, variety, etc. And so I think this is a great place, especially if you're new to this and you're kind of like, well, I don't really know where to start. Start with our website, go to the recipes tab, print off, copy, paste, whatever you want to do, and start incorporating some of these. Again, you'll find something for everyone on there, something that you may want to take to a party, or even just a normal meal you can make at home.
Yeah, absolutely. And also another new addition to the American Diabetes Society's website is meal plans. We now have meal plans that you can download for free. We have Mediterranean inspired, meat lovers, quick and simple, vegetarian, low carb options, budget friendly meals, family friendly meals, classic low carb, and a grocery shopping guide. And you can download all of these for the low, low price of free $99. You guys, the dietitians, you guys have been so busy because the recipes are beautiful. And we've tried a couple of them here at home, and they're absolutely delicious. And just to be clear, all these recipes are free. You just go to AmericanDiabetesSociety.org, and you can make that recipe for free. You can download multiple different meal plans depending on which way of eating you want to try, and whether you're on a budget or not. Whether if you need a grocery shopping guide, you can literally download that and print it out and take it with you to the supermarket. I just want to give some major kudos to our dietitians. You guys have been busy. I haven't checked that part of the website lately, and I was checking it the other day. I'm like, man, you guys have been busy. It looks beautiful.
Yeah, it's our honor. I think having a place to start for everyone, no matter if you're 10 years into your journey or you're like, I see this live and I want to do this tomorrow. We want to know that you're supported. I don't think there's any dietitian that is participating in this that wouldn't be willing to answer questions and all of the above. So we just want you guys to know that we want to give you what you need to be successful in this. So let us know what that is, especially in the comment section. We're looking at all of that.
Absolutely. And if you have a question for us, type it into the comment section. Put 3 capital Qs at the beginning, just like Ravindra did here, QQQ. That way we know it's a question, not a comment. And Ravindra says, can you suggest some vegetarian, high protein, low carb recipes? So like I just said, there's a vegetarian meal plan that's going to by definition be higher in protein because it's very low in carbohydrates. But talk more to Ravindra and tell her what we've got on the website that's going to help her with her vegetarian diet.
Yeah, it kind of depends on if you're ovo, lacto, what you're doing there. So let us know because we're happy to help with that. But, halloumi and zucchini skillet, cottage cheese, egg bakes. I know that's eggs, but paneer and cauliflower curry, protein packed keto smoothies. I mean, eggplant lasagna. Again, you name it, you'll find it there. So go check us out and then give us some feedback and let us know. But I think you'll be really happy with the vegetarian options and meal plans there as well.
Yeah, I totally agree. I love the meal plans that people can download and print out for free. And everybody, I want you to go to the American Diabetes Society.org, the website right now, and check out the recipes, check out the meal plans. You can download them, you can save them. And then up in the top right-hand corner, there's a donate button. And while you're there, donate $1, donate $5, $10, 20, 100. Hey, 500 if you got it, But I don't want anybody to donate money that they can't afford. But if you can afford it, please leave a donation that does not affect your finances negatively. Because if we can raise enough money, we're going to start reaching out at a level that we've never been able to before. But it all hinges on the money. Let me just also add that none of the doctors and dietitians on the board of directors receives a salary. None of us make a penny from being on the board of the American Diabetes Society. The ADS does not reimburse our travel. We do not get a check, a stipend, bonuses, none of that. Not a penny goes to any board member. Also, the registered dietitians who are so active on the ADS for the recipes and the meal plans and just brainstorming how we can help people with diabetes, they don't receive a penny in remuneration. There's one person that gets paid, and that's our social media manager who gets paid to promote this message out for all the world to see. That's the one and only person who gets a check from the American Diabetes Society. So if you can donate even a small amount, that's going to help go a long way towards helping us help people with diabetes know the truth about a proper human diet, a Mediterranean diet, a vegetarian diet, low carb, keto, ketovore, carnivore, even a lion diet. Let's see if we've got another questions. Michael says, what about the drugs, Ozempic, Mounjaro, and then Wegovy? And so there are several board certified practicing doctors on the board of the American Diabetes Society. And all of us are pro pharmaceutical when that is indicated and when that is necessary and needed. We're not anti-drug. We're practicing physicians. There are cases when the only option for a particular malady or diagnosis that you have is a pharmaceutical. That sometimes is entirely optimal. But what we don't want is for people to think that there's no option except pharmaceuticals. Okay. And so there are people with severe obesity and there are people with severe type 2 diabetes who are going to benefit from at least taking a low dose of Ozempic or Mounjaro for a short period of time. But what we here at the ADS try to educate these patients on is that, yeah, we're going to do a low dose for a few months to kind of, it's almost like a quick start or a get out of jail free card, right? Or a little bonus is we're going to help you start getting the pounds off and start getting your blood sugar down while you are cleaning out your pantry and cleaning out your cabinets and cleaning out the fridge and the freezer and filling up your house with real human food, because that's the ultimate answer for diabetes. We want to be very clear. We do believe in the judicial use of pharmaceuticals, but we do not believe in the blind, thoughtless use of high doses of pharmaceuticals while ignoring your diet, which, if you're type 2, your diet is what's causing your diabetes, right? And so none of us, I don't think, would advocate, oh yeah, just eat whatever and take a high dose of Ozempic or Wegovy or Mounjaro. None of us are going to advocate that. We're going to talk about your diet, because that is the biggest thing that you need to be thinking about and talking about. What do you say, Temple?
Well, I was going to add to that too, this is the number one diet and therapeutic approach for after these medications and while you're on them as well. And I think that gets missed a lot when the GLP-1s get brought up. But if you want to retain muscle mass on these medications and afterwards, you should be low carb, keto, carnivore. It's very protein first. And so that is the whole goal. If you want to use these medications in a way that most of us believe is healthy and sustainable long-term, being able to come off of them without weight gain rebound is huge. And so protein first, obviously we are pretty much all encouraging resistance training. And so the keto carnivore lifestyle sets you up for success when using these medications for life, and not just the 3 to 6 months, 9 months, 12 months that you're on them. And I really want to emphasize that, because I think we all probably get a lot of clients who have rebound weight gain from these meds. And so, keto stabilizes blood sugar and hunger without a drug. Keto preserves muscle and metabolism without a drug. It eliminates the food hunger without a drug. And so it is natural to understand that this is the bridge for coming off of these medications and even being successful on them.
I totally agree. And I just wanted to make sure Susan understands we use Stripe to accept donations. It's one of the safest donation platforms on planet Earth. It is very, very safe. It's as safe as online banking. And then also somebody said that they tried to scan the QR code. Is it right there? Am I pointing at the right place, Temple? I know it on our screen, it looks like it's over there, but I think it's right here. And so a lot of people may not know how to use that. So what you do is take out your phone, turn on your camera, and then you point that right at the QR code. And then a yellow or golden button will pop up. You click that, and it's going to take you right to the American Diabetes Society's webpage, donate page, where you can donate anywhere from just a little bit to a lot of bit, depending on what you have. And so you can either type in the web address and go there, or you can use the QR code up in the corner of the screen. But it's very, very secure. We use Stripe, and then all of the money goes into the American Diabetes Society's bank account, which is at Chase Bank, which is one of the safest banks in the world. So yes, your donation is very, very secure and safe. Let's see what else we've got here. Here's a question from Amanda. Can someone put a link in the comments periodically for people to be able to give? I'm unable to get the link to, oh yes. Okay. So I'm going to type it in to the, I'm going to type it into the comments right now. So if the QR code's not working for you, and while I type this in, Temple's going to tell you something important.
Yeah, I also sent that to you via chat if you wanted to just copy and paste it in as well. I did see a question about dietitians and maybe some of the things that kind of goes along with why a lot of them are still kind of on this professional rut, I call it, of giving poor advice. And number one, I already talked about, the education pipeline is very outdated. A lot of dietitians are still taught the guidelines that we know not to be true and helpful. And so understand that just like physician curriculum, in a lot of ways, our curriculum is very outdated. Most dietitians are practice and protocol driven. When I worked for the VA hospital, I had a list of X, Y, and Z things I could say. Deviating from that can get you into trouble when you work for institutions that kind of have that power and industrial influence over you. There's also obviously a fear of liability and professional backlash. So you have to understand that with anyone, right? Physicians, pharmacists, dietitians, all, we're trained to do no harm. And the kind of fear of God is put into you to some degree of like, if you do something out of the lines of what we say, we'll come for your license. And so a lot of dietitians fear that as well. And then of course, there's no incentive for a lot of dietitians to have updated knowledge. I have my own health journey, which was my incentive to get with the program and figure out why traditional nutrition education wasn't working for me. And now my incentive is you guys and healing and reversing type 2 diabetes. And so I think a lot of those issues cross over with physicians as well. But that's just a little bit of the dietitian background of why so many are still stuck in this kind of outdated rut.
Yep, I totally agree. And I think that every single member of the ADS board and the dietitians, we all came to this way of eating because of a health problem that we ourselves were having. For me, I was severely obese and had pre-diabetes. And this way of eating over the last, 12, 14 years has completely reversed the pre-diabetes. It's gone. I have a beautiful A1C. I think it was 5.4 last time I checked. So no sign of the pre-diabetes. It's gone. It's cured. It's reversed. However you want to phrase it. Different people are comfortable with different phrasings. But also, I used to be 297 pounds, and now I hang out at about 225, which I'm very happy with. At being 6'3.5", I'm very happy with that weight. If I could snap my fingers, would I lose 10 more? Of course, wouldn't we all? But I'm at a very healthy weight, and really, probably more importantly, a very healthy waist to height ratio, which is a great way to measure your overall metabolic health if you can't afford to go to the doctor or you don't have time. Temple, what has low carb, keto, carnivore, what has that done for your health personally?
Yeah, very similar situation. I was 70 pounds heavier than I am now. I was infertile. I had PCOS, which is essentially diabetes of the ovaries, not much different. I was also pre-diabetic. I had an A1C of it was horrible. I was 21 years old and I couldn't have a baby. And it just was really, really heartbreaking for me. And Virta Health, which many of you probably know about, did a study at the hospital I worked at. And that is really what opened my eyes. I lost 70 pounds, have kept it off, got pregnant naturally. My last, A1C was like 5.1 or something. Fasted insulin is 3, and I've honestly just never felt better. I'm 10 years older. I'm 32 years old and I feel fantastic. And aging is a pleasure and a gift now. And so it didn't used to be that. And so it turned my life around. And so, like I said earlier, once you see it, you can't unsee it. And when you see people living a quality of life that isn't their best, it's heartbreaking. And I think that's what drives a lot of us.
Yeah. Somebody said they would have never guessed that Temple was 70 pounds heavier. You can actually, I think, go on her Instagram and just scroll back. And every so often she probably for personal motivation, but also to help motivate you guys as well, she posts one of those fat pictures alongside what she had, her beautiful self right now. And so a lot of us do that. I don't have a lot of pictures back when I was a severely obese doctor because I was very self-conscious because I've always been fit and athletic and very slender. And then all of a sudden in my mid-30s, I was like, and so I was not happy having pictures made. So I only have one or two, and I'll see if I can dig one of those up and post it. But let's see. Oh, okay. Here's a good question and this brings up compared to what? And that's what I want everybody to start asking themselves. And AIM says, what about drinks like bubbler? I'm not familiar with those. Did they mean bubby? Is that so? Anytime you ask a question like that, Ames, my response is always going to be compared to what? So let's just kind of walk through the hierarchy. Temple, is Diet Coke okay? Well, compared to what? Compared to regular Coke, yes, Diet Coke is a great improvement. Now, is it completely safe and harmless? Maybe, maybe not, right? Some of the research is equivocal. What about Zevia with a Z? Is that okay? Well, compared to what? Compared to Coke and Pepsi and Mountain Dew and Dr. Pepper? Heck yeah. I absolutely want you drinking the Zevia. If you're currently a Dr. Pepper or Mountain Dew addict, I want you to switch to diet of whatever your favorite poison is. Do that for a while, then try to switch to Zevia. But for me personally, long term, I want you to try to slowly keep decreasing the amount of any sweetener that you put in your mouth, and try to keep moving back towards more naturally occurring beverages like water, sparkling water, black coffee, unsweet tea. Well, what's your take on that, Temple?
Yeah, I completely agree. I tend to just want to meet people where they are. What's the next best step that you can take today for a better, healthier?
Baby steps are fine.
You know?
Baby steps are fine.
Yep. So I completely agree. What's the next thing that we can get you to? I would tell people that, even 0-calorie sweeteners can cause cravings in somebody, right? A lot of people struggle with that sugar dragon, even using stevia, monk fruit, allulose, these types of things, because it's your brain reward pathways don't care about calories, right? They taste it, it's sweet, it's, a cephalic phase response with insulin, and it can sometimes cause you. So I think I would just exercise caution with some of those things. If you're constantly needing them and you find yourself craving and wanting and that addictive type behavior, that is where my red flags go up. But again, what's the next best step, right? If that's a bridge to get you to real food, so be it. And I'm totally happy. And I want this to be realistic for you long term.
100%. Totally agree. And so wherever you're at right now, it's completely fine, depending on your personality style. And you know what that is. I don't know, but if you're like, you know what, I'm going to go carnivore tomorrow, that's fine. If that's your personality style, then do that. But it's also fine if you're like, well, I'm currently just eating whatever, and I'm going to try to start slowly transitioning to eating more real whole foods and more lower carbohydrate options, because I don't think I can just go straight keto or straight carnivore or straight carnivore. That's fine. We love you. We're here to support you. If you're like, I've been eating just standard Western junk, I'm going to try to do the Mediterranean diet that's just real whole, real foods. We are here for you. That is a great, great change, great improvement. That's the first step. And I say this every day, but let me say it again. Just taking that first little step, eliminating the Dr. Pepper and replacing it with something that's less bad. Huzzah. Eliminating the honey buns or the ding dongs or the donuts, and even replacing that with whole grain bread. Huzzah. That's less bad. Yes, you are on your way to better health. Keep slowly making those changes every time you go to the supermarket. Buy a few more real whole foods and buy a little bit less ultra processed junk. Your body's going to respond to that. You're going to get a little healthier. Your blood sugar is going to come down a little bit. Your weight's going to come down a little bit. Keep going. Now I want to address one more comment, and then we're going to turn this over to Shayna Husson, our registered dietitian, and Dr. Mariella Glant, who's a board certified endocrinologist and on the board of the ADS, and we're so proud and thankful and happy that we have her. Brian says, what happened to the Hippocratic Oath that doctors have taken over institutional rules? Now, it's going to take me a minute to answer this, Brian, because first of all, I have to tell you, there's no conspiracy. Your doctor's not on the tape, okay? Your doctor went to medical school because they were called to be a healer, to be a doctor. Shayna and Temple and all of Michelle, our dietitians, they went to school to help people improve their health. Okay. Every dietitian went to school with that goal. Now, the problem with maybe your doctor, Brian, your doctor feels like they're still upholding that oath by following the guidelines from other associations and organizations, or by recommending a vegan diet or recommending this diet or that diet, or saying cut back, don't eat bacon, cut back on red meat. They believe in their heart of hearts that they're giving you good nutrition advice. That's the problem, is they're not trying to mislead you. They're not trying to make money off you. They truly believe that, just like Temple believed that years ago, and I believed that years ago. If you had come to and saw me as a patient back in 2001 and you were overweight and type 2 diabetic, I would have said you need to join Weight Watchers and join the gym, stop eating the bacon, start eating lots of whole grains, start drinking fruit juices and fruit juice smoothies. Not because I was trying to harm you or trick you or make money. I believed that was the best way for humans to eat back then. because I was ignorant and had not done this self-education process that all of us are currently doing right here today as a big group of people. Do you agree with that, Temple? And if somebody says, well, my dietitian told me to stop eating red meat and to eat lots of whole grain bread, and as a type 2 diabetic, that dietitian is not evil or bad or mean or anything. They just don't know better yet.
Right. You know, the oath says, do what's best for this patient. The institutions say, do what's in the protocol, even if there's a better way. You know, example of this is dietitians getting in trouble in institutional hospital settings for recommending a ketogenic diet. And it's happened. And so where a lot of us battle is navigating this gap of we can't practice the way we want with our oath, and we know there's something better. And this is why you're seeing a lot of us leave institutional settings. I think most of us have or are still working in it, but battling in it. And where you guys come into play with this is supporting organizations that help change policy, supporting organizations that have a new way and are supporting, you know, doctors, physicians, clinicians, all of that are doing things differently. And that's why we're here. And that's why we're asking for your help with all of this. Is there's a gap that we're trying to meet, and you guys play a role in it just as much as we do.
Absolutely true. Now, as I bring on Dr. Glant and Ms. Huston, I want to one more time ask everyone, please either shoot the QR code and donate $1, $5, $10, $20, $100, whatever you can afford to the American Diabetes Society, or there's a link in the show notes that you can click to donate, or in the chat, people keep putting in the address where you can go to donate. We need your money in order to reach the millions and millions of people all around the world who have diabetes and who are suffering from it. And we are the American Diabetes Society, but we're not going to keep this beautiful message of hope within the United States. We're going to share this with everybody, and we're going to share it for free. And we're going to be able to do that with your generous donation. So let me bring on Dr. Mariella Glant, who's a board certified endocrinologist. I'm not sure where in the world she is right now. Sometimes she's in New York, sometimes in Israel. And then Shana Huston, who's a registered dietitian with the American Diabetes Society. Hello, my friends.
Hello.
So good to see you again. I know you guys have both been super, super busy, as have all of us. We're going to turn this over to you guys and let you run and gun for the next hour or so. I encourage everybody right now, please, down at the bottom of the screen is a button that says share on your phone or on your laptop. Click that button and share this on as many different social media platforms as you're comfortable doing, because I'm telling you, these two professionals can help people reverse type 2 diabetes. They can help people with type 1 diabetes have a beautifully normal A1C. Pay attention, listen up, ask your questions in the comments. If you haven't already done so, hit the thumbs up or the heart. Make sure you're subscribed to this YouTube channel, because we're going to be doing more and more videos as time goes on. And I want you to be one of the very first people that gets a notification when we post a new video. Okay, Shana and Dr. Glant, it's all yours. Take it away. See you soon.
Thank you so much.
Hello, everybody. Hi, Dr. Mariella.
How are you? Good to see you.
Oh, you as well.
Well, we are, it's fun to see you here because we have a shared mission. We've been working and talking together for quite some time, and it's great to be here with everybody. I'm going to take this off because I'm seeing very blurry. There we go. Tell me, why don't we start by kind of introducing ourselves and talking about what we're doing? Do you want to start?
Sure. I'm Shanna. I'm a low-carb dietitian, and I'm on vacation this week, actually. So my background and my environment are a little bit different than what I'm used to. But I've been in the space for 25 years as a registered dietitian. And for a long time, I taught the conventional methods. And after a while, I thought, well, why aren't people getting better? And why am I struggling with my metabolic health as much as I am? And I developed insulin resistance following the conventional methods. So about 6 years ago, I left because, just like Dr. Barry and Temple were talking, it's hard to teach low carb, ketogenic, and the whole disease reversal process for type 2 diabetes in the conventional setting. So that's a little bit about me, and I'm so excited to be here with you.
Well, I'm Mariella Glant. I'm an endocrinologist, and I was trained in a very conventional way. I studied at Columbia. I did my residency at Harvard, and then I did my fellowship at Columbia. And I didn't learn much about nutrition. I learned a lot about medications and knew how to really control people's glucose levels very well with medications. But then about 10 years ago, maybe a little bit more, I came across this new revolutionary idea that we could actually reverse disease with diet. And that blew my mind. I mean, I just could not believe that it was actually as simple as that. And once I understood that type 2 diabetes is your body's just basically saying that it's rejecting glucose. And then if you take the glucose out, you can reverse the disease. It really changed the way I practice. And I was fortunately at that time in private practice. So it allowed me to test this, meaning, just started implementing this in patients after about a year, I think, of reading and being really convinced that this is the right thing to do. I started implementing this, and the results were so incredible that this became my modus operandus. And then I went on to become a founder of Ona Health, which is basically a virtual platform that helps people basically reverse their diabetes through this journey with a doctor and a coach, and really specialize in underserved communities. So this is me in a nutshell. So basically practicing low carb for about 10 years. So thousands of patients that we've reversed diabetes on. Mm-hmm. And that gives us a lot to talk about.
Yes. And I had that in my own health as well. Like when I had insulin resistance, I was thinking about food all the time. I would eat breakfast and think about what I was going to have for lunch. And I couldn't figure out, like, why is all this food noise in my head? And why do I feel the need to never feel satiated, even though I didn't have a big weight issue? So I think the interesting thing about prediabetes, type 2 diabetes, insulin resistance is you can't always outwardly see it in somebody. They may look really healthy, and that can, they have prediabetes, festering and getting worse day by day. And we'll talk a lot about how to prevent all that and start to reverse it, rather than just a Band-Aid approach that might be helping some symptoms, but isn't getting to the root cause of the issue.
Right. The interesting thing, right, is like when you go on vacation I sometimes loosen up the diet a bit, and then I'm like starving, and I'm like, oh, this is what it's like to be hungry. But after 10 years of eating basically a ketogenic diet, I forget what it's like to be hungry. So once in a while you're reminded, and you're like, oh my God, basically carbs really control us rather than the other way around, right? We're controlled by carbs. So it's really nice to have freedom. I really think that more people think that this diet constricts you. I think this is the opposite. If you're not restricted, you have freedom. And that's the beauty of having control of your life, that you decide when you eat and what you eat, and not because all of the temptations around you or you lose your health over this. So yeah. So what would you say is one of the biggest difficulties you encounter in treating patients?
Yeah. So like I said, I've been in the field for like 25 years, and I've had lots of different jobs. I've worked in employee health. I've worked in outpatient dietetics. I now own and run my own business because I wanted to be able to teach what I know is healing and helps people to thrive. But I would say for, most people, it's setting up your environment to be successful. And, like you were talking about being on vacation, like your environment is just so different. And, I think this is day 5 of me being on vacation. And it's like, I just feel like a little fuzzy in the head and a little bit, gut stuff going on. But I would say like that is helpful, like surrounding yourself with people who are going to help you and guide you, and then just setting your home environment up for success. And you know, a lot of it starts with education. Like, you don't know what you don't know. So that's why I love this organization and I love this platform, because we have a really easy to navigate web page where if you're like clueless and you're just like, I have no idea how to even get started with this, you can start on our website, get recipes, get meal plans, and just keep it simple. I think sometimes people get a diagnosis like prediabetes or type 2 diabetes, and they're like, oh my gosh, they just get so overwhelmed that they don't want to make any kind of changes whatsoever. So I would say just like keeping things really simple and starting with maybe 1 or 2 small things that you know that you can achieve, and getting used to those things. And then just make it easy on yourself, especially at your home, your workplace. We know, especially here in America, I know you're not always in the States, but we are tempted everywhere. I mean, you can't go in a gas station or a school or a workplace without being completely tempted with things that are not supportive of a low carb lifestyle and you know, chronic disease reversal. So I would say those 2 things, like just making really small, simple changes that you can get used to, and setting your environment up to be successful. And maybe you can expand on, you know, how to start going about to do that, and what you want to add to that.
Yeah, I think you're right. You know, people think, oh, ketogenic diet, something so complicated, and it couldn't be easier, right? It's just like piece of meat with salad, eggs with cheese, ham and cheese, or whatever. But it just breaking it down and realizing that it's just about real food. We don't need anything complicated. We don't need any substitutes. We don't need any fancy things. We can do this on any budget, and surprisingly so. And I think one of the keys is just understanding that. And so it takes away all the complexity. And this is not really a diet. This is a way of life, and we shouldn't. The more I think of it, when people think of it as a diet, they think of it as something very short-lived, and that's often a problem. What we have to understand is that it starts to become part of your identity, right? The more you do it, the more we are what we repeat, in a way. So once you start eating this way, you just repeat it. Next thing you know, when you eat something sweet, you're like, oh my God, I feel intoxicated, right? So it's just really a matter of just getting into a very methodical and a very, I think, don't become emotional about this, right? We take out the carbs, and this is what we do. It's not poor me that I can't eat carbs. No, lucky me that I figured out that taking out the carbs is what's going to make me healthy, right? And then just, you know, do it like you brush your teeth. Don't get angry because of it, but just kind of accept it. And it's something you do and the more you do it, the easier it becomes. And the more it becomes a part of our identity. So I really think that it's much, much easier than we think. And it doesn't have to be complicated, and it's not a fancy, weird diet. No, it's just real food, right? And that's all there's to it. That's really all there's to it. And understanding that, of course, that this comes with a lot of layers, right? Because we're like, but what about the fruit? Am I not going to be deprived of? No. We need to understand that your body is rejecting this glucose, and maybe it was okay to eat fruit when there was scarcity in the winter, when eating to fatten up like bears before the winter. But in this situation where you're overstuffed with energy, too much energy, there is no need. And we got to bring the insulin levels down in order to burn our own fat. So this is done by being, you know, very unemotional about it. What do you think?
Yes. And I think the simpler you can make it, the better. Like, even when I'm going out to eat, because we all go out to eat, right? Like I always find that I just feel a little off after I go out to eat, because you're out of, you lack the control of the food preparation. But yes, I can always find a hamburger. I can almost always find some sort of vegetable or a salad, leaving out buns. Like it takes a little bit of getting used to, but over time it just becomes second nature. And you just feel so much better that you want to keep going with it. But I saw an interesting question come in a few minutes ago. And I think it's a good one. And I think both of us can really talk quite a bit on this topic, but it says, this is from Susie. And she says, why does my fasting blood sugar go up every morning while I am still fasting? It goes up to 150 to 185 and stays there until I take insulin. I am on carnivore.
Good question, and a common one, actually. So I think this is actually one of the last things to fix itself, and it takes sometimes years. You agree? It takes sometimes years to fix this. And all of us have an increase in blood sugar in the morning because all of the hormones that are getting us ready for work and for the day are at full capacity. So we have cortisol, glucagon, epinephrine, norepinephrine. This is the way we get up in the morning. And cortisol especially starts to go up and peaks around 8 a.m. So this is, all these hormones will increase our glucose levels. Now, normally, if we're not insulin resistant, our pancreas secretes insulin to counterbalance this and keep us at a normal blood glucose. But because of the insulin resistance, we don't. So the glucose, we're not able to shut that down. We're not able to control that excess glucose production by the liver. And therefore, the glucose level goes up. And in people that are on carnivore or keto or even low carb, this might be the highest glucose of the day. So I don't pay too much attention to this. I ask them, please just check your sugar later. You'll see that your sugar is just great if you're really compliant with the diet. But in general, we see that it doesn't play so much of a role in the big picture. And it's just a sign that we're still insulin resistant. Now, one of the things that you can do to really minimize that is to have dinner early. Eating dinner early makes a big, big difference. So this is an easy thing to do. If you're taking medications, for example, like metformin, then a metformin at night will also decrease that glucose production by the liver in the morning. So you can take that metformin right before you go to sleep. It doesn't have to be taken with food, like a lot of people think. So, what are your thoughts?
I think there's a lot of confusing information about this because I get a lot of questions about this as well. And, I get a lot of questions, will a snack before bed help with this, to get a little bit more carbohydrates in my system so that I don't see that spike in the morning? And I've seen this actually like backfire on a lot of people. And as you were saying, a lot of it is just a metabolic flexibility issue where you're more insulin resistant already, and you get that morning response. But I think another thing that we need to keep in mind that people don't often think about, and I saw this in my own life, was that there are other factors that play a role in our blood sugar other than food. And even though carbohydrates are by far, and food intake in general, and how often you're eating, and insulin resistance, and all of those things are huge factors, we also want to remember that stress can play a role because we do have the stress hormones that are being released, especially in the early morning times. But I went through a really stressful time period and I saw my morning blood sugars climb and I didn't know what to do about it because I'm like, I'm following low carb. I'm doing intermittent fasting. I'm doing the timed eating. I haven't eaten in 18 hours. What is going on? And so I had to really work on my stress response and my nervous system as well. And just your environment where you're at, how you're taking in your food, the time of the day that you're eating. Sometimes we see that insulin resistance can be even worse at night. So as Dr. Mariella was saying, eating an early dinner can be super helpful because we are more insulin resistant in the evening. So for snacking, when we're eating right before bed, even though we could eat the same exact meal at 7 p.m. versus 10 a.m. and have a completely different response just because of the hormone interplays that are happening in our body throughout the day, and activity level. There's a lot of things that go into blood sugar management. But I like Dr. Mariella said, this is one of the last things. And I've seen this with people that I've worked with too, that morning blood sugar response can just be really stubborn. And it makes sense that it would come down after you take insulin because that is helping with blood sugar. But just know that it can definitely take some time, and that there are other factors that are coming in play with.
And in fact, the more insulin we take, the more resistant we become to insulin. So that would not be my first approach, right? But this is not medical. We're not giving medical advice, but in general, it's important to understand that as a concept, the more insulin we take from the outside, the more insulin resistant we become. So sometimes it's better to take less insulin and find other ways of decreasing the sugar, for example, exercise and the diet. And over time, we're going to see that improvement. But otherwise, the more insulin we take, the more insulin we need, because the receptors just downregulate. They don't want to, they're overwhelmed by so much insulin, so they're not even there anymore. So
for sure. All right, I'm trying to leaf through some of these other questions that we may, and bear with us because, of course, we just joined a few minutes ago and we're not sure exactly what's been answered.
I didn't see the questions, so you go ahead and read what you see.
Okay. I guess, this one is very similar. My fasting, this is from Maureen. My fasting insulin, I think she means her fasting glucose. My fasting glucose is still over 100 despite being carnivore. I imagine she means fasting glucose, because fasting insulin over 100 would be really high. What more can I do to bring it down?
Okay. Yeah. I'm guessing you're saying the fasting sugar, right? So again, same thing, right? I think for me, the biggest bang for your buck is finishing dinner really early. This is really an amazing tool for lowering morning glucose levels. That's the biggest bang for your buck. You're really not supposed to be eating when it's dark outside. We don't have the physiology for this. We never did this in the history of human beings, and because we didn't have light. So how could you cook when 200 years ago when nobody ate when it was dark outside? So our bodies are not really fit for this, and therefore, and actually every organ in the body has a circadian rhythm, and the whole digestive system does not do very well when it's dark outside. So easiest thing I would say is try stopping eating, say like 4 p.m., 5 p.m., and see what happens. See how that goes.
Yes. And I'm a huge proponent of intermittent fasting. I think most of us on the board in different ways for different people. And we can call it timed eating. But just like the earlier that dinner can be, I know in my own life, I feel the best, and this might not be an approach that works for everybody, but I feel best when I am done eating between like 3 and 4 p.m. And I know that that's not as socially acceptable as maybe fasting through breakfast every single day. And this is not every single day for me. But I wear an Oura ring and my sleep is so much better when I have an earlier time that I am finished eating, because like Dr. Mariella said, like we are not set up to digest food late at night. Our stomach acid decreases. We stop producing as many enzymes as we did earlier in the day. Your body's just basically like, what am I doing with this giant bolus of food as I am going to bed? Like, I don't even know what to do with this. So I think that it does go a long way. And I used to be one of those people. I know a lot of people intermittent fast. It's a really, hot topic, and there's a lot of merit to it for sure. But most people like to fast through breakfast and eat later in the day. And again, that can work very, very well for some people. But I've found in the population that I work with, and maybe you can talk about the patients that you've seen, especially women, like to have a little bit earlier eating window and be done eating earlier in the day in general is very helpful. And that can, we can kind of broach into the topic of snacking a little bit too. I know, let's talk about what do we start with our patients who are insulin resistant? Because I know for me, my very first thing that I start with, if somebody's kind of new to this lifestyle, is the nighttime routine. And for the reasons why we just talked about, not eating at night, not snacking. And like you said, our circadian rhythm is not set up to eat all of this giant bolus of food at night. So we first work on the night routine because we can't really set ourselves up for success with poor sleep and the snacking habits. So for me, I'm working on nighttime habits and snacking and eating well-rounded meals so that we can stop putting food into our system, constantly throughout the day and spiking the glucose and spiking the insulin.
Right. So two things. First of all, just going back to the intermittent fasting, the craze of intermittent fasting, people were eating, for it, they didn't really pay attention to the window. So everybody's like, oh, I do IF. Well, no, because if you're eating your first meal at 2 p.m. and your last meal at 10 p.m., that's not going to be helpful. Okay. And then also what you eat during those times, but that's a different question. So, how do I start? I actually start by, it really depends on the patient, right? If some patients want to go all in, and let's go. And even in those patients that go all in, I don't start with everything at once. I actually start with 3 meals, no snacking.
Yep.
And I actually start worrying about the timing of food later, but maybe the way you're doing it is better. But for somebody who's ready, we take out the carbs, no snacking, no more than 3 meals a day, and lots of fluids and the soup broth. If you're hungry, just have a cup of soup broth. And then I start to move the dinner earlier, and absolutely, because you see that the nighttime snacking, which is so common, right? You sit in front of the TV, it's like a reflex. People just eat. And this is such a bad thing. So I totally agree with you. I do it as a second step, but I think it's really, either way, it's about building new habits, right? So it's interesting that, but I find it easier for them. When people go all in, I think it's actually easier if they're healthy. If they have a cardiovascular disease or renal disease, then you have to go slow. But if you're healthy and you understand that you can be free, then it's very empowering to take the carbs, start drinking lots of fluids to avoid the keto flu, and then within 2 weeks you're like, oh my God, I feel fantastic, right? It's so empowering, so exciting.
It is empowering. And so many people go and get a diagnosis of prediabetes or type 2 diabetes, and they're told, like, these are the medication options you have, and this is a progressive disease that you're going to have forever, and we just have to manage it the best that we can. And this is what's happening to you, and you feel very helpless and out of control, and that's just what's going to happen. And I know in my own personal family, type 2 diabetes and polycystic ovarian syndrome are very, very rampant. And if I didn't practice the lifestyle that I do now, I know for sure I'd be overweight. I would be battling my blood sugars. I would be battling, I already had insulin resistance before my blood sugars went wonky. And that happens a lot. Like fasting insulin is often elevated for a long time before, wonky blood sugars or prediabetes are showing up. And there's so much you can do.
Yes, absolutely. I see here there is a question. How do I manage meds with working nights?
This is a great one.
Really good one. Except too bad we don't know what are the meds here, because it does matter, right? The different medications have different mechanisms of action. So we can't really.
I think it says meals. How do I manage meals?
Oh, sorry.
Yeah.
Okay. So, what I say? Have a good meal at 7 or 8 p.m. with a lot of protein and fat. Don't eat anything at night. Nothing. Zero. Just no, nothing. And then you drink, and this just works. This is really, really, already your body is in so much stress because the not sleeping, it really will throw you off. There's nothing, this is your job. This, you may not have control over this. But that puts you in such a disadvantage for metabolic health. But If you're on top of that, eating in the middle of the night, this is disaster. Okay. And completely just have a really good meal, high fat, good protein, satiated, a piece of meat with salad or not even the salad, or some kind of veggie that you want. But just make sure that you have, it could be ground beef, it could be lots of eggs, it can just something that you like. And then wake up when, work. You're not going to be hungry at all. You're going to be full go. And then you go to sleep. And then when you wake up, first of all, you could eat something when you get home. It's already morning. You can eat again, something light, go to sleep. And then that we have a lot of patients in Ona Health that work overnight shifts because it's the Medicaid population that works really hard and lots of difficult jobs overnight. No problem. This is a great way of dealing with it. So it really shows results. No eating at night. It's the same applies.
Mm-hmm. This is a huge struggle for a lot of people, and there are ways around it that I've worked with inside my academy, people who have shift work or they're working at night, and it's difficult, but not impossible. And this hits home for me, and it's kind of a hot topic for me, and one that I really am passionate about helping people with, because I just lost my mother not too long ago to fatty liver that progressed to cirrhosis, which basically fatty liver is due to insulin resistance. And it was, she was just told to watch it. And fatty liver is a little more challenging to diagnose because there's not just a definitive blood test that you can get. And by the time I knew about it and, could offer her some recommendations, it had already advanced to cirrhosis. And then not too long after that, she developed liver cancer. But she was a nurse for 40 years and worked a lot of night shifts and, was eating, her circadian rhythm was non-existent. She was eating at nighttime and sleeping during the day. And we can talk about our lighting environment a little bit too, and how that affects our metabolic health. Most people don't think twice about the lights that they're under, or natural versus artificial, and how that might be playing a role with their metabolic health and their blood sugar. But she was just set up for metabolic disaster.
Yeah. Nurses, really, yes.
Yeah. And now it's knowing that what I know a couple of years after the fact, I'm like, it all makes sense. She was not a drinker. I do want to put that in there too. She would have maybe 2 or 3 glasses of wine all year long. So a lot of times we get a fatty liver diagnosis and we think it's because of alcohol. And I remember when I first started practicing as a dietitian, and you probably saw this too, it was called fatty liver. We had to differentiate non-alcoholic fatty liver disease as opposed to, because before this, 50 years ago, we only ever saw fatty liver
from alcoholism.
Yeah. And now it's like we see little kids, children young who are drinking sugary drinks and a lot of fructose that is shunted to the liver, and the liver doesn't know what the heck to do with it.
It's a toxin. Mm-hmm.
It is, and it's making the liver toxic and fatty. But anyway, I digress. Going back to the whole night shift part, I can see why my mom had such a trouble with her metabolic health. But this is exactly what I would tell my night shift people and shift work people is get that good meal in before you go to work, especially if you're working night shift. And just like Dr. Marielle said, try not to eat during your shift. And I would say too, this works for some people, is if you can go to sleep without eating before you go to sleep, that can be helpful for some people too. And then maybe depending on when you're doing your shift, like wake up and have, if you have that 8 hours before you go in at nighttime, again, maybe you can break that into two different substantial meals, just so we're not eating at nighttime, because it's just, it is so detrimental to your body and your organs, and just what is going on with all this food at night.
Absolutely. I think there's another question, right?
There were a couple.
One about
and there's a good one I wanted to pop back to. Yeah, there's one on the screen that you can read. If you see
Perimenopausal.
from Rhea. Okay, so Rhea says, I'm struggling with my weight and I'm perimenopausal. I'm 49. I'm perimenopausal as well. I get the shakes when I fast. I avoid lights due to migraines. My circadian rhythm is messed up. Any suggestions? Yeah, so you could go ahead and answer, and then I'll definitely. I am a huge circadian health. I've worked that into my practice recently, and it's been very helpful for women.
Yeah, go ahead. You can answer that first.
Okay. So as I was saying before, a lot of times it's easier to start with a nighttime routine, because if your circadian rhythm is messed up and you're having trouble getting up and getting morning sunlight, we have to deal with the nighttime routine first, because I can tell you all day, like, oh, seeing the sunrise and getting out for morning light is really helpful for your circadian rhythm, which it is. If you're not feeling like getting up because you're not going to sleep at night and you're not getting restful sleep, I think it's more helpful to start with that. And so I don't have them with me right now, but I have found and I have the luxury of having a somewhat predictable schedule, right? So I like to be in bed by like 9:30, asleep by 10. And there are a lot of studies that show, and we can talk a little bit about human growth hormone too. That is a huge, that plays a huge role in recovery and just being able to reverse insulin resistance as well. Mm-hmm. But that's kind of peaking between like 10 and 2. So if you're somebody who's going to sleep pretty late, I always try to let's work on, like I just worked with a client last week who's going to bed at 2:00 in the morning. Like, let's start inching that back. And a lot of it has to do with the lighting that you're exposed to. So if you're under a lot of blue lights, you're on your computer or your phone, or you're watching Netflix or whatever it is, your body is releasing cortisol in response to that blue light. So, right now I'm staring at my computer. And so that's going to play a role in my hormones, which we don't think about. And we've just, in our modern day and age, is so different than what it was even 100 years ago. Video games, whatever it is, it keeps you up. And I work with a lot of clients who are so tired at night, but they feel wired, that wired but tired feeling. Like I work with a lot of women, especially in my age group, and we're trying to do it all. And it's like our kids go to bed, or we get home from work, we finally have the kitchen cleaned up, and it's 8 or 9 o'clock, and we just want some time to ourselves. So but popping on some blue light blocking glasses after sunset, I know, like I'll admit this, like my family still makes fun. Like my husband makes fun of them. He's like, "What are those orange glasses?"
Orange glasses.
Those are ridiculous. But I don't care. Like I'll go through the airport with them if I'm flying. I don't care, because they help so much, and they just dim that blue light if it's in your environment, and it just helps you to fall asleep and stay asleep. Because if that blue light out of your environment, like Dr. Mariella was saying, we did not have lights at night after dark 100 years ago. We had, once there's no light out, we should not be exposed to that anymore. And so getting the blue light out of your environment is so helpful, just to let melatonin take over. So melatonin helps you fall asleep, stay asleep. It's secreted by the pineal gland. We also have melatonin in our mitochondria, but it's not going to be secreted if you're exposed to all these bright, crazy lights. And so we're not sleeping well. So we're more insulin resistant. And there's studies that show you're 50% more insulin resistant if you get 5 or less hours of sleep a night. And so you do that chronically, and all of a sudden that's playing a huge, huge role. So if we can get, people falling asleep, staying asleep earlier, and all of a sudden we want to get up and watch the sun rise, and we want to get out for some morning light. And that sunrise is so helpful, because that's when blue light is coming into our environment, but there's also some red light. And I know I'm getting, kind of. It's
interesting. It's interesting.
But it does help with shutting off melatonin and raising cortisol. So then we want to get up and go. And then there's other light that's coming into play. But I will just say this, the more morning light exposure that you can get, the better off you are hormonally, because the light coming in your eyes and striking your skin is telling your brain what time it is and telling to run all those processes that should be going at certain different times. Like we talked about, our different organs having different circadian rhythms. And if you're outside and you're getting those signals, all of those processes and hormones are going to, neurotransmitters are all going to be released and running at the correct times.
Yeah. Agree with everything you said.
So it sounds like circadian rhythm stuff and lighting, it sounds too simple. And I like a lot of women say, okay, so you're just telling me if I go to sleep earlier and I go and I watch the sunrise and I get 15 or 20 minutes of light exposure in the morning, on a walk or whatever it is, you're telling me that that's going to make a big difference. And yeah, it does. Like once you start practicing it. And I know sometimes it's a little bit more challenging to put these things into play, but just knowing that they make a big difference, again, is all the things that we can learn about that make a big difference with our metabolic health that are in our control.
Right. That's the fun of it. Right.
Yeah. It's just so empowering.
Right. It's just the adopting it is the key, right? Because one thing is to know it, and the next thing is to actually go to sleep early, right?
Mm-hmm.
Which is a completely different story.
Yeah, and I get it. I have
perimenopause, etc.
Right. I have 3 children. I, run a business. I get it. It's like sometimes you just want to stay up later to have like a quiet house and get some time to yourself. But it can be hugely detrimental, especially as we go through perimenopause and menopause.
Right. So we see what other questions are coming up. Okay. All right. If we eat more protein, okay. It's actually pretty hard to eat too much protein, real protein. If you eat, it's our daily recommended allowance of protein is very low. It's very difficult to overeat protein if you're eating it in its natural state, not as a shake. If you're eating protein in the way it comes in nature, it usually comes with fat. And together, these two things lead to satiety through hormonal pathways, not just by, with carbs, we feel full when we've stretched mechanically the receptors in our stomach. That's when we feel full. But with protein and fat, we have hormonal signals says, hey, I'm full. I've eaten enough. So it's actually really difficult to overdo it with the protein. And too much protein actually turns into sugar. So that's, which then maybe gets stored into fat, but first it'll be turned into sugar.
Yeah. And I've seen this more so, and just the blood sugar response in general. Like you were saying, if it's real protein, especially when it's packed with fat, like chicken thighs versus a chicken breast, or, eating ground beef that isn't 96.4, like you're eating 80-20 ground beef instead. When we're going into like the powders and things that, and I'm not saying there's not a time and place for these things. I use clean protein powders and collagen every so often, but to make them your mainstay, that might have a different effect on your blood sugar because it's so powdery and it like hits your bloodstream a lot more quickly than something you have to chew. And pairing protein with fiber is very helpful as well, just to slow that digestion process down. But it is true, like you can get to the point where protein is going to be converted, but it's taxing for your body to do that. Like your body doesn't really want to use protein as an energy or fuel source. It wants to use carbohydrates first and fat second if the carbohydrates aren't there. And to convert, for the liver to convert the protein into carbohydrates is a very taxing thing for it to do.
Oh, yep. So how do we get enough protein in, right? Is the next question.
Mm-hmm.
Animal products.
Yes, I know. I put a lot of information out, and I know that all the dietitians on the ADS board, we put a lot of information about, because I know it's tough. Like I I try to get 100 grams of protein in a day for myself. And that's hard. Like, you have to think about it, and you have to make your meals animal focused. And, I'm eating animal meat or eggs, or I do well with dairy products. Not everybody does. I live in Wisconsin. That must be that must be why, the dairy state. But anyway, those are my mainstays, and I try to build my meal around about 50 grams of protein, and add in fiber from there. But there's a lot of recipes on the ADS website on how to get that amount of protein in. And I would say, shoot for this most days. If there's a day you only get 50 or 60 grams of protein in, it's not the end of the world. Like, your body recirculates a lot of amino acids. People don't think about that. They think, oh my gosh, like I have to have 100 every day. But it actually recirculates a lot of amino acids. So if there's a day or two here or there. But I know I have a protein guide on my website. I think Temple, Michelle, Shannon, the other dietitians on the ADS, we all have protein guides, and all of us put out information on our Instagram pages as well that you can find.
But I would say that I'm not personally, or the way I treat my patients is that I don't count anything. I think that you shouldn't get obsessed with exactly how much protein you're eating at all. You should just eat real food, animal-based, and when you feel satiety, that's it. This is a way of living. This is not a medical thing that you need to be counting protein grams for the rest of your life. I think that in and of itself leads to a lot of stress. That's totally unnecessary. So once you understand, I can eat this, I can't eat this, end of story. And then it just becomes much easier to do. So I'm really not a fan of counting anything. And as long as you stick within the guidelines of real food without the carbs, it's actually quite easy. It's really rare that you have to get so granular.
Precise. Yeah. And like we were saying, before we started eating this way, like higher protein, higher fat, lower carb, like there's just food noise in your head all the time because your body's not suppressing those appetite hormones. And I know with me, when I'm working with clients, I might say, like, let's do, shoot for this many grams of protein just to see what it looks like. But after you eat that meal, like, okay, I think I'm hitting my protein target. And then you feel it in the satiety mechanisms for sure.
Yeah.
I think we should probably you for sure. There was a question about GLP-1 in here somewhere.
Yeah, I don't know where it went.
Oh, I lost it. But that would be a good one. Did you find it?
No, I'm not sure where to look. But we can talk about GLP-1s because everybody's talking about GLP-1s. And there will be other things coming down the pipeline, and there will always be something else, another magic pill. And don't get me wrong, I have prescribed GLP-1s since 2005. I have thousands of patients on GLP-1s. So I know these medications very intimately, and I use them sometimes as bridges. Over the years, I became less and less enamored with them, especially as my understanding of low carb increased. And I understood just how powerful low carb diet is in satiety. You don't need a GLP-1 when you're eating keto. In some patients with very uncontrolled diabetes, it can be a very interesting, wonderful tool. And people who have massive cravings and can't start the diet, it can be a very good tool. It does work in many people. In other people, it doesn't work. Or in some people, it works, but then you need to add again you need to increase the dose. So it's like a drug, and you become less and less responsive to it. So over time, you get to maximum doses, and then you're stuck. Now, there's nothing to do, and you don't have any tools. But if you're doing a low carb or ketogenic diet, carnivore, or any of these, with any of these options, you don't really need a GLP-1, or it allows you to come off of it. Now, it's it does have a role, and some people, it can be quite critical to get them started. So I do use GLP-1s. But, you know, we cannot win this war with GLP-1s if we don't treat the root cause. It's just another Band-Aid. And it's a Band-Aid that is really expensive. And it's a Band-Aid that has a lot of side effects and that doesn't make you feel good. Okay. The difference is that, you know, when I suppress my appetite with GLP-1s, I can lose weight, but I will lose weight by becoming deficient in calories. That's not what I want. I want to decrease my weight by decreasing my insulin, which, by the way, it's what GLP-1s do. GLP-1s do decrease insulin because you're eating so much less. You're not eating as many carbs. So that's why your insulin does go down. But there are other mechanisms as well. But the bottom line here is that because of the mechanism, we also lose muscle mass. And when we lose muscle mass, that's very difficult to regain. And also it means that if I stop the GLP-1, I will rebound because now I don't have the mitochondria in the muscle to use up the glucose. So I will rebound and gain a lot more weight. So GLP-1s also, because they suppress appetite, they suppress it across the board. But in my experience, they particularly suppress eating protein. And that's a bummer when you're trying to get nutrition in. So people are actually malnourished. And you know, all these like Ozempic faces, et cetera, it's not a joke. It's because people are malnourished. So they have decreased their nutrition. Yeah. And so that's one way of losing weight, but it's not the way I'd like to lose weight. Mm-hmm. And so sometimes, you know, they're incredible tools, but you might be able to get away with a low dose. A ketogenic diet allows you to lower the dose and to eventually stop it.
Mm-hmm. Yeah. And it's interesting because people that my population, my community, people I've worked with, they don't realize, number one, they have GLP-1 in their bodies. Like it's not there, but there are natural ways to increase it as well. Mm-hmm. And a lot of times the way that we've gotten ourselves into the mess of chronic lifestyle disease is because we're doing the opposite of what actually helps to increase the GLP-1. And of course, like we have to remember all of our hormones are working synergistically and they're like a beautiful orchestra that is working together. And so if we're suppressing one thing and trying to raise another thing, a lot of times other hormones are being messed with as well. But I do want to say, like if you're contemplating a GLP-1 medication, there are natural ways to increase it. Fiber, soluble fiber, especially protein, like we were talking about, especially protein in the morning. So having a good amount of protein earlier in the day, and then that will help to increase it throughout the morning, and then exercise after meals. That's helpful. That's a helpful way to keep that GLP-1 hormone going as well for a little bit longer period of time. And so if we're looking at and there's other things too, good night's sleep, like sleep, of course, that's going to help with all of our hormones. But if we're not doing these foundational things, then, you know, our GLP-1 is lower than what might be optimal. And so doing the work to improve the foundations is going to help across the board with not only GLP-1, but all metabolic health. But I think there's one more. I did find the question that I think would be really helpful while you're here as an endocrinologist. And then it looks like we're going to be switching the guard here pretty soon. But this comes from Vicky, and it was posted a little while ago. But as a type 1 diabetic, can I ever reverse insulin resistance? I think this is a really great topic to speak about. I haven't worked. I'll be honest. Like I haven't worked with a ton of type 1s recently because of the type 2 epidemic that we're seeing. But how would you speak to that question?
I think this is an amazing question. Type 1 patients, right, lack insulin. So I always think of like type 1 and type 2 diabetes almost being opposite diseases. So in type 1 diabetes, you don't have insulin, and insulin is life-saving. Type 2 diabetes, you are resistant to insulin because you've stored too much. The body doesn't want to store anymore, and insulin is a storage hormone. So the cells in the body are rejecting insulin. and therefore sugar builds up because sugar is brought into the cells by insulin. So builds up in the blood. The point here is that type 1 diabetics, since they are told that they can eat anything they want and just cover it with insulin, over time, they become insulin resistant, which means that they have not just type 1 diabetes, meaning they lack insulin, but also now when they inject insulin, the body's not responding to it. So they have two problems, type 1 and type 2 together. Mm-hmm. Now, the problem is that that this means that over time, they're going to require more and more insulin and puts them at risk for so many more complications, okay? So we already, type 1 diabetics, by having hyperglycemia, have all the microvascular complications of diabetes. But when you add on the macrovascular from the insulin resistance, then it's really unnecessary. And this is a consequence of us telling patients not to worry about what they eat, just cover it with insulin, who cares? Well, that's a huge mistake. Now, it is, when you go on a low carb diet as a type 1 diabetes, we can easily, I wouldn't say easily, we reverse, and I've treated many patients like this, we reverse the insulin resistance part and make your life easy to manage with type 1. So how do we treat type 2? How do we treat insulin resistance in a type 1? Like we treat insulin resistance in anybody. A ketogenic diet, exercise, good sleep, metformin, and whatever other a cocktail of medications as necessary. Sometimes GLP-1, sometimes SGLT2s. This needs to be done with supervision of a doctor. But the point is that insulin resistance in a type 1 can get to be so bad, and it's really just created by our treatment and completely avoidable. Okay.
Mm-hmm. And as a registered dietitian, part of that question, like I was trained to just look at carbohydrates with type 1 diabetics. Like I was not trained to tell them about the whole fat fueling system. It's like, nope, we're just, if your blood sugar hits this, you dose for this. And so many type 1, I think a lot of type 1 diabetics that I've worked with anyway are kind of doing their own research and figuring this out. Like, oh, I do have my fat burning, fueling system intact yet too. So there is again, going back to like, we have a lot of, power within our own selves, and the more educated we can become. And I love that, that you spoke about the insulin resistant part, because it's very important.
I hate to interrupt this very good conversation. Thank you for this. You guys are helping educate people with type 1 and type 2 and other forms of diabetes all around the world. That's what the ADS is all about. So thank you for doing this with us today. Thank you. We're honored to have Dr. Glant on the board as our board certified endocrinologist. And also, Shanna, love the work you do as a registered dietitian. Next up, we have Professor Ben Bickman and registered dietitian Shannon Davis. So thank you, Dr. Glant. You're free to go. Thank you,
guys.
Shannon. You're free to go. Thank you so much. And now we're going to shift gears, and we're going to start talking to Professor Ben Bickman, who I always refer to as the Right Honorable Professor Bickman, because he is has always been a respected professional, but more and more so, his star is just reaching the apogee. He is becoming quite a big deal, and we're very honored to have him on the board of the American Diabetes Society. And then we have Shannon, one of our registered dietitians, who's doing amazing work with the recipes on the website and the meal plans on the website, which is a huge, huge benefit. And I just want to say, I'm not going to talk long, guys. Don't worry. I know I'm a bit verbose. I've been accused of that. I want everybody right now to check and make sure you hit the thumbs up or the heart button. Make sure you're subscribed to the ADS YouTube channel, and make sure that you have shared this on at least one other social media. And then either use the QR code up in the corner or the link down in the show notes to send a small donation straight to the American Diabetes Society. Don't do super chats or super stickers because YouTube's going to get some of that. We want every penny of your donation to go straight to helping people who are currently suffering with diabetes. Now, Professor Bickman and Shannon, I'm going to let you guys take it over and introduce yourselves and start educating these people that we have hanging out with us today. And I'm going to be watching the comments, and I'll pop up a comment or a question if I think it would be really helpful for you to answer that. Does that sound good, guys?
Great.
Perfect.
Thank you. Thank you. It's such a pleasure to be working with such fine professionals as we have over here. All right, guys, it's all yours. Take it away.
Okay, great. Thanks so much, Ken. Yeah, I'm the Right Honorable Ben Bickman, professor of cell biology and metabolic scientist. Shannon, you want to introduce yourself also?
Sure. I'm Shannon Davis. I am a rogue dietitian, just like the other dietitians that you will see on this platform. Probably not what you're used to as far as a dietitian is concerned. But yeah, we are here to speak all about insulin resistance and metabolic health and diabetes reversal. So
Yes. Amen. All right. Now, Shannon, correct me if I'm wrong. I think that I get to teach a small lecture right now. Does that sound right?
Ben, you can do whatever you choose. I'm going to be your wingman, and
okay,
I will
great.
be here to back you up.
Very, very good. All right. Well, if I understood the marching orders correctly, I get to be everyone's professor for just a moment. And of course, nothing thrills a professor more than having a new crop of students to teach. Let me share my screen. I hope I can do so effectively. And then Shannon, can you confirm that you see this title slide?
Nothing yet. Oh, now, yes, sir. It's there.
Okay, great. Good. Now, Ken, you watching from the back or anyone else, if you see a problem with this, please just make a comment, let me know. But everyone, thanks for your support. When we first envisioned the American Diabetes Society, I came at it as a scientist who had been a long member of an alternative diabetes association within the United States, and just increasingly frustrated by the lack of evidence that they wanted to, just how selective they were. And having said that, let me sort of make the case for our view. And I'm going to present what I call the metabolic origins of disease. And we have a metabolic problem within the United States. This report from about a decade ago found that only 12% of American adults had optimal metabolic health. And in other words, almost 9 in 10 of us were considered metabolically unhealthy. And the researchers based this finding on the degree to which adults across the country had some component of the metabolic syndrome. And as everyone probably knows, the metabolic syndrome is a cluster of complications that always tend to clump together. And however, as a metabolic scientist, I want precision, that while I appreciate the use of the term metabolic because it has such a lovely ring to it, it's important to note that what all of these problems have in common is an issue called insulin resistance. And in fact, what we call the metabolic syndrome used to be called the insulin resistance syndrome, which in addition to being so common, so prevalent, also is highly relevant, which is how I've justified devoting my career to understanding it, where virtually every chronic disease is either caused by or exacerbated by insulin resistance. And even things that aren't considered lethal, but still heartbreaking and frustrating, even the most common forms of infertility are derivative very heavily from insulin resistance, PCOS in women or erectile dysfunction in men. And many problems of the brain, including things like migraines and depression and even Alzheimer's disease, are heavily connected to insulin resistance, in this case, in the brain. Now, over the past few moments, I've been mentioning this villain of insulin resistance, and I am mindful of the fact that I haven't defined it yet. Insulin resistance is a pathology with two parts. It's a coin with two sides. The first part of it is what you think of when you think of the words insulin resistance, which is that some cells are failing to respond to insulin. But there's another part of this as we flip the coin over, which is that insulin levels are high. There is no such thing as insulin resistance in the absence of elevated insulin. They must come together. That is very, very important. And so anytime you may hear someone invoke the term insulin resistance, even if they add an adjective of physiological insulin resistance, look at it and ask yourself, well, is insulin elevated? If it's not, then it is not insulin resistance, and they're simply invoking something else that's wrong, and they just don't know better. Now, let's put all of this in a different perspective. Some of my frustration with conventional clinical care, which of course you're not hearing about here because we're bucking convention, is that we have a glucose-centric paradigm, and we're only looking at the glucose levels in a patient over the years, or some surrogate, and I would even say inferior marker like A1C. And we're looking at the glucose year after year, and we're waiting for it to start to climb. And then we intervene and say there's a problem. But with a problem like insulin resistance, you may notice there's something conspicuously absent. And so if we superimpose insulin onto this same timeline, it has a very different progression where insulin can be elevated years or decades before the glucose ever changes. And that's important because that is insulin resistance, a state when insulin is elevated, but glucose is not yet, perhaps. And then as it transitions into type 2 diabetes, when the body's become so resistant to its own insulin, now we have both of them elevated. And as Mariella mentioned in describing the differences between type 1 and type 2, with type 2, there is too much insulin. And it's important to note that it never goes away. Even though it may come down, as I indicate here on that orange line, it still does not get back down to where it used to be. And so we need to shift our glucose-centric paradigm to one that focuses more heavily on insulin. And I'll revisit this perspective in a few minutes. All right, now you know what insulin resistance is. Where does it come from? Well, for the sake of time, let's just focus on the major problem and the major cause. And the key contributor is too much insulin. To say that clearly and perhaps redundantly, too much insulin drives insulin resistance. Unless that seemed kind of counterintuitive or even strange, it is in fact reflective of a fundamental biological principle. Too much of something causes a resistance to that something, whether it's drug or antibiotic or even other hormones. Mariella mentioned how GLP-1 agonists make a little bit of GLP-1 resistance, making the person need more. That is itself a phenomenon. In fact, one of the classes I did most poorly at as an undergraduate once upon a time was economics. But I'll never forget the principle of diminishing returns. And we see the same thing here. So too much insulin drives insulin resistance. But then you're thinking, but Ben, wait a minute, is it even common to have too much insulin? Yes, boy, is it ever. If you look at what people eat globally, we eat about 70% of all of our calories from carbohydrates. And then we look at what that does to insulin, and it all gets a little more sobering. When a human eats pure fat, there's no insulin response at all. When a human eats pure protein, there might be. In many people, there's not a response. In some people, there may be. Type 2 diabetics, for example, may see a higher response. But when someone eats pure carbohydrate, there is a dramatic response where insulin will climb by 10 times or more and be elevated easily for up to 3 hours. And this is in an uncommon person, a person who's insulin sensitive. If that same consumption happens in a person who's insulin resistant, then not only can the insulin levels actually go multiples higher than that, but it can be elevated for much longer. It could take 4 or 5 hours for the insulin to come down. And now when we start to put all of this in the context of the modern global diet, I was going to say American, but that's not fair. It's a global pattern now. The uncommon individual is only eating 3 meals a day, and insulin maybe would look something like this. But of course, the more common individual globally is snacking or sipping throughout the day, and they are living every waking moment in a state of elevated insulin. And it is even more so the case if a person already has some degree of insulin resistance. So hopefully at this point, you appreciate what insulin resistance is and you don't want it, or you want to reverse it. So let's get on to that. How can we reverse insulin resistance? And throughout the next few minutes, you have to sort of appreciate a bit of an additional context, because to talk about this effectively, I have to bring in some aspects of type 2 diabetes. Unless you think that's a little strange, type 2 diabetes is the most likely outcome, or it's one of the more common eventual outcomes of insulin resistance. And so it's maybe the purest manifestation of chronic insulin resistance. That's perhaps the best way to describe it. But if you want to reverse insulin resistance, here is a hard and fast rule. If it doesn't lower insulin, it will not solve for insulin resistance. And you can do this, perhaps. Let's look at what happens with two main interventions, drugs and diet. What about drugs? So there are a lot of drugs that would claim to be anti-diabetic or to improve type 2 diabetes. But does that mean they improve insulin resistance? So let's look at a couple common ones, sulfonylureas and insulin. Sulfonylureas are drugs that are called insulin secretagogues that will force the beta cells of the pancreas to produce more insulin. And then, of course, insulin is just what insulin is. It's just a person injecting with insulin. This justification is based on the idea that if we just push insulin up even higher, we'll lower the glucose. And if your view of metabolic health is purely glucose-centric, this seems justifiable. You may not have even measured the insulin in the patient, and you don't care if you've pushed it higher, because what does insulin matter? You've only been trained on how much glucose matters. Unfortunately, insulin matters a lot, which is why so many papers that have looked at this have reported that nothing gets better when you give the type 2 diabetic insulin to try to correct this metabolic problem. And in fact, knowing what you know now, that too much insulin drives insulin resistance, what do you think happens in the patient who's given insulin when they already have a lot of it? Well, no surprise that insulin resistance gets worse, as noted in these papers here and others that I won't take the time to cite. So let's move on, though, to the last drug, and it is timely, and I am only now perhaps wondering at how much this topic's already been discussed based on the Q&A I just heard at the end of the previous segment. But I just want to force my opinion here on the matter of GLP-1 agonists. Of course, GLP-1 is a hormone that is produced from the intestines. So we're all making it to some degree. And it has a general effect at delaying gastric emptying, so making food linger longer in our stomach, making us feel full. We feel some bulk there. But speaking of feeling full, GLP-1 also has a central effect on the brain, activating satiety centers. So the brain is telling the body, we don't need to eat. The net effect of this, in combination with a little bit of glucagon inhibition, which I don't have indicated here, is that blood glucose levels will be lower and insulin levels will be lower as well. So in this regard, we would say GLP-1 agonists do improve insulin resistance, and I would agree with that. Now, however, there can be too much of a good thing. But let me provide what is my nuanced view of these drugs. It actually almost creating a bit of a defense for their use, but not in how they're currently used. This was a fascinating paper published in the mid-90s. And it is fascinating for reasons that will become quite obvious by looking at perhaps some people or determining that, exploring that some people may not have equal GLP-1 responses when they eat. So this first figure that I'm showing you, they broke people up into two groups based on their body fat levels, lean and obese individuals, and they ate a high-fat meal. And you can see that the GLP-1 response is kind of running overlap a little bit. The obese individuals, the purple line, it started to go a little down at the end, but it's still pretty close to the lean group. Now, if you'll allow me to think beyond the constraints of this singular figure, this would suggest, imagine, if you will, two individuals who go out for dinner, a lean friend and an obese friend, and they order the same fatty piece of steak, and they eat that fatty meat or that fatty meal, whatever it is. This figure would suggest that both will have a roughly equal degree of satiety, that they would enjoy the meal, push the plate away, wipe their mouths, and get up and go on with their day, quite content. Now, however, what if they ate a high carbohydrate meal? Look at the difference. The obese individuals had effectively no significant elevation This one singular point at about 15 minutes that was a little elevated had such big error bars that it was not statistically different. And in fact, if you look at around 2.5 hours, it went down. And it is possible then that far from having a satiety response, they may in fact have just a bit of a delayed hunger response. And so now the two friends went out to dinner, but as opposed to a fatty cut of meat, they had a plate of pasta and garlic toast or garlic bread. The lean friend pushes the plate away quite satiated and is done. The obese friend is asking for seconds. So let's have some sympathy and some empathy when it comes to understanding why GLP-1 might have a role in individuals, but not as a weight loss drug per se, but perhaps rather as an intervention, albeit at much, much lower doses than is commonly consumed. And this is how it's consumed nowadays. We would say, let's use a lower dose with the intention of helping you control your cravings for carbohydrates. Because any honest assessment of human behavior admits, and the evidence certainly supports it, that if humans have addictive tendencies towards any degree of food or macronutrient, it is carbohydrates. Now, as was alluded to in the Q&A earlier, and I don't want to be redundant, there are consequences to this, including that the intestines may slow down a little too much, including that perhaps a direct effect of the drug or an artifact of the poor nutrition, lean mass can go down quite considerably. Now, the main thing people report is the cravings. They will say, well, my cravings got better. Now, I think I just showed you evidence from that 1996 paper suggesting that that can in fact be the case, that might be the proper use, although I would say at much lower doses. But even then, the economics of metabolism indicates a diminishing returns, where this paper looked at people over 2 years, and they found by monitoring their sweet cravings at around the first half a year, sweet cravings were down significantly. So their desire to eat sweet foods, chocolate, fruit juice, etc., was way down. At 1 year, it persisted. They still had a significant improvement in their control of their cravings. At 2 years, it was gone. They were right back to where they started, all while continuing to take the drug. To make matters even worse, this paper was just published this year, and they found an almost 200% higher risk of major depression and a 100% increased risk of anxiety and suicidal behavior. So perhaps when we are rejoicing in their improved cravings for food, maybe that's just a reflection of a reduced craving for life and the things they used to enjoy in a very general way. And finally, this may explain why so many people get off the drug of their own volition. 70% of patients drop the drug on their own at 2 years. And what happens when they drop it? Well, of course, everything starts to come back. But remember, 40% of what they lost originally was lean mass, including potentially a degree of muscle and bone. Well, that may never come back. And so even though they may not get quite back to their initial weight, it's not too much of a stretch to think that they may in fact be, as a percent, fatter than they were before they ever started. So if drugs aren't a great way to improve insulin resistance, and there are more that I could have talked about, so please keep that in mind. Mariella mentioned metformin. Metformin is in fact one of the drugs that does improve insulin resistance. It has mitochondrial consequences, though, that need to be considered if a person wants to exercise. But let's move from drugs into diet very briefly as I wrap up. Well, there are 3 macronutrients, and that's what we need to manage. Managing macros matters most. The first one, control carbs, prioritize protein, and then don't fear fat. With control carbs, there are a couple rules I submit are helpful as just a metabolic scientist. Focus on fiber, and then carbs come last. Human evidence has shown that if you simply adjust the consumption of the macros, you can reduce your blood glucose effect by about 50%. And then prioritize protein and don't fear fat. I have those together here because they come together in nature. Our fear of fat has resulted in us doing something unnatural, which is pulling them apart. Protein should be consumed with fat. We have greater muscle growth when they're consumed together, and we digest it better. It is an unexpected effect of the bile acids. Most people only think of bile as being relevant to fat digestion, but it also enhances the enzymes in the gut that digest proteins. And then lastly, one final comment on GLP-1, a paper just published within the last year or so, finding that if you keep calories consistent and only change the balance of fats versus carbs, a low carb version, even equal protein, results in GLP-1 levels that are about 3 times higher. So if GLP-1 matters, then just make more of it on your own. All right. So in this mini lecture, very brief, which is appreciate, please, how hard it is for a long-winded professor. Ken said that he's verbose. Ken has no idea what verbosity really is. Wait, come to the university, Ken, and try to stop a PhD from talking about his or her area of expertise. But in this time together, we've discussed the origins of insulin resistance, what it is. I mentioned how it affects the brain, but also what to do about it. And now Shannon and I, as I hope I've stopped sharing the screen, are going to answer some questions.
Perfect. Excellent explanation. It's amazing because it's for everyone can understand.
Perfect. Nothing thrills me more. All right. So Shannon, do you know where we can see the questions?
Yes, on the right where it said private chat, hit comment. So here's a question, Ben. There seems to be a trend towards higher protein, lower fat, low carb diets. How will this affect insulin?
Oh, yeah, that's a great question, actually. So we're seeing the newest version of Walter Kempner's rice diet. Nowadays, it's called the sugar diet. It is, in fact, just a new version. Now, I don't want us. I think we ought to be more than just flippant when it comes to this, because if you look at the history of the rice diet, there are results that shouldn't be just summarily ignored. As hard as it is for me to say this, as a scientist, I need to be an objective seeker of truth. There is something that does happen that's interesting when protein is restricted. And it pains me to say this because I'm an advocate of dietary protein, an enormous advocate, which is a paper that was published in Cell Metabolism within about the past 6 months. They took college-aged individuals and had them restrict protein to a very low, it was about 10%, which I'm not recommending. But they found that FGF21 levels went up by about 400%. It is rare to see that kind of effect in humans. And they noted that the FGF21 resulted in a significant degree of mitochondrial uncoupling, which is something I've studied quite extensively in my lab, looking at the degree to which mitochondria are just revving their little engines just to burn through energy, to burn through calories. And indeed, they found that they had to feed the patients several hundred calories beyond expected in order to have them maintain their body weight. So this idea, now that I'm really being verbose and taking a page from Ken's book here and saying maybe a little too much, I want to defend, in a way, while I'm an advocate of higher protein, I think that people who find when they adopt a low carb diet and they find that their blood glucose levels start to rise paradoxically, they may be people who could experiment with lower protein, higher fat. But I'm an advocate of a high protein version in general, and I think that's where people ought to start. But then, Jane, to get right to the question, how does that affect insulin? Well, it won't very much. And this is Dr. Jeff Volek's and Stephen Finney's work has really shown this well, that when you take people on a low-carb ketogenic diet, even when protein is relatively high, their insulin levels come down. However, if a person has type 2 diabetes, they almost always will have a higher insulin response. And this is where I think we might see people that adopt ketogenic diets or carnivore diets. Why might they see an increase in glucose? It's because in a person with prediabetes or a recovering type 2 diabetic, or they have type 2, they will have a higher glucagon response to protein. And when glucagon goes up, it spikes blood glucose, and that may put it at odds or at war with insulin. All right, that's a long-winded answer, and I'm sorry to take so much time on that one.
Excellent, because I know people are going to ask about the sugar diet. So how does alcohol affect insulin and glucose?
Yeah, that's a good question. Yeah, so ethanol doesn't really have much of an effect. So ethanol alone is relatively benign when it comes to insulin and glucose. The problem is, of course, what it comes with. And if everyone knows, and ironically, I say that as a guy who's never touched a drop of alcohol in his life, so I don't know. But I don't know personally, but alcohol often will come with some sort of juice or sugar to sweeten it up. And that, of course, changes the game, where you have added in now something that is absolutely going to spike your blood sugar and your insulin. That is a particularly pathogenic mix, because ethanol already demands priority boarding on the metabolic bus, if you will. It demands immediate burning. And if you can't burn it, you store it. This is why alcohol can lead to fatty liver disease. You amplify that effect if you consume ethanol with an insulin spiking sugar, because now you are slowing the burning of everything, ethanol included, and now you're making more of it turn into fat. So you're going to amplify the effect of stimulating fatty liver disease.
And if I can add to that, Ben, what I notice a lot is, so the alcohol makes people, we know their inhibition, and I can speak because I have had alcohol, but your inhibitions will go down. And then what happens after the fact is people will eat sometimes uncontrollably high carbohydrate, high sugar, pizzas and chips and
they get snacky.
The snacky after. And so, the liver's prioritizing, like you said, getting rid of the alcohol. And now you're just throwing gobs of glucose in there. That's just going to be packaged up as triglycerides and go right to the liver.
Yeah, amen. In fact, it's funny because as the often designated driver, I can't tell you the number of times I'd roll my eyes and say, can we just end the night already? You don't need a snack, guys. Let's just get the hell home.
But they do, Ben. But they do.
I know.
All right. Let's see. More questions. I'll just look to pick out one. My daughter has been keto for 10 years. She had COVID in October of 20. Now she's pre-diabetic. Her fasting insulin is high. How can she reduce it if her carbs are already at 20?
Wow. So what's interesting about COVID and type 1 diabetes, which is not what the person's asking here, what Carl is asking. So everyone, pardon me for kind of going briefly off topic. There was evidence early on showing that infection stimulated type 1 diabetes. Now, lest anyone think that's something unique to COVID, it's not uncommon actually for an autoimmune disease to be triggered by an infection, COVID or otherwise. But it was interesting for me to see that trend happening in the literature and even in my own neighborhood, actually, with a couple kids of my kids' friends. So in this case, I can't imagine a scenario where this would have lingered. And so I'm a bit at the edge of what I can speculate, but I will just try to answer what I can here. Inflammation causes insulin resistance. The very simplistic view of insulin resistance that I presented in the time constraints that I put on myself, where I only focused on the main one, but there are three cardinal causes of what I call fast insulin resistance. And too much insulin is one of them, and inflammation is the other, is another one of them. And in this case, with an infection, there's of course a dramatic increase in pro-inflammatory cytokines, or these hormones that promote inflammation, to say it another way. And so an infection, an illness, will promote insulin resistance. Now, this, depending on how much this has lingered, I don't know. That goes beyond. It may be the easy answer would be, well, perhaps she's not recovered yet, or there might be some kind of autoimmunity quirk going on here. But I think it would probably be related to inflammation.
How do we convince our doctor to test for insulin if we are not yet diabetic? They don't value the insulin as a symptom of prediabetes.
Yeah. I mean, well, Shannon, you're a clinician on the front lines. I'd almost be interested to hear what you think. Sure. Maybe I'll just do a brief answer, then okay. I'd like to see what you think. It depends on how big the ego is of the physician, perhaps, where when you add letters after someone's name, it's like a wall between what you're telling them and their own brain. And I mean that generically. That's not something unique to MDs or DOs. RDs have it, PhDs have it. Shannon and I can both attest to that. I think it would just be to try to impress upon them the fact that with a disorder called insulin resistance, there's something missing from your blood test, and that would be insulin itself. And so just try to impress upon the clinician that insulin resistance is better or even best understood by actually measuring insulin itself.
Exactly. If I would chime in just a bit, I think the hesitancy is they don't really know what to do about it. They don't know how to treat, because if you look at our common lab values, a normal fasting insulin will go up to 22. Well, we clearly know that's not a normal fasting insulin. What I recommend is, if your doctor is hesitant and won't do it, guys, we have so much control and power now amongst ourselves to go have our own labs checked. I mean, Dave Feldman has created Own Your Labs. There's so many ways. And I think I want to say it's $8 or $10.40. Go get your own checked. And ideally, I mean, we say in the single digits, under 10, optimally 6 or less.
Yep.
So as a rogue dietitian, what is your explanation for the professional rut in which many registered dietitians practice giving a bad advice to type 2 diabetics? Well, David, thanks for that. I mean, I can't speak for anyone but myself, but I think that number one, we are not taught the way that I teach. That was something that I had to take upon myself to go dive down and learn. And most people are still we come out of school just like doctors and physicians. We practice by the guidelines what we've been taught. And I did that for most of my career. I've been a dietitian for 19 years, and it wasn't until the past, since 2018 that I have flipped the switch. But something never sat right with me in the first place. There's no way all these people are non-compliant. There's no way that every time somebody sits across from me and I give them, guidance or direction, and they come back and they've not gotten the results that them nor myself are looking for, that is a non-compliant patient. If it's not working, we have to pivot. But dietitians are afraid, I guess, that they don't want to go against the academy, or they don't want to be different. But I am not doing anyone any good if I keep them sick, no matter what I'm practicing. And so my duty as a God-given human is to do better for society. And if what I am telling you is not getting you better, and I'm a dietitian and I am the expert, then it is my duty to go learn and be better. And we can't undo what we've already done, but to continue to do and know better, shame on you.
Yeah, amen. In fact, I even have my own version of this. Some people here might have heard me share before. I actually had to defend my job as a professor. The dietetics department at my university considered my teaching of low carbohydrate principles when it comes to very specific pathologies like type 2 diabetes and Alzheimer's disease, showing the whole time just purely peer-reviewed evidence, that they cited that I was teaching principles against best science, and that they made the case that I should be removed from the university. And I had to literally defend my job from this rabid group. And I think it was partly born from ego. And they said that I shouldn't be able to talk about nutrition. And I said, well, then you can't talk about physiology and cell biology because that's my domain. And so there's very much a protective wall there, but it is also evidence of just how heavily biased nutrition research has been for decades against things like saturated fat. And then, of course, ketones. I mean, forget about even mentioning the word ketones or ketogenic to a conventional dietitian. It's like uttering a curse word.
I know, it's really sad. I mean, we saw that with Dr. Noakes and Dr. Fetke as well.
Yep.
What is the best type of fasting insulin? I mean, Ben, I only know of you just asked for a fasting insulin. I could be wrong.
No, that's exactly right. Yeah, you're just going to say, can I get my fasted insulin? Now, you guys, as A1C has become the measurement du jour, where clinicians are so enamored with A1C, part of the problem we face is that you don't need to have a patient come in a fasted state. So it's become increasingly common for patients to get blood tests just come in anytime it's convenient, and they're not fasted at all, which throws everything off. And that is, again, just reflective of right now, it's part of the glucose-centric paradigm where the conventional clinician just thinks that A1C is the end-all be-all. And it's not only for glucose measurement, but it also results in a disruptive blood test that won't even allow you to get a fasting measurement, because they'll say, don't even come in fasted.
Right. And, guys, your A1C can be normal for 10 to 15 years. In the background, your insulin's doing this. So I want to see the full picture. I want to see a fasting insulin along with an A1C.
Yeah. Yeah. And another problem with A1C is that there's another part of this equation. What we call A1C is a sum of something plus something. And one of those somethings is glucose. And so we often just say, well, then that's all there is to it. If A1C is high or low, well, then glucose is high or low. No, but there's another part of that equation, which is the longevity of the red blood cell itself. Red blood cells that are long-lived are just more statistically likely to get glycated. And it might not be that it's because glucose is elevated. It may just be a sign that the red blood cells have quite a hardy longevity. In contrast, so in other words, giving a false positive, if A1C is high, but glucose may be normal, the red blood cells just are long-lived. Conversely, you could see the state where glucose levels are high, but red blood cells are very fragile because of perhaps poor nutrition, and thus the A1C is artificially low, giving a false negative. So they would look at the A1C and say, oh, you're fine. But in fact, their blood glucose levels may be quite elevated. It's just the red blood cells aren't living long enough to get glycated. So I'm frustrated with this obsession with A1C because I think it's a little bit of bad science. Not that it can't have a role, but it should certainly not be the singular marker. I would rather look at fasted glucose than A1C, to be frank.
And, to tag on to that, if you're carnivore, there's a good chance you may see a higher A1C because your red cells do live longer. And I worked in the dialysis world for over 12 years. We see false low A1C because the half-life of their red blood cells, we're giving them EPO constantly or blood transfusions, or their red blood cells are lysing because of the inflammation from being, getting a needle cannulated 3 times a week. So you need a big picture and you need trends. So How long should one fast before a fasting insulin? Minimum 12, 14 hours?
I think so. Yeah. Yeah. Now, however, having said that, that is not the same thing that would apply to someone going in and doing an oral glucose tolerance test.
Yes.
Everyone remember, if you got to actually go in and do an OGTT, you need to remind your beta cells what it's like to get a big rush of glucose. And so you do not want to fast that long. If you fast that long and go do an OGTT, you increase the likelihood of you failing it, where you don't have enough insulin pre-formed in order to have both phases of insulin secretion. So your glucose may go higher and stay higher for longer. So if it comes to an OGTT, you want to make sure you actually eat, and not only eat, but actually eat some carbs within about 8 hours of going in for that.
Yeah. It's a shame that we can't measure, like the Kraft test over here, like they do. And I know there's a gentleman, Andy, I think he's actually watching, Andy Taylor in the UK. They do Kraft test on athletes, on everyone. And it's profound what that shows.
Yeah, that is the absolute gold standard. Yeah. Just so everyone knows, as much as Shannon and I generally would just say, at a minimum, get your fasted insulin measured. But gosh, if you can do an oral glucose tolerance test coupled with insulin measurements, in other words, the Kraft test, or there's a derivative, simpler version that I just call the Hayashi test, based on a guy last name Hayashi in Japan, which is a sort of simpler version. But if you can look at that dynamic insulin movement, boy, now you're really getting the gold standard.
Mm-hmm. Okay. What do you say to someone who says that animal protein is to be used sparingly and it's pleasing unto me that they should not be used only in times of winter? Or
Okay. So Shannon, what everyone here doesn't know is that we're getting into religion. So I'm a member of my faith. I'm a very religious person in the Church of Jesus Christ of Latter-day Saints, are commonly called the Mormons. As people know, Mormons are a little quirky. We don't drink coffee. We don't drink alcohol. We don't smoke or engage in any kind of tobacco consumption. I'll try to be very brief here, but it is something that within my religion is a huge point of, I'm being a little dramatic. It's a point of some discussion, not contention. But there is a verse of scripture that says this. And what I think is relevant to the person who asks, the Sage Femme, is I would please encourage you to go look up the talk by Ezra Taft Benson called A Principle with a Promise, where he says that the Lord's use of the word sparingly is to encourage us to avoid the indiscriminate killing of animals. And I'll just leave it there because it's a very specific topic and it very much is religious and bent. But it's my own religion, so I'm happy to answer it. Anyway, Sage Femme, go please look up 2 talks. One, both of them called The Principle with a Promise by Ezra Taft Benson and then Boyd K. Packer.
And
Right,
I'll
thanks,
just, no, you're welcome. I'll just tag, guys, I am an animal lover. Like my goal, I really want to open an animal sanctuary. I have no children. They're my life. I love them. And I grew up on a farm where we raised what we ate. And I didn't know that at the time. I thought they were sold to breeding farms. You know, my parents, it was awful when I learned as an adult. It was so bad. It was so bad. I'm like, you mean Bubba did not go to a breeding farm?
No, Baba went to your tummy.
He did. And gosh, anyway, I really believe that if you're going, if you in all possible can purchase humanely raised, it does make a difference. And, you can find that. You can find free range and humanely raised, which I think changes it. It's not just a, assembly line and a slaughter yard.
Yeah, agreed. Yeah, I mean, there's a lot to say about this, and anyone who looks at, I saw a clip online where these guys were, I would call them politely knuckleheads, were saying how it is, if you're a Christian, you can't eat meat, and I just thought, where on earth is that coming from? They were specifically referring to Christianity, and I thought, where in the New Testament? In fact, go read 1 Timothy chapter 4, where the Apostle Paul makes it exceptionally clear, where he speaks of the latter days, prophesying to the young apostle Timothy, or missionary Timothy. He says that people will be seduced by the spirits of devils. Those are his words. And he says that there are 2 things basically that will identify them. One, they'll command to abstain from marriage. They'll say marriage is bad. And the second one, they'll command to abstain from eating meat, which I, the Lord, hath ordained for the use of man. 1 Timothy chapter 4, verses 1-7. I invite any Christian who thinks meat is bad to try to reconcile that, in addition to other scripture that I won't take the time to get into.
If someone started wearing LC, not keto, to lower A1C, and it worked. Someone maybe started eating low carb, not keto.
Yeah. Okay.
Low carb, not keto, and it worked. Why would his triglycerides have increased? He cut pasta, pizza, soda, etc.
Okay. Yeah, that is uncommon. It is very rare to see. So I'm afraid I'm going to end up with a disappointing answer here. Triglycerides move as carbs move. Overwhelmingly, that's the direction it goes. And so if a person's restricting their carbohydrates, I would fully expect triglycerides to go down. And so seeing triglycerides go up, I don't know. I'm not sure. Maybe it's a case of just familial.
Oil? Maybe it's seed oils.
Maybe. I don't know. It might be worth seeing what happens with triglycerides if they ate more monounsaturated. But you guys, even still, as much as people want to just look at animal fat as being saturated, animal fat is actually almost a 1-to-1 mix of saturated to mostly mono with a little bit of polyunsaturated. Yeah, I'm not sure. It may be worth manipulating some of the fats and just make sure maybe you're not, drinking heavy cream or something.
Right. And how low carb are you, and how frequently are you eating, and are you exercise? And I think there's a lot that plays into the picture. Yeah.
Well said.
All right. Let's see. Next question. Let's see. While they're waiting to put one up, I'll read one. This is Andy. He said, what would you consider the gold standard for testing insulin resistance?
Well, yeah, Andy, it sounds like based on what Shannon said, you're already doing it. The craft test is absolute gold standard. I did mention, and I want to just repeat it because I think it's valuable. The Hayashi test is a bit of a faster, simpler analysis where it basically looks at the first, I think, 90 minutes and then it's done. And then they found that, and I think they even came to their conclusions based on comparisons with the craft test, that their simplest takeaway was that if the peak of insulin was at 30 minutes, and every subsequent point was lower, then it was a green light, and that was a sign of a good insulin-sensitive body.
All right, let's see. I'm going to go look over here and see if I can find any. Somebody asked, would you speak a bit about linoleic acid?
Yeah, sure. Now, I'm not a seed oil guy. Everybody knows that. So linoleic acid, which is to say, I'm fairly familiar with the biochemistry and the cell biology effects of linoleic acid, but there are people who that is their singular view, and they would be able to articulate their view, the view of seed oils and linoleic acid perhaps better than me. But I have an informed opinion, maybe two parts. One is the real world human evidence. In the Minnesota coronary experiment in the Sydney Diet Heart Study, where they had people living in institutions for years eating in two separate cafeterias. This is the best, perhaps some of the best diet nutrition research ever done, and ironically, paradoxically, the most overlooked. And both of these studies conducted around the same time in two very different parts of the world, Minnesota and Sydney, Australia, finding consistent results that in one cafeteria they were eating saturated fat in their meals. In the other, it was seed oil, which is primarily linoleic acid, the omega-6. And in both studies, the people who ate the higher seed oil version of the diets died more, all while their LDL cholesterols were wonderfully low, as they would say. And wonderfully is in quotes here because I wouldn't say it's wonderful. But that is pretty convincing evidence. And even heart disease did not get better, which was the primary outcome they were measuring. So this is the kind of study you could never do again. And so we need to point to those studies. Now, as an insulin resistance guy, I have seen many on that side of the community say that linoleic acid, seed oils cause insulin resistance. And that is not true. Linoleic acid does not cause insulin resistance. I have done those experiments with my own hands where I treat cells with linoleic acid and then I measure the insulin signal about 15 to 30 minutes later. They do not become insulin resistant. However, I think that linoleic acid can be, perhaps we could call it a secondary contributor, because linoleic acid will accumulate in fat cells and prevent fat cell hyperplasia. So it will prevent the fat cells from reproducing, which means that the fat cell gets bigger and bigger. A fat cell is an insulin resistant fat cell. And so in that sense, linoleic acid can contribute to the fat cell growing in a way that the fat cell will become insulin resistant through its growth. But that is a secondary effect because there's actually more going on in the fat cell to cause that. So at best, I consider linoleic acid a secondary cause. Now, having said all of that, I think linoleic acid is very pathogenic, and it results in the creation of highly reactive lipid peroxides, which damage cell membranes, damage nuclear membranes, mitochondrial membranes, damages DNA, it damages proteins. So lipid peroxides are highly reactive and pathogenic molecules, and thus I think it is prudent to avoid linoleic acid rich seed oils. But it's not as simple as just all linoleic acid is bad, because it is also ubiquitous in nature. You cannot eat a natural, like an animal fat. You cannot find any source of animal fat without some degree of linoleic acid in it.
And they hang around for like 2.5 years. So what are your thoughts on CGMs and diabetes management? And do you think the over-the-counter ones are accurate? My insurance only covers the prescription if you use insulin, and I do not.
Yeah. So there was a paper just published finding that there's quite a wide range of accuracy with CGMs. And that was interesting for me to see. And frankly, a little troubling. I'm still optimistic and still very much an advocate of CGMs and the democratization of access. I think few things can change behavior more than someone seeing what's happening in their own bodies. And I think that's very powerful. So while there may be some concerns with accuracy, I still think it's helpful for overall trends and general information. And thus I am an advocate. And the technology will continue to just get better and better.
I'm going to throw this one up. I saw it a while ago. Ask, because I'm drinking it. Asking about yerba mate tea.
Yeah. Yeah, good question. I actually just did a metabolic classroom on this. So
it was excellent. It was excellent.
Yeah, well, good. Thank you. Yes, so someone could go to my YouTube channel, Ben Bickman, PhD, I think, and watch that there. But a brief answer is I'm an advocate. I drink yerba mate daily. It's a habit that I really enjoy. It's interesting because there are bitter tastants, like among many things I could say. Theobromine, for example, has been shown to reduce appetite. Chlorogenic acid has been shown to, even consumed in real time with glucose, has been shown to reduce the glycemic and insulinogenic response to foods. So there are a lot of benefits that go beyond just I feel a little more energetic or I feel a little more perky that I think support its use in improving metabolic health.
We're getting a lot of shout out, Ben. I know Victor. Victor, thank you. Target Prime Rib said you're an inspiration, Dr. Bickman.
Love it. Love it.
So,
yeah, we're doing good. You guys, thanks for the support. Let me just echo some of what Ken mentioned when he kind of brought us on the stage. I actually had ceased my membership in this alternative organization because I had become so frustrated with their total unwillingness to acknowledge the mountain of evidence supporting the efficacy of a low-carb diet in any form of diabetes, type 1, type 2, MODY, I would even say gestational diabetes. Every form of diabetes, which we define as high blood sugar, benefits by putting less sugar in the body. And they just were seemingly incapable of acknowledging this. And perhaps on a cynical point of view, it makes sense because it's a bad way to sell drugs.
Yeah.
And who is funding the alternative organizations? Well, it's drug companies. And so that's bad for the bottom line. If someone can control their blood glucose by just controlling what they put in their mouths, someone's not going to make money. And so this support, which we see growing into the ability to fund our own studies and the ability eventually to have our own annual meetings, which thrills me as a scientist who attends and presents at annual meetings. And I take my students to annual science meetings. I would love nothing more than to have us sharing our work at the annual meeting of the American Diabetes Society. So there is a lot that we're looking to do. And the fact that you guys are here and tuning in and supporting really is making it possible.
It is. And I concur on that. And, guys, we just want to encourage y'all to do your own research. It's okay to ask questions. It's okay to push back to your doctors and to your dietitians and to let you know that you do have the power. You do have the control. This is reversible. It is reversible. I've seen it every day. I know Dr. Bickman sees it every day. It's a dietary, it's a food disease. So if we focus on that, then you will see your disease improve.
Yeah. Amen. You guys, I just am so dumbfounded by, and it might, maybe part of this is Ken's star power, but just how many people are here and commenting. It is just remarkable. Matt asks a question. What is your favorite metabolically related alliteration? Matt, thanks. Actually, I'm pleased to see that someone notices. I was very, very inspired. Many, many years ago, I lived in Russia, actually, not to bring in religion again. I was a missionary for my church in Russia in the mid-90s. And I learned Russian very, very quickly. And to challenge my ability to translate, I would have my mission companion read like messages or talks from a man named Neil Maxwell. And he was the most articulate, beautiful speaker I have ever seen in my life. And I figured if I could translate his material, I could translate anything at any time, including military analogies. I could talk about car engines, all, of course, trying to lead people to religion in a funny roundabout way. But he used alliteration as a device in his messages, and it just left such an impression on me that I find if I'm about to say something, as I'm always thinking about 5 seconds ahead of what's about to come out of my mouth, I'm going through like my vocabulary of synonyms to see whether I can find a series of words that will cling together and allow me to have some alliteration. So anyway, it's a funny little quirk and gives you some insight into my brain.
Prioritize protein, control carbs, and don't fear fat.
Yeah. And then I often add frequently fasting, actually.
Yeah.
Yeah. Anyway, Ken, thanks so much, Ken, for arranging all this and really lending your star power to bring people in. I think we can all look at what we've been doing and just pat ourselves on the back, by golly. Ken, you're muted. You almost professional.
I was going to say thank you very much for being here today. Everybody watching this, keep in mind that every professional you see on this live stream today is doing this for $0. They're taking time out of their busy professional schedule to reach out to people with diabetes all around the world and say, hey, there's actually a better way, a better strategy. If you're type 2, you can reverse that completely. If you're type 1, you can have a normal A1C and never have the disastrous complications that come from uncontrolled type 1 diabetes. I encourage every single person watching this to look down right now, make sure you're subscribed to the ADS YouTube channel. You may think you are and you may not be. Click that subscribe button, hit the bell so you get notifications, because we're going to be doing a lot more video content in the months to come. Hit the thumbs up, hit the heart. Feel free to click the share button and share this all over social media, because Professor Bickman and Shannon and I all know, but you may not know, that there are millions upon millions of people all over the world who believe right now that type 2 diabetes is a chronic progressive disease that they got for some unknown reason, and they're going to have it. They must have it for the rest of their life. There is no alternative, and that's just not true. So please share this video with a friend, in an email, in a WhatsApp, in a text message. Share it on your social media, because if you don't, these people will never know that, hey, this is not a chronic progressive condition. This is basically carbohydrate toxicity syndrome. And when I cut the carbohydrates drastically enough for my personal physiology, my A1C will go back to normal. And I know, Professor Bickman, you have a little panic attack when I say A1C, but also your fasting insulin will go much, much closer to normal. And your fructosamine test will go back to normal. And your fasting insulin test will go back to normal. And if you have a Kraft test done, which is a long drawn out process, the results of it will also go back to normal. Type 2 diabetes is not a permanent condition. You can reverse it. And the way that you can help pay this forward, if you know what we're saying is true, is to either point your phone's camera at that QR code and send a donation to the American Diabetes Society, or there's a link in the show notes you can click and send a donation to the American Diabetes Society. I was telling everybody earlier, Professor, that I've been watching the donations closely, and we haven't gotten a penny from Coca-Cola or Pepsi or Kellogg's. They're just, the money's not coming from them like it goes to the other, which I like how you phrased it, the Alternative Diabetes Association, because we're no longer the alternative. We're the answer. Yeah. They're the Alternative Association, and they get $1 million a year from each one of those big food manufacturers. We're never going to get that from them or from the big pharmaceutical manufacturers. And if we do get a big fat check from Coca-Cola or Pfizer, we're going to tear it up and send it back, and probably issue a press release with a video of us tearing up the check, saying we don't want money from big food, big pharma, because that always comes with strings attached. They always expect something for that money. And that's why every time I talk about the Alternative Diabetes Association getting millions of dollars in donations, I always put that in air quotes, because a donation is something you give freely without any thought of getting a return, right? That's the actual definition. But if you give $1 million to an organization, but you expect some messaging to be shifted or maybe some recipes on the website to be changed, that stops being a donation at that point, doesn't it, Professor Bickman? I consider you to not only have a PhD in physiology, but also you're a philosopher as well. Am I right in that the definition of donation?
Oh, I sure think so. There's no doubt that there's an expectation because the donor is playing the fiddle and the organization's just dancing along to it.
Sounds like feedback to me.
Yeah, sadly, that seems to be the case. Now, thank you guys so much for doing this for the ADS for the hour. Professor Bickman is on the board of directors. He's doing this for $0. Shannon is one of our esteemed registered dietitians at the ADS. She did this for $0 today. So if you got value from them, they want you to pay them back by clicking on the donate button and donating whatever amount you can financially be comfortable with to the American Diabetes Society, because we are on a mission not to become your partners for life, but to stamp out type 2 diabetes as a disease paradigm and to help every person on the face of the earth with type 1 diabetes have a normal A1C and drastically cut their risk of diabetic complications. Now, next up, we have registered dietitian Michelle Hearn. And I don't recognize this guy. Who's this? Oh, it's Eric Westman with a beard. I didn't recognize him. Thank you so much, Ben and Shannon. You are free to go. You can hang out or you can take off as your schedule permits. Dr. Westman, I am so sorry. I thought that some random person had snuck in, got backstage somehow. You look amazing. That's better. Oh, I recognize you now. Yes.
Now it's like COVID time.
Yes. Thank you, Michelle, for not showing up with a beard. That would be weird. So I'm going to turn the next hour over to put it in the capable hands of registered dietitian Michelle Hearn and board certified. You're internal medicine, right, Bickman? Westman. Yes, the board certified internist, Dr. Eric Westman. Please share this. Please hit the thumbs up. Please make sure you're subscribed. And please donate if you're financially able to the American Diabetes Society. Okay, I'll shut up now.
Thanks, Ken. Hey, Michelle.
Hey, Dr. Westman. I'm so honored to be with you. You guys, I was on a little bit earlier. I'm Michelle Hearn. I'm a registered dietitian. I have so much respect for Dr. Eric Westman. Dr. Westman was co-published one of my favorite papers ever, which actually really changed my outlook as a registered dietitian. And you guys can everybody can go Google this, look this up. I think this is a great paper. I didn't know I was going to pump you up to begin with here. This is seriously, this was one of the foundational papers that really shifted when I started to be in a low carbohydrate nutrition and led, really encouraged me to write my book. It's using dietary carbohydrates as a first line defense for type 2 diabetes. You guys, if you have a minute or if you're listening to this, pull up a Google browser and put that in there. Therapeutic carbohydrate restriction as the first line of defense for type 2 diabetes. Put in Eric Westman. It is an incredible PDF that not only goes through how carbohydrate restriction can reverse type 2 diabetes, it answers the questions about, well, what about triglycerides? What about saturated fat? It blew my mind. I thought it would change the face of the clinical practice I was in, but there's a lot of things. But anyway, so if you want to introduce yourself, talk about what you do, and we'll just kind of get going from there.
Great. Thanks, Michelle. And I'll never forget the first time I saw you present at one of the meetings and what a great influence that you've had so far. I'm Dr. Eric Westman. I'm an associate professor of medicine at Duke University in Durham, North Carolina. And I've been at Duke since 1990, actually. The first 10 years I worked in smoking cessation or nicotine. We actually worked on the early studies that led to Chantix and other nicotine replacement treatments. So, and that helps me understand sugar addiction, because I was in the nicotine and smoking addiction world, and the language is so similar the details are so similar, it's almost spooky. So, but I was always an internist at heart, and still am, and which means we get in-depth training about organ systems. Of course, the artificial dichotomization is that the psychiatrists and neurologists get the part of the body that's above the neck, and then internists get the part of the body that's below the neck. It's all connected. But anyway, so I learned how to help when the liver fails or when the heart fails, or so internists often are taught the medication treatment for all these things. And so when two of my patients at the VA in Durham, North Carolina, really just down the street from me now, lost weight on their own, going against everything I had been taught, using the language from Michelle's book, it caught my eye. So these two gentlemen lost over 50 pounds doing the Atkins diet, in short, but I had to kind of figure out what they did. And it went against everything that I was taught. And this, for me, this is 27 years ago now. And so I was curious and kept pushing, learning, and ended up in Dr. Atkins' office and studied what Dr. Atkins really was using at the pinnacle of their clinical career. Jackie Eberstein and Dr. Robert C. Atkins had a practice in New York City. And I got to take a glimpse of it and study it. And so we came back to Duke University and studied the low carb diets, and the first ones were obesity, and then the one on diabetes. It's just kind of, where does the time go? It's published in 2008. Wow. So we did a randomized trial of low carb versus low glycemic diet for type 2 diabetes. And with only 49 participants, we had statistical and clinical significance in diabetes control between a low carb and a low glycemic diet. This is published now, what year is it? So 17.
Gosh, almost 20 years ago. 17 years ago.
Other groups have done research, and then most recently, Virta Health has their own company data on reversing type 2 diabetes. And looking back, we didn't claim reversal of type 2 diabetes. We showed what could happen, but I see that in my clinic all the time. And just a couple recent cases of diabetes reversal, even let me go before pre-diabetes reversal. There's often a point where someone is told they have an elevated blood glucose. And the story recently I got is they were in nursing school, and so early 20s, told they had pre-diabetes, and they looked at what they were eating, and they were having sugar sweetened cereal 2 or 3 times a day. And so when you're faced with, and one of the people who influenced me, one of my patients, I'm influenced heavily by my patients, so we shouldn't call it pre-diabetes, we should call it diabetes stage 1, because it shows you're going down that pathway toward diabetes. And pre kind of means to most people, you don't really have it.
It's not a problem yet, or whatever.
Don't have to take action and all that. But so when someone tells you that, often people wake up and they start minding the sugar and the starches a bit. But so I had that recent discussion, and it was just a pretty easy answer. I show a textbook from 1923 that shows the treatment for diabetes was a low carb 10 grams total, not net, per day for treating and reversing type 2 diabetes. 1923.
So that's almost 100 years ago. They had this prescription. So
it's the same. So for obesity and for diabetes, this is what doctors did 100 years ago. Got all forgotten. So the science has come so far that the ketogenic textbook, with an egg on the cover, has a great cachet, should I say. So I use that as kind of show and tell in my clinic these days to show what can happen and all the science that's there. But so 2 weeks ago, I had a resident in the clinic, a Duke internal medicine resident with me, shadowing me. And we're talking to a 75-ish-year-old woman who had been on insulin for 15 years. And she was brought in by a family friend who had heard about us and came in from, a couple hours away to Durham. And we're chatting, and, she just never heard about low carb diets, was on 90 units of insulin a day, and blood sugars were almost normal, like 100, 110 milligrams per deciliter, almost 6 millimole. And so I'm working with the resident, shadowing, she's shadowing, and I'm asking, well, what should we do? And how should we adjust the insulin? And it's just not apparent. It's not commonly taught and not common knowledge that you should reduce the insulin on the first day, on the first day of reducing the carbs. So the insulin is treating the carbs, basically.
Exactly, yeah.
Of course, if you're teaching a type 1, that's how you teach it. More carbs, more insulin. But so I worked out and okay, maybe I wanted to show a little how powerful this was and great. And so I said, well, gosh, if the blood sugars are normal and you're eating 200 grams of carbs and you're on 90 units of insulin, let's just stop all the insulin. How brash is that, right? So you're stopping all the carbs but she lived a couple hours away. So I said, well, let's share texts on our phone, and you text me tomorrow what your blood sugar is, so that she wasn't using a CGM. It was kind of old school, the old finger stick. And it turns out the resident came back the following week. The first thing she said is, what happened to that patient? What happened? Well, her blood sugar stayed the same. So cutting out the 90 units of insulin for the 200 grams of carbs meant that now the blood glucose was the same, because you stopped all that input into the body and the insulin trying to get it into the cells. And so and to this day, she even stopped texting me. I said, no, text me every morning. In her mid-70s, she didn't feel comfortable. I said, well, if you're not comfortable, I want to know and help you with it. So just imagine, there are hundreds of thousands of people in this situation. I was looking up, there are thousands, there's so many people on insulin and on other medicines and pre-diabetes, even not on insulin yet. And we know the answer. Among many different answers, but it's one that's easy, replicable, got all the science behind it. All we need is to get the message out. And so to be a part of the ADS as a fundamental principle of getting the message out that type 2 diabetes is reversible, I can't think of a better cause, really. And so with patients that I see, there's nobody more gratified than getting off insulin. She was on insulin for 15 years.
Yeah.
She came off in one day. Now, of course, people will say, oh, is it sustainable and all that? Well, yeah. What's not understood is that she doesn't want to take insulin. And the trade-off of not having the muffin or the bagel in the morning is an easy trade-off. And so there's often sort of a false belief that, well, no one can sustain it and all that. If you've now fixed a medical condition that nobody else has been able to fix, that sure does make it sustainable. So anyway, I just wanted to bring in the history of the research and science, and but it's so old now. Someone told me recently, I'm doing my PhD. I want to use the work, and I sent the papers, and she said, no, the papers are cool. I can't use them in my PhD, which goes to the idea that this needs to be restudied and studied over and over and replicated, and yet I think the education and advocacy and just raising awareness can do so much benefit. And that's what I really like to see the American Diabetes Society do. And so anyway,
that's the goal, right? And that's the hope. I had I don't know if you get into some. I genuinely try to avoid what's a good way to put this on social media, back and forth disagreements, unless somebody's actually asking questions. But I feel like if we could just get everybody on the same page with some of these basic facts, being that, like you said, that type 2 diabetes is a disease where you're no longer tolerating carbohydrates, where your blood sugar is elevated, and that when we lower carbohydrates, we can reverse type 2 diabetes. If we could get doctors and dietitians on that page. And I'm very, I'm for personal sovereignty. If somebody wants to take insulin, if somebody wants to take medication, but my overwhelming clinical experience was that's not really even discussed. It's just throwing pills at you, kind of giving you this arbitrary, eat some oatmeal. Okay, see you later. Where it's like, hey, and I know even for mental health, like Dr. Chris Palmer and I were talking about this. He was saying it's just his dream that's something we talk about. Like, hey, before we put you on all this medication, let's talk about what a ketogenic diet can do for mental health. And so have you seen, and this isn't something that comes up, people say like, okay, I have a family member, I really want them to follow this low carbohydrate diet. Some of the pushback that I get sometimes, you talked about sustainability, which it's a very, in my opinion, sustainable way of eating. But a lot of people do say they struggle with carbohydrate addiction, sugar addiction. They're around it all the time. Can you speak a little bit about that, or how you talk to your patients about that?
Yeah, well, the more simple the system, the more sustainable it is. And so I found that now I'm teaching people on the internet who've learned internet keto, we call it, kind of as a loose term for all the various ways that people talk about it and do it. And when we teach our method, the simplicity of having one sheet of paper, of having, the idea that you use total, not net carbs, that it's okay to eat the same types of foods. It's okay to not eat a meal. It's okay not to have a macro calculation. It's okay not to use a calculator or an app. People think they learn keto and it's all these other bells and whistles that don't have to be a part of it. So the simplicity really helps with the sustainability. And I flip it over now. If it's the right kind of person, I'll just say, you did the diet, it worked, and then you fell off, and it didn't work. Well, no, it's really the foods that sucked you back into the addiction that took you off the diet that was working. And it takes a couple explanations of that for someone to really kind of get it, that, it's the addictive foods that took you away from what was working and sucked you back. You didn't fall off the diet. You didn't fall off the good food and good eating and you were feeling great. What happened is you got sucked back, just like a cigarette smoker. The first puff will lead to a pack a day. And so, we can backtrack, and one tool I use is, what was it that got you off track? And I'll use the language, what derailed you, or what's really, I'm saying, where was that first puff of the cigarette? And so we want to find out, avoid that place if it was the bar or what was the food, and find a substitution for it. It's fascinating how you can be addicted to sugar, meaning, Skittles. You can be addicted to and have an addictive relationship with bread that doesn't taste sweet, or potato or rice. So really, I have a picture on the wall with all those foods in one box, which makes it easier for me to explain. Well, these are really all the same thing. They get digested to sugar, and they hit the sugar addictive part in the brain, releases dopamine. And now some people, I don't even bring up addiction at first at all, even though they're crying out to me.
Even though they're saying, I can't stop eating cookies.
Like trying to, if someone's not ready, an alcoholic, you can't talk about alcoholism at first. If you're trying to develop rapport and work with someone over time. So that's kind of a judgment call, and a lot of people will sort of shy away from that. Oh, it's not like smoking. You don't have to smoke. And you can be addicted to food, the sugar, or certain triggers. So that's a lot of what I talk about these days. And as I start, and then as I treat someone who's relapsed back to the addictive foods, it's not common knowledge. And one of the things I do is I'll take 2 or 3 books with me in that's relevant to our discussion. And so I'll point out and say, and here's your reading.
Yeah, good for you. Yeah, I do think too, I love your idea of simplicity. Like I heard once at a lecture, and I think about this a lot, is that when somebody has, type 2 diabetes, they have obesity, they're in crisis. And when people are in crisis, nobody says, okay, I'm in crisis, challenge me. It's like, I need this like as simple as possible. I don't want massive, like the macros or whatever. And having a very simple, like, we're going to eat these things, we're going to avoid these things. I think that has been incredibly helpful. Dr. Mariella Glant does something very similar to what you have in your book. Yeah. And I found amazing. We've had such incredible success with patients who just literally stick with that, like, okay, I'm focusing on this. I'm avoiding this. And I've also found kind of describing, and like you said, it's kind of hard to, if it's your first time meeting somebody and they tell you like, I just can't stop eating rice and it's my culture. It's, it's hard to say like, but one thing I do often share with people, like, so are you aware that this is hurting you? This is causing your blood sugar to increase. This is increasing your risk of disease. Yes. And you cannot stop or will not stop. Well, yes. Okay. So it's kind of like, so to me that's what an addiction is, right? It's we continue a behavior that we know is detrimental to our health with the inability, and we'll put ourselves in that same situation. But unfortunately, gosh, sugar addiction is, or even carbohydrate consumption is so prevalent. I think it can be challenging for people, but like you, I imagine, like I've found the people that just really run with it. Like, I'm going to stick to this as religiously as possible, experience pretty incredible results relatively quickly. Yeah.
And the reminder for me, I'll bring it up, is that my story, two of my patients taught me about it. Mm. You don't need a doctor to change the food. Mm-hmm. Right. They read a book written by a doctor, Dr. Atkins, but he was just talking about food. And so I also try to, as quickly as possible, say, and I want to teach you so well, you don't need me. Mm-hmm. Often people want help. It's called the locus power of control, the health locus power, meaning spot of control. They think they're powerless, like the vulnerable situation. So I'll take over and say briefly, yes, I can help you. I know you have all these problems, but I've helped people with similar problems, and yet over time I'll kind of pass back the power and saying, oh, good job, you've done so well, because it's not me and it's not the drugs, right? I'm not using drugs, so getting that empowerment. It's easier if someone's reverse diabetes, I have to say, and the blood sugar CGM or even the finger sticks, it really show the improvements so quickly that that this particular case of diabetes is once someone gets it, is really pretty simple, which is just like we just need to tell people about this. Put on a CGM, watch the food, and I dream about the day when there will be that glucose watch,
because that's wild. Because when I was a kid, I remember, so like in high school, we had our heart rate monitors. You had this huge strap, and it was like a computer. And now I can get all my heart rate and everything from my watch. Right. And so the hope that you can just get your blood sugar, your blood glucose directly, and people will know. Because that is very powerful when people see in real time, like. Because people still, I'm sure when you first see patients, one of the biggest things we deal with is, oh, I just had fruit because fruit is healthy, or, oh, I had plantains.
I'll bring in, body language, like, what?
Yeah, it's like, oh, and often it's not, once again, this is not a judgment. It's people who can give really bad advice. They don't, or such arbitrary advice that they're, well, I'm eating the healthiest I can. I'm having oatmeal and a banana and, limiting my fat, and I'm taking my medicine and I'm getting worse. And so it's such a powerful thing. And I really appreciate that you said too, that it's like, I feel like you're giving people their power back. You're saying like, this is your choice. Well, you can literally reverse your disease.
Food. That's where the power is. In fact, that for a brief moment before the pandemic, Jeff Volek was on the other end of the building in Philadelphia at Fancy. So the big nutrition meeting. And I was on the other side. In fact, I didn't see him, but we were speaking about the same time. there were 1,000 dietitians in the room.
Oh, wow.
I don't know who set up that meeting. It was about the keto diet. And for a moment I thought, wow, we're making inroads with the American Diabetes Association. Now, the American Academy of Nutrition and Dietetics. But then we were never asked back. Or at least
they were like, ooh, our sponsors didn't really like that talk.
That could be it. Yeah, I remember going down to the vendor area and it was just, food after food after food. But, back to what you said about the definition of what diabetes is. I ask people this, and sometimes, especially those who are super smart, doctors and educated people, and they learn that, and they hear that type 2 diabetes is a problem of not enough insulin.
It's so weird.
And that is so wrong. I mean, type 1 is, yes. And yet, so I have to kind of erase that at the beginning. And he's saying, what did the doctor measure? Well, the blood. No. What in the blood did the doctor measure to diagnose diabetes? The A1C. Right. What does the A1C measure? Glucose. Yes, diabetes is elevated glucose. Of course, in the context of elevated insulin as well, but nobody measures that. So, but to have, I think it's a company ploy to get the belief that people, the food doesn't matter. It's just you're not having enough insulin.
Thus, we can inject you with insulin. And
right. So that I totally agree. There should be a, what is diabetes really? And what are I'll joke about we don't measure blood seed oil levels. Come on, we measure glucose. Yeah. So what's more important? Things we measure and we know, or things that might be a problem? So relative importance is the sugar. So yeah, the focusing on blood glucose, and then I just wanted to point out a paper that I wrote on the pathophysiology of diabetes, and talk a little bit about interacting with the paradigms that we interact with, because I wrote out how to calculate how much blood sugar is in the bloodstream typically, and I had to do like middle school math, right? The zeros cancel and you're left with 5, because the reviewer said this is too basic. Why are you putting this in an article, a scientific article? And I argued because people have lost this knowledge. So
the basic knowledge is gone.
5 grams of sugar. Well, the nuance is there's actually a lot of sugar in the blood cells. So you might add on a couple extra grams, but it's between 5 and 8 grams of glucose in the entire bloodstream at a given moment. So if you eat 20-gram apple, you're going to be doubling your blood glucose. It's not a surprise if you only have 5 glucose and you pour 10 or 20 grams into it. So I do a lot of teaching with diabetes about just how many grams of carbs you're eating, how much in the blood. For those who want to know, the simple version of just here's a handout, follow this food, that it works like a charm. I'll ask people to watch a video of me going over a handout. I'd say 80% do, not everyone does, but really the simple following the zero carb or very low carb foods, because it's carbs that are elevated, sugar, not type 2 diabetes is not a problem of not enough insulin. In fact, there's too much insulin. And then you get into the old, well, what is insulin resistance? Oh my gosh. So just remember, with a CGM or a blood glucose meter, you're in charge of lowering that blood glucose. And hopefully it'll be in a watch or who knows, an earring or
something very easy as someone could just. Can you speak a little bit more, because I think that's such a good point that maybe I don't even talk enough about, is just how little blood glucose we need in our bloodstream at any given time. And so it's like, oh, what happens if we drink a bottle of cola or even an apple, like you said, a banana, which is also the bane of my existence.
Well, so you have to imagine that there's a cylinder of blood. It's 5 liters for an adult. So imagine a child, it's even less. So much less sugar, much less. The blood sugar of a child is going to go up a lot higher given the same amount of carbohydrate that's ingested. because there's just much less blood there. So if you have 5 grams in this vat of blood, and now you're adding another 10, 20 grams of glucose, it's going to raise the concentration. And that's what we measure when we're measuring the blood glucose, the blood concentration of glucose. And even, doctors are so far removed from all of this, it's hard for me to even talk to other doctors about this. Because they don't really understand even what a milligram per deciliter is anymore. And it does go back to, middle school math. So anything, David Unwin in the UK, who I had a chance to meet with and see at the Public Health Collaboration of the UK. Hello to everyone in the UK. If you were at the meeting, say so. David, of course, made some infographics of teaspoons of sugar. So roughly a teaspoon of sugar is about the same amount of carbs in the blood. So if you're eating a teaspoon or 2 of sugar, you're going to be raising your blood sugar because you're pouring 10 grams of glucose into this system that only has 5 grams. And so you can download those graphics from the PHC UK, publichealthcollaboration.org. And it was great to see them. That group in the UK is just so vibrant and into even Dr. Cooper is now studying people who've been in ketosis for 3 to 5 years, young women, and looking at the whole system-wide blood screen. Everything looks great. So it's exciting to see. It's not just a therapeutic tool to get you somewhere. This really may turn out to be one of the healthiest lifestyles that you can live, even if you never had a health issue at all. So I came back from 2 meetings in Europe and was totally energized. That first one was in London. The second one was in Switzerland called Keto Live. The other exciting work doesn't have to do with diabetes so much, but it's with the cancer treatments. Finally, we're seeing Dr. Seyfried's work being translated into humans. And I've always been supportive of Dr. Tom Seyfried, but as he says, his patients are mice. And so that leap from mice to humans is a big one. Yeah. But finally, the research is being done and the final results aren't out, but Matt Phillips in New Zealand is doing work with glioblastomas, and he presented work there that was new to me to see. So anyway, the work on diabetes, as I mentioned, is so old it can't be mentioned in PhD theses, and it's so obvious when you think about the blood glucose and all, and yet it's obfuscated by the insulin resistance and there's not enough insulin. You need my medicine and all that. So if only we could get that word out, right?
Exactly. And it's interesting. We've got a question here we'll get to next. My sister is a surgeon, and so her and I get to talk quite a bit. But yeah, a few things she says, and I think I take for granted because I'm in this space. She's like, yeah, a lot of doctors still don't believe that type 2 diabetes is reversible. They do believe it's a chronic disease. And she was also saying when she sees patients in clinic, sometimes patients will tell her, oh yeah, my blood sugar is normal, but they're on like 100 units of insulin. So it's right. It's like if your blood pressure is crazy high, but you're taking massive amounts of it, it's like, no, it's not normal. So it's just
that's a great point. It's carefully clouded so that if you do have normal blood sugar control on all of these medicines, it's not like you don't get any complications.
Exactly.
Complications still occur. And so I wouldn't be upset if my general medicine and internal medicine colleagues were having people live long, healthy lives with, on insulin and eating tons of carbs, but that's not the case. And so when a recent patient called me back, no, it was his friend who said, you call Westman again, and hustled him over. He had lost his toe. So I treated him for years. He was doing great. He, got off track. Got sucked back into the carbs, and then got back into the insulin treatment, and his blood sugars were, relatively normal. And then he lost his toe under the endocrine care. So he comes back to me, tail between the legs, and I'm like, look, it's addiction. It's the food's fault. It's not you.
Yeah.
This is someone who is well educated and has all the money in the world.
Yeah.
And yet our healthcare system, and let me get on my bully pulpit just for a moment.
Yes, do it.
If you step back from when I was in training in the 80s and 90s, we've not improved the health generally of the American people.
Yeah.
And so the people in charge have failed. You would think that there would be at least, I was looking up a statistic about children. There's been an annual growth of diabetes in children of 5% per year.
Yeah.
So
that's terrifying to me, because that's, we're going to see huge repercussions of that in several decades.
Well, and so what I'm thinking now is, where are the pediatricians? Where, and we need to start roping pediatricians into the ADS just as soon as possible. And I remember a couple talks, Ken at Ken's conference, Dr. Barry's conference in Tennessee, we were talking about upstream medicine, meaning we don't want to wait till people get diabetes. We want to start helping people before they leap in the river of sugar and get traveled down here. And I mean, it sometimes, as Dr. Glantz said, it's a work project to get someone off the medicines. We want to get in and get involved and teach in advocacy before someone even, has pre-diabetes, and so the more, I know that it's the American Diabetes Society, but we're actually also talking about heart disease, because diabetes is really the main cause of heart disease and stroke. So we're talking about atherosclerosis and big picture view, shifting from worrying about cholesterol levels to worrying about insulin resistance and blood sugar and abdominal obesity and all these other things. So anyway, I'm not quite sure how to be on a bully pulpit. My old organizations don't want me coming saying, you guys suck, But I mean, as Ken's book, of course, The Lies. Is it The Lies My Doctor Tells Me?
My doctor told me, yeah.
I can't say that, being at a university and all that, but I can think it. And the medication care. In fact, someone came in recently and said, "Well, he has a doctor of medicine. A doctor of medication." A patient came in saying, "What, an MD? Oh yeah, a doctor of medication." That was brilliant.
That's kind of what it's become, and I think that's such a great point. It's, in my opinion, very statistically sad too. The United States has the most expensive healthcare in the developed world and the worst outcomes. And like you said, I've actually recently been, I would do some work with eating disorders, specifically women, and the eating disorder care. The statistics similar to type 2 diabetes are increasing exponentially. Like, it's getting worse than what it was, and treatment is the exact same. When I was 12, I'm 42. It's like, why are we doing the same thing that is not working and is keeping people sick? And you and I kind of know it's because it makes a lot of money for systems, but why are more people not advocating against this and standing up and saying, we can heal people. We can, we can do this. It's hard, but I guess, that's why we're doing what we do. That's why we need everybody in the comments to please make sure you're liking this, you're sharing this. If you're able to donate, there's a donate barcode. It means everything. So
I wanted to give just one story of, as you can kind of tell, my history, I've tried to stay within the change from within. And I really have, and I'm still in a university program, straddling the university and out there and the wild internet, and I'm doing the best I can. But some years ago, the American the other Diabetes Society, was coming up with a guideline panel, and one of my colleagues here at Duke was asked to be on the panel. And he told me, and I said, "Yeah, go do it. It'd be great." I had been on a few panels before with the VAs and study sections, and know that sometimes is a battle of egos in the room, you know. But I thought, yeah, go do that. Well, so 6 months later, I get a call basically saying, you know, Eric, they want to take out all of our data, all of our studies on the American Diabetes Association paper about diet and diabetes. And I said, you can't let them do that. I mean, so he had to stick up for his own data on the panel even, so that, you know, I'm starting to think, oh, well, they just don't know, and the organization, you know, is just busy doing it. No, there was active attempted suppression of data within the other American Diabetes organization, and that's just not, that has me, you know, at this point, yeah, people may have changed and all that, but you have to give science its due. And so before that, and I didn't know it was possible, a university professor at SUNY Downstate, Dr. Richard Feynman the other, said to me, you know, Eric, we're not getting good peer review. And I said, well, yeah, the journals basically say you can't publish that, you're going to kill people. Like, no, the paper's done. We already have the data. We didn't kill anyone, but they were worried about changing the word out there. And so Richard said, you know, let's start a new journal. And I'm like, you can do that? You know, like, you know, I'm a low-level professor and he's a senior professor. And so he said, yeah, people create new journals all the time because our articles and echo chambers get so focused that you can't get a fair peer review. So that's the Nutrition and Metabolism paper journal. Now the Journal of Metabolic Health is giving fair peer review, but a paradigm shift occurs, not because the older people learn the new way. It's the older people kind of fade away, and the new paradigm, like a cell phone, is able to do things that you couldn't do before. So with the modern knowledge that I lead with the Virta Health studies showing, look, you can reverse diabetes. It's, you know, almost automatic, and the data are there. You can't do that with medicine, and so that we're able to fix things that medications can't fix. And now, really, the ADS, our mission really is to educate and get through this suppressive bubble, if you will. And the grassroots movement is unbelievably effective, I have to say. That and it's really been our only effective tool, because the other, you know, pharma is going to want to make pharma more money, and so anyway, that's my story of how I lived through active, you know, being a, you know, fairly naive but fairly optimistic but naive researcher, saw active suppression that didn't occur because he stuck up for it and, you know, was going to threaten to make it go public. Of course, Lydia Bazzano went public about how the different food organization was suppressing and throwing out information, and you know, didn't really have any sort of meaningful effect that I saw. But so yeah, I'm not a conspiracy theorist, but I've seen this kind of suppression, and in a brilliant talk that Ken Berry gave at the fundraiser in Las Vegas earlier this year, new organizations don't, these days you don't just influence old organizations, you create a new one. Yeah. And you spring one up, and you can overpower pretty quickly if we all band together the other kind of noisy, because we'll be louder and effective, and people will follow the effective approach, I believe.
I believe it too, because I mean, I used to think when my last year in the clinic was 2020, I was like, there has to be a point where people say no more. And if anybody on this has a relative or themselves has had type 2 diabetes, it is not pretty. You know, I literally, as someone worked in acute care, we'd have people with massive infections that would lead to kidney failure. I had somebody go in for a routine debridement of an infection and they died. Like it's a horrible disease. And so it's like we have all these organizations like Dr. Westman was saying that are even, I mean, they're fighting to keep people sick. And so you're not going, in my opinion, you're not going to overthrow these multi-million-dollar. Just say, okay, screw you. We are going to educate people. We are going to help you heal. I shared earlier when I was on with Dr. Hampton, I've had two incredible patient stories. One guy, his A1C was 10. It went down to 5.4 in 71 days on a low carb diet. I know the gentleman was over 13.4. And it took 6 months, but we got back down to 5.4.
These are expected, these changes, you know?
Yeah.
So while that seems outlandish and uncommon, no, these are commonly seen.
Yeah, this is what it should be. Everybody that has type 2 diabetes that goes to their doctor, it should be like, yep, we're going to get you healed soon. Like, here's your food prescription. Here's your, and somebody did ask, I do want to, and thank you everyone that's saying super nice things. We really appreciate you guys. It does seem like some people don't struggle with carbohydrates as much as others. Some people maybe more tend to be a little bit more addicted to them. And I have my thoughts on that. I know for some people it's a huge coping mechanism, but are you able to speak to why maybe some people are able to give them up easier than maybe others?
Yeah, well, stress is the number one factor. So, you know, when someone says, oh, you know, I'm an emotional eater, I'm thinking to myself, yeah, we all are.
Yeah.
You know, but I don't say it, you know, I'm you know, you know, if someone comes in and says, you know, my A1C went from 12 to 5 and when I, you know, did carnivore or cut all the carbs out, I'm like, yeah, great. But that's what happens. So I think we all are victim to the emotional eating. And so those who are under stress, having to use the tools around them to cope, food is just so readily available. And I think that's probably the number one issue. I'm sure there's a list of, you know, how you were raised and was sugar used as a reward system for you. In some families that didn't happen. I didn't know that. You know, once I sat at a meeting of hundreds of people and I even stole money from my mom's purse to go buy those candy apples, you know, and everyone looked at me like, you're a thief. I didn't say that again, but you know, that's what addiction does. You'll steal and try to get it. But other, you know, I fight medications commonly so that doctors unwittingly are part of the problem in terms of medications they prescribe. But I think it's the coping, emotional eating, stress.
Yeah, it is interesting to see too that when people, and it can be that positive or that negative snowball going, meaning like if you're able to reduce the carbohydrates for a while, you know, sometimes there's that period that's really hard initially, but then you start to feel better. Then you start to have more energy. Well, now I want to keep doing this. And now my life is a little better. But you know, unfortunately you can see the reverse. It's like, oh, I'm super stressed. So I ate this thing. Now I'm more inflamed. So now I'm extra stressed. So now I'm eating this thing. And so it's like, can we cut that in its tracks? And I always tell people to I need you to stay with me. Give me 30 days. Like, and most people that seems pretty doable. If not even just 2 weeks, let's really lock in. Because, you know, that first 5 to 7 days, I know if I could redo my initial start, I didn't know about electrolytes. I was new. I wasn't as smart. I didn't do salt. I had like the world's worst headache. I almost quit that day, but sticking it out. And I mean, I was eating, you know, 400 grams of carbs a day, going from 400 to 0, miserable for a few days, but then like massive shift. And so once you get that massive shift and you experience it, it's almost like your eyes kind of become open. You look around and you see like, gosh, the whole world is inflamed. The whole world is eating so much junk. Like we have to get this information out that healing, like the human body and brain, you're supposed to be like high level. You're supposed to be lean and physically healthy. And it's interesting that, you know, sometimes even that is a suggestion, you know, just saying like, hey, I think that I made the statement, I think if you're a dietitian, you should be metabolically healthy. And I got like destroyed on social media. Oh my gosh, how dare you? How dare you see? We could go on a tangent on that. But anyway, I know I really appreciate like all your thoughts and your work. And, you know, I'm obviously a huge fan. That was still the paper from 2015, although I love the 2008 one too. But the other one is my favorite.
we got to keep them published. Keep
I know,
publishing
because you
it,
have people
but,
with their PhDs that need to use them.
yeah. Well, and Ken, thank you, Ken, for the work you've done so far with the ADS. Really great progress, and I hope this will help. You know, there's so many people that just need to know, right? Just have the alternative choice as a choice. So, well, anyway, have we overstayed our welcome?
No, not at all. I just wanted to join the conversation. Excellent conversation, excellent education here. I just got an update. During this live stream, we have raised $6,605
Amazing.
so far up to this point. And let me reiterate to everybody watching, none of the people you've seen on this live stream are getting paid a penny to be here today. We're all doing this out of our sense of professional sacrifice, because many of us, including Dr. Westman, early in our medical or practice career, we gave bad nutrition advice. We didn't know any better, and we would tell you dumb things like eat more whole grain bread and drink lots of fruit juices and fruit juice smoothies, because we didn't know better back then. And so part of the reason we're all doing this is because we're trying to atone for sins in our past. But I think the bigger goal, like Dr. Westman stated earlier, is that we're never going to be able to overtake the current leading diabetes association or dismantle them. And we don't want to dismantle them. You never want to burn something down without having, here's an alternative that actually works better. And so that's what the American Diabetes Society is an alternative. If what you've been trying with the other associations not helping you, if your A1C is actually going up, like mine did when I tried their diet, then you need to try another pathway. And this is that pathway. Thanks to our great registered dietitians, Michelle Hearn's on the board of directors, and we have several other dietitians working with us as well. We have over 100 recipes on the American Diabetes Society website. And when you cook and eat these recipes, your diabetes actually improves, unlike recipes.
No high sugar, high carb.
That's right.
You know, some of the recipes have 45 grams of carbs on the.
Yes. Some of the on the other association's website, you will spike your blood sugar if you make and eat their recipes. Also, our recipes, which is something I asked for from day one, is to have reasonable serving sizes, because if you make a 2-ounce something and then a serving size is, you cut that into 12 pieces and you have 1/12, 2/12 of an ounce, that's your serving size. In what world is any adult going to make that, a 1/10 of an ounce of serving size? Nobody. Everybody's going to eat 6 pieces of that. So then basically what you thought was your carb intake is not what your carb intake was at all. So all of the recipes on the American Diabetes Society website are free, and they have reasonable portion sizes that an actual human might eat and be happy with. And they're so rich in protein and fat, I think you'll be very happy with the serving sizes, because you're going to stay full for a long, long time. Also, we have meal plans available that you can download and print out from several different dietary genres, from vegetarian to Mediterranean to carnivore. You get to kind of choose the style that you want to go with. And as always, every time I talk with Dr. Westman, I want to thank him for the pioneering, maverick work that he did early in the low carb space, way before it was cool. Kind of like, I think it was Barbara Mandrell, that she was country, but when country wasn't cool. Well, Dr. Westman was low carb and keto when they definitely were not cool at all. Frowned upon very severely by people with gray beards and long white coats back then. More and more we're seeing, especially young doctors and dietitians, come on board and say, yeah, this makes a lot of sense. If diabetes is a disease of high blood sugar, then anything you eat that raises your blood sugar is probably bad for somebody with diabetes to eat, right, Dr. Westman?
Exactly.
Like, duh. And so I think that he also is exactly right, that you're not going to change the opinion of the gray beards. It's very rare when you find a gray beard that you can talk rational, logical sense to them and them go, Oh, I see your point, young whippersnapper. You're right. I'm going to change everything that I've said and published over the last 40 years. That's never going to happen. We have to wait for them to either retire or to retire. And so this next generation of medical students, of medical residents, and young practicing physicians, and students in dietitian schools and newly minted registered dietitians, that's who's going to pick up the torch and who's going to lead this. And I hope that the American Diabetes Society plays a huge role in that and provides an alternative home for people where the other diabetes associations' recommendations just didn't work for you, didn't help you. Your diabetes got worse. You didn't lose weight. And so that's what the American Diabetes Society is. And any parting words, guys, before we wrap this 5-hour fundraising marathon up?
Yeah, well, I just want to say thank you again, Dr. Berry, for everything you're doing. And obviously, Dr. Westman, thank you for being here. And just encouraging everybody to please, subscribe, like, share, because I'm always amazed. Like Dr. Berry says, millions of people just don't know this information. So,
yeah, just to add, the power is in the food. Mm-hmm. The power is in nutrition, and doctors have had that erased from education for our generation. And so the grassroots movement is so powerful, and you can be involved. We can all be involved and make this change. In my more optimistic moments, things have changed a lot, mm-hmm. and keto products, while I don't think they're great for keto diets that are prescription strength, that movement in that direction is a good one. And it's never fast enough, but that's why I'm here and involved. And I hope everyone gets to be a part of this, because it's going
to. Totally agree. And I think that, where did that comment go? Yes, here it is right here. Two great pioneers who have now gone to heaven, Dr. Richard Bernstein and Dr. Sarah Hallberg, both now watching down from heaven as the American Diabetes Society grows and blossoms. And I think they'd both be appreciative of what we're doing here. And I think they would both approve. Thank you both. Thank all the experts for hanging out with us today and helping raise $6,505 as of the last count. It's not too late to hit the donate link right now or scan the QR code. You can give $1, $5, $10, $500 if you got it. Whatever you're comfortable giving, please donate to the American Diabetes Society so that we can teach every person with diabetes all around the world that they can have a normal A1C and that they deserve to have a normal A1C. Thanks, everybody, for joining us. Click the share button right now, even though we're wrapping up, because anybody can watch this on the replay for free, and then check out all the recipes and the diet plans at the AmericanDiabetesSociety.org. There's a link in the show notes. Thank you, guys.
Thank
See you later.
Bye-bye.